उसने काफी वेट रिड्यूस किया यार। ये मेदांता इफेक्ट है या जिम इफेक्ट है? करने वाले एक माइक नीचे ले जाओ।
Hi, Chitesh. Hello, Chitesh. Good
Sir,
morning. Good morning.
कैसे हो?
मैं बड़े
All
9 बजे
set?
शुरू कर दो. ऑल वेल. तुम्हारी कॉन्फ्रेंस अच्छी चल रही है. हेलो. आवाज नहीं आ रही. Chitesh, हाँ.
सर आवाज आ रही है?
हाँ, अब आ रही है.
हाँ तो सर मैं पहले ऊपर आऊंगा.
ठीक
मैं
है.
आऊंगा, मैं इंट्रोड्यूस करूंगा सूद सर को. तो सूद
ठीक
सर
है.
कम्स ऑन डायस. आपको सूरज करेगा सीबी के साथ. देन यू विल
क्या
जॉइन अस.
करेगा?
उसके बाद सूद सर जो है वो पहले 2 सेशन जो है विनीत के और पंकज के वो
ठीक है.
कंडक्ट कराएंगे सर. उसके जो
Okay.
बाद के जो 2 सेशन है रमेश बाबू के और संजय पांडे के वो आप कराओगे. ठीक है.
हाँ, ठीक है. आई एम ऑनलाइन.
राइट ओके.
कितनी देर में शुरू कर रहा हूँ?
सर अनदर 5 minutes.
ठीक है. ओके.
And we are live right now actually.
या.
Good morning, everybody. So we start our day 2. The first session is on urology, and the moderators are me and Dr. Suraj. Dr. Suraj, you're online?
Yes, sir. Good morning, sir. How are you, sir? Good morning.
Perfect, Suraj. So we'll start. So I would like to invite the first chairperson for today morning session. That is Dr. Rajiv Sood. Sir, please come on dais. Dr. Rajiv Sood is the founder, Dean, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. He is Chair Academics, Department of Urology and Renal Transplants ABVIMS, and Dr. RML Hospital, Consultant Urologist, Parliament of India, both Lok Sabha and Rajya Sabha, Chairman, Indian School of Urology, Governing Council Member, Delhi Medical Council, Board of Directors and National Society Delegate, Chairperson, IMA Standing Committee, Central Service, Doctors and Allied Organization, Chairman, Monitoring and Guided Committee for CBET and R&D, Co-Chair, IMA Standing Committee for Men's Health, Co-Chair, IMA Standing Committee for Initiative of Sexual Health. Dr. Suraj, you can invite the second chairperson, Dr. Anil Goyal.
It would be my honor. Dr. Anil Goyal, he has done his MCH Urology and DNB Urology. He is currently practicing as a senior consultant urologist. He's also a finance secretary for the Indian Medical Association. He's a president for the Men's Health Society of Delhi. He has been a member from the Delhi Medical Councils from 2009 to 2019. He has been a president for North Zone Urological Society of India from 2016 to 2017. Also served as president for Delhi Medical Association from 2014 to 2015. He's a member of SIU. He's very interested in endourology, female urology, pediatric urology, and androurology. He has been an organizer for various conferences, and he has done a lot for the urological societies. Thank you, sir.
Good morning, everybody. And with this, we start our scientific deliberations of second day of this IMA Kidneycon 2022. And to start with, our speaker is going to be Dr. Vineet Gohar, who will be talking on lower urinary tract symptoms and prostate enlargement. Dr. Vineet Gohar is affiliated to as principal resident physician NT-FGH, clinical and resident faculty assistant in NUH, and clinical lecturer also in NUH. He is awarded with the Service Quality Award in 2010 and 2013, 5-year Outstanding Service Award in 2014, and also 10-year Long Service Award in 2019. His interests are in research field, genitourinary tuberculosis, EPN, upper tract urinary cancer, minimal invasive surgery for stone and RCC, and ergonomics in endourology. He had several academic achievements, and which include more than 50 peer-reviewed publications, 200 presentations globally, core member of Eurosomi, iTrue, IRAP, ULOT, FB, SIU, J, Social Media Committee. He is Associate Director and Program Coordinator Fellowship Training in NUHSL, and also Director Peer-to-Peer Training Program, overseas visiting academic consultant in INU, India. So I'll request now Dr. Vineet Gohar to start the deliberations on lower urinary tract symptoms and prostate enlargement. Dr. Vineet Gohar, please.
First of all, let me thank the organizers, especially. Okay. I'm just trying to play my slide, but it seems to be, we just tested it, it was working well, but I can't seem to play it from now.
So we can see your slide. If you can just put them on full screen.
Yeah, I'm trying to do that. So every time I do that, it seems to be going out of focus.
Okay. Do you want to unshare and share again? If you can stop share once. Okay,
I can try that. So while we do this, I'm very grateful to the IMA, especially for organizing this. And thank you, Dr. Bali. Thank you for the very kind introduction by Dr. Rajiv and all the IMA panelists. So this is an absolute honor for me to be participating in the conference. I'm going to try again. Okay, hopefully it's working now.
Yes, sir, it's perfect. You can go ahead.
Thank you. So my topic that's been allocated to me is low unit tract symptoms and prostate enlargement. A very, very, very grateful thanks to the president of IMA, to the chief patrons of IMA, Dr. Singh, Dr. Desai, and also to all the esteemed panelists, Dr. Jayesh, and of course, he was my senior, but also a very close friend, Dr. Kshitij Bali. I think I owe you a very big thanks for giving me the opportunity. So I have nothing to disclose. We are here to discuss benign prostatic hyperplasia and low urinary tract. When we talk about prostate enlargement, it's synonymous with benign prostatic enlargement, which is different from a malignant prostate. What's important to understand is that the low urinary tract and the upper tract, they have a very sensitive relationship. And maintaining the homeostasis is integral for voiding. So what that means is anything that affects the upper tract may affect the lower tract and vice versa for sure. So the terminologies that we need to be associated with when we talk about prostate is first is BPE, which is nothing but a benign prostatic enlargement. We know this is a physiological. All of us men are bound to have this. And after 40 years, we all will experience some form of an enlarged prostate. It usually increases with age, and definitely it's increasing more with 60, about 60 years of age. Now, BPH is a histopathological diagnosis, which is where you actually have a diagnosis of a hypertrophied prostate. And the low urinary tract symptoms, it's a very broad terminology used in urology, but it's very commonly associated also with the prostate, and that's where we're going to focus today. What's important to understand with the prostate is when the prostate grows, it usually grows from the transitional zone because a prostate has a central zone, a peripheral zone, and a transitional zone. And the transitional zone is just surrounding the urethra. And due to various effects, which are basically the response of the hormone, which is testosterone and dihydrotestosterone, it causes enlargement of the prostate from the middle and then goes out. So typically, if something is going to be pressing on the urethra, it's not going to allow you to pass urine. And that's what leads to low urinary tract symptoms. But everything that is low urinary tract symptoms is not because of the prostate. While BPH is important, we should look at every single anatomical aspect. It could be a simple meatal stenosis, it could be a stricture, many drugs, and of course the bladder activity, nocturnal voiding, which is otherwise nocturia, neurogenic problems, UTIs, and of course foreign bodies in the bladder and tumors. So urologist's role is cut out when a patient comes to you with low urinary tract symptoms. What he is trying to establish is this a problem which is bothersome due to an outlet obstruction, which is called BOO, which is basically this part of the bladder is blocked. And is that because of BPE, which is a prostatic problem? So that we'll look at how a urologist's perspective, how we look at how to evaluate this. And believe me, this problem is getting tripled. And as we live longer with lifestyles improving, there will be a real massive population which will demand treatment, and it's going to triple in the next 3 decades. Now, obviously, when we have such a big population, we cannot be doing surgeries and medical treatment. So we have a wide option to treat, and we'll discuss a few of those management options once we diagnose the problem. So what we have been typically taught as urologists is the Hall's ring, which is you have an enlarged prostate, you have low urinary tract symptoms, and it's causing bladder outlet obstruction. You need to manage all these 3 components. What I like to look at it as now as the rings of change, where a urologist also must consider he has a spectrum of prostate disorders. He is dealing with an age group from 40 to 100. Very often, people who are 90, 95 still want their prostate sorted out. It doesn't mean that they don't have a prostate problem, which you can just put a catheter and leave them alone. And they are definitely asking you for all the treatment choices. A very intelligent patient population comes to us for these options. So I think the time has changed and we also have to improve. But what's not changed is low urinary tract symptoms, how we classify them. When it comes to the prostate, we have 2 main streams. One is obstructive and one is irritative. Obstructive means you can't pass urine, which is voiding. That's where a patient will come and tell you, I have a weak stream, I have hesitancy, that means it takes time to start passing urine. Incomplete voiding, where I pass urine, there's still some urine inside. In between, it stops, which is intermittency. And of course, it takes a long time to pass urine. Now, filling or irritative means the bladder is being affected by the outlet problem, which is basically frequency. They need to pass urine very often. Nocturia, a very big problem, which is waking up at night to pass urine. And urgency, that means you can't control the urine. And of course, sometimes it can leak, which is incontinent. So when we look at these, we classify them as storage symptoms, we classify them as voiding symptoms, and then post-micturition symptoms, which is basically a sensation of incomplete voiding and tribble. And it's important to understand that LUTS is not specific to BPH. And again, you have to rule out all of the problems before you say he has got a prostate problem. And also, every patient does not come with every single symptom. You see, he may come with a mixed variety of symptoms. The most common usually is where they have a bit of difficulty in passing urine, as well as where they have a mixture of irritative symptoms and voiding symptoms. But what we have to do is we have to assess these LUTs. So for us, we usually rely on what is called as the IPSS. We'll talk about it, which is an International Prostate Symptom Score. Clinically, we still rely on a digital rectal examination, a prostate-specific antigen test. We have to check the upper tract. I told you what affects the lower tract affects the upper tract. Because when the bladder is obstructed, there is a pressure inside the bladder which goes on increasing. It causes a black flow, a reflux. And unfortunately, then the kidneys also get affected. And several times the kidneys can absolutely blow out. So of course, we rely on an ultrasound. If you have that in your clinic, that's excellent, or you can always ask for one. A uroflow is something a little more we'll show, where we talk about how he's actually avoiding. This is very useful to the urologist as well as to show the patient you're having a difficult time passing urine, or these are the problems that you need to sort out. Cystoscopy is optional. Cystoscopy is when you suspect there is an issue. So what we do is then we take a camera through the urethra, we go inside, and we actually visualize. I find cystoscopy in today's practice useful because you're able to show the patient what is happening inside. When he sees that, oh, my prostate is big, he sees that the bladder has gone through changes, he then understands that, yes, this treatment is necessary. So for surgical counseling, I find it to be useful, but it's not compulsory. We do sometimes rely on urodynamics or pressure flow studies. Again, these are more to rule out other problems than to establish a diagnosis of a prostate enlargement per se. With that, this is a typical chart which we have in the clinic, the IPSS. It is your best tool after your digital rectal examination. In a digital rectal examination, you suspect the prostate has become big, and then you ask him to fill up this questionnaire. It's available in more than 100 languages all over the world. So patients can fill it up, and then they give you a score. Now, when he's got mild symptoms, or you can try medical management. But this is very important, not only for initial assessment, but also on follow-up of a person who you start on medical management. And it's extremely important to have this when you want to assess his quality of life, as well as your quality of surgery. How have you actually managed the patient? So somebody who comes to you with a symptom of 20 to 35 initially, and he's come down to a symptom of 0 to 7, he is improving, and so have you done a very good job. So it's very important for us, this particular test. And what a friend of mine has also been introducing this, where he's trying to get an objective assessment with a visual score. So he tells the patient, okay, look at this chart and fill up. So this is what we call as a visual prostate symptom score. It hasn't been validated in many places because it was quite new, but we've tried it, and I think it's quite interesting. The patients, when they're waiting in the clinic, sometimes they find it quite interesting to fill this questionnaire. And I think with time, we'll know whether this can be a good adjunct to IPSS. So we made a diagnostic assessment and said this low urinary tract symptom is due to a benign prostatic hyperplasia. So what I also need to keep at the back of my mind is everything is not BPH. I've been saying that. So what exactly am I looking at? I need to make sure I'm ruling out a prostate cancer, very important. Also infections and neurological causes, medical problems, iatrogenic. I think the list is ever-ending. So once I know it's BPH is when I can treat the BPH. What I do rely on, well, I told you, is I need to measure the uroflow. Now, if you look at this curve over here, when the patient is asked to pass urine, he passes it in a machine, and the machine shows that he's able to pass urine well immediately, and it comes down. However, here you can see that he's actually taking time, he's forcing, and he's straining himself to pass urine. I also look at the prostate. You can measure the volume. It's very easy in the clinic. But what we also look at, what we call as the intraprostatic protrusion. That means the prostate is growing into the bladder. This is a very challenging part because usually when this happens, often medical management doesn't work and surgical treatment is needed. Apart from that, most patients will remember you when you've done a digital rectal examination, so please be gentle. And when you do that, you also need to assess the PSA. Now, a PSA is the most, unfortunately, it's still the go-to test, but it's very unreliable test to measure for prostate. But what it does help us is when you do treatment and you find that the PSA has come back to baseline, or you find that the PSA, for example, when you remove the prostate and the PSA levels have come down to negligible, then you're confident that your treatment is doing well. What it also does is gives you a clue whether there's any signs of malignancy. So something which is still important. Every patient must have his baseline kidney function to be assessed. If you don't do that, you can actually be liable medical legally. And of course, you'll be unhappy that you have missed out a problem which is happening in the upper tract and focusing only on the lower tract. So these are the basic tests that we do. They're very simple, very easy to do. And once you have that, we follow this sort of algorithm where we look at all these tests and we decide, okay, this patient has very mild symptoms, so maybe I can just observe or I can try to give him some medical treatment. If I find that the patient is a bit more bothersome, then I may even consider doing other treatments. Important here is that there are certain times you have to do a surgery. And those are what we call as absolute indications, where the patient is constantly having hematuria. He's having stones in the bladder. He's having many recurrent UTIs which are persisting. And also if he's developing a renal insufficiency. And those are absolute times you have to explain to the patient, you need a surgery, and surgery will only benefit you. So what we rely on are these called as predictors. So you diagnosed it, but you also need to know, when do you intervene? When do I step up the intervention? So usually people who are growing older, patients whose prostates are growing bigger or who have a larger size prostate, whose PSAs for their age are slightly higher, whose IBSS is worsening. The Qmax, which is a Euroflow, which we look at, the maximum speed avoiding is coming down. And we find that the amount of urine, which is residual volume of urine, is increasing. So there are dynamic characteristics. And then, of course, like I mentioned to you, there are complications. All these are indications where the BPH treatment has to be stepped up. What we are trying to say that is, the pathophysiology is different for different ages. Everything is different. The size of the prostate, the IPSS, the symptoms, the risk of developing a urinary retention, as well as sexual history, a very important component today. So treatment has to be different for different age groups, because the prostate also has receptors. It has a dynamic component, which is how he's passing urine. It has a static component, which the receptors are acting on. And then, of course, the shape of the prostate, like I told you. So a urologist must consider all these 3 points. And obviously, one treatment cannot fit all. So it's very simple to manage a prostate problem. You go to the Department of Urology. His doctor is going to tell you medical treatment, surgical treatment. But medical treatment is not that easy either, because we have so many medications to choose. These medications are basically acting at different receptors in the bladders. The most common ones which we use are basically alpha-1 adrenergic receptors, which is your typical tamsulosin, alfuzosin. What these do is it helps to relax the prostate, helps to relax the urethra, helps to relax the sphincter so that the urine
Can we
comes.
wind up?
Yep. Basically what we learned from the past is that medical management is not good. And we follow the treatments. And I think a PSA for everyone, what I say is a prostate is unique. So every prostate has to be managed. We have all these treatment options, which are basically remove the prostate, medically manage. We have to consider minimally invasive to more invasive treatments. So today we have plenty of treatment options, just reflecting, which is either resect the prostate, or you are able to even vaporize the prostate, or you can use a laser to remove the prostate. So a surgeon must know how to handle all these 3. And today we also have many other options, which are called as minimally invasive, where your patient doesn't want surgery, so you can put what we call as stents. These are various devices, which we use all of them. And of course, today we have something called as steam therapy, where patients who are sexually active, we put the hot water into the prostate, and then by apoptosis, the prostate dissolves. And lastly, we have guidelines to give you based on the size of the prostate, as well as on the various options. So we have a whole galaxy, and it takes vision to transform your patient's BPH journey. Thank you for that.
Thank you, Dr. Vineet, for this deliberation on lower urinary tract symptoms and where prostate is the major cause. And we know that in rural India, Today also, it is the major cause of obstructive uropathy and kidney failures. So it is not a small problem. We will discuss further when the questions are taken up after all the sessions. Before now, as the second speaker, for very important topic, we are living in the stone belt. In Delhi also, and in India, in the northern India, it runs from here to up to even Pakistan. And this stone belt is one of the stone belts in the world, and where we are living. And Dr. Pankaj Wadhwa, Director Endourology in the Medanta Institute of Urology and Robotic Surgery at Gurgaon, is with us, and he will be deliberating on how to manage kidney stones. Now, something about Dr. Wadhwa. Dr. Wadhwa completed his training in urology in 2003 from PGIA MER Chandigarh, following which he worked as the senior research associate at All India Institute of Medical Sciences at New Delhi, and also received initial training in robotic surgery at Roswell Park Cancer Institute Fellow in New York, and he specializes in advanced endourology, laparoscopic and robotics urology, treating urolithiasis, BPH, and uro-oncology. And it will not be completed without mentioning that our stalwart and most decorated teacher at All India Institute, Professor S.N. Wadhwa, is father of Pankaj Wadhwa. So with this introduction, I call upon Dr. Pankaj Wadhwa to start the scientific deliberations on this topic.
Right. Thank you very much, sir, for that wonderful. Maybe I'm not sure how much of it is actually. I hope I have done enough to actually get all that accolades. But I'd like to thank the IMA for this opportunity, and the organizing committee for considering me for this. Thank you very much. I'll just share my slides. Right. So I'll be talking about management of kidney stones. And we live in the northern Indian stone belt. But more than that, okay, sorry. So this is the prevalence of stone disease across the world, and we've got 9 to 10% prevalence in our country, which is very high. And it's increasing. There's no doubt about that. I've borrowed this slide from a very old presentation, but this was fairly accurate in 1971. It is still accurate in 2022. Maybe the spectrum has further exploded, but it's still, stone disease is still a very significant portion of what we deal with in most urological institutes. And unfortunately, a recurrent stone disease will contribute to 20% of such patients will actually develop renal failure. So it's important that when we're actually treating them, we look at the risk factors and try and identify them so that we can actually prevent it. So it's not just about treating the stone per se. So the non-dietary risk factors are age. So it's unfortunately, it afflicts people in their prime. The males are more afflicted than females, although that distinction is reducing because of dietary changes. Geographically, we see a lot more stone in the stone belt right across the north, central, and northeast part of India. But it's the south is quickly picking up, although they get smaller stones, but they have enough stone burden now. That's because of changing diet patterns, which have become more cohesive almost across the entire country. Family history is extremely important, and therefore the role of genetics. Medication overusage of steroids, furosemide, overdosing with vitamin D, unfortunately, are contributing factors. Anatomic variations like UPJ obstruction, medullary sponge kidney disease will, of course, predispose the patient. There's a lot of systemic conditions like malabsorptive syndromes for the gut, hyperparathyroidism, obesity, gout, and all of these will actually exacerbate the stone condition. Amongst the dietary risk factors, increased intake of oxalate, animal protein, sodium, sucrose, fructose, non-dietary calcium supplements, and that's a big problem. And vitamin C will add to the problem. Surprisingly, adequate dietary calcium is actually a preventive factor. So how do we evaluate these patients? We do a standard hematological profile, which will include CBC, more importantly, the kidney function test, including the uric acid, calcium, and phosphorus. We need to look at their bleeding clotting profiles. A urine examination is still extremely important, tells us about the pH, the kind of fluid drinking habits by the specific gravity, whether there are any crystals already, whether there's any infection. A standard urological radiological investigation is the ultrasound, which will pick up most problems to start with. Would get followed up with a non-contrast CT in an acute condition when a patient is having actual pain, and more likely a functional evaluation in terms of an IVP, but more commonly a CT urography wherever is available. Occasionally, even a DTPA scan in case the renal function is already compromised. Special set of investigations, 24-hour urine metabolic evaluation, quantitative cysteine, which is rare, but we do see it once in a while, and a stone analysis wherever possible. So who really needs this entire metabolic workup? Anybody who's got bilateral stone disease or a stone in a solitary kidney, those who come more than once, younger patients, those who have an obvious family history, those who have associated diseases like bone, osteoporosis, hyperparathyroidism, malabsorptive syndromes, gout, renal insufficiency, those who already have a documented cysteine uric acid or true white stone and calcium phosphate stones. So amongst these, it's absorptive hypercalciuria, hypositraturia, gout, and low urine output, which will actually contribute physiologically. So who needs a surgical treatment? In an emergent condition, you need to decompress this obstructed system, which would be due to the stones and UTI. Those who have bilateral stones with an AKI or acute kidney injury already occurring, on those with a single stone with the same problem. A more elective approach, of course, for somebody who's got symptomatic stones, who got persistent obstruction because of the stones, and those who have recurrent UTI because of the stones. So this is a bit of a busy kind of a slide, but the management strategy effectively depends upon the stone factors, how big is it, what is it made up of, what is its location, renal factors regarding that particular renal unit, the anatomy, there could be natural variations, there could be an ectopic kidney, there could be some kind of anomalies, including obstruction like a UPJ obstruction. The actual renal function is extremely important. Then of course the patient, this is patient-centric. So is the patient already in renal failure? Do they have COPD? Do they have a bleeding diathesis? Are they on medication for antiplatelets? Are they obese? And the occupation. So our approach would be totally different for a pilot versus, say, the general population for a small stone. So that's stone location. It could be partial staghorn in the pelvis or associated in the one of the calyces. So what's important is to be versatile, to have all the armamentarium which we currently have, and this is what we have. So conventional open surgery, very minimally used now, but it's not out in the bin. We still need to resort to it occasionally. Lithotripsy was very much in vogue for the last 2-3 decades. Still is there, of course, but the usage has dropped down because it's not as efficacious. Endoscopic rules the roost. There's PCNL and RIRS, and I'll be alluding to that. And occasionally we use laparoscopy and even robotic-assisted laparoscopy. So minimally invasive approach because it allows using multimodality. There's minimal access, so cosmesis is important. Lesser postoperative pain. Patient gets back home faster back to work. Lesser wound complications, especially in the obese patient. And importantly, it's a recurrent disease. These patients will come back. So another busy slide, but effectively, depending upon where the stone is, how big it is what we offer the patient. So lithotripsy is office procedure, relatively non-invasive. It involves hitting the stone with shock waves, which are acoustic shock waves, and then you break the stone and hope for it to come out. And when I say hope for it, is exactly why it's not so much in use these days, because the efficacy is only about 80% for up to a 10 millimeter stone. And there are some obvious contraindications like an infection, pregnancy, an obstructed system, uncorrected coagulation defects. Relative contraindications, somebody who's heavy, cannot lie down straight, and therefore the focusing of that stone is going to be difficult. Patients on pacemakers, which is so much more commoner these days. Uncontrolled hypertension is an absolute no, in my opinion. So comes to the main workhorse of what we do for stones, for larger stones and branch stones, is PCNL, which involves us making a hole into the kidney, accessing the system, breaking the stone and taking it out. Now, this is usually done in the patient lying prone, but newer techniques, and that's what's changed in the last 10 years, is you do supine PCNL or a modified, so the positioning is easier on the patient. So this is just an example of an obese lady with renal insufficiency with a large stone, and so a single small incision, and gets back home in 2 days. Well, this is a more challenging case with this kidney full of stones, and it's a complex anatomy, and those are the number of holes that I need to make over 2 sessions to actually clear this kidney out. So new kid on the block, not really new kid. It's been there for a while, but now the scopes are leaner, meaner, narrower, more flexible. We've got lasers to fragment these stones, which are stronger, more efficient. So yeah, it's the way forward for treating stones in a less invasive fashion. So this involves going to the natural urine orifice right up into the kidney. So this is an example of somebody who's got a misplaced or ectopic kidney with the stone in the inferior portion. So if you notice, it's difficult to get there. So you go with this flexible scope and you can actually turn and relocate this stone. And that's, if you see the video, you see how the technology has made the vision so fantastically clear. You can see the capillaries, and the magnification is wonderful. The reach of the scope is so much more better. And you can go into various portions of the kidney most of the time. Sorry, let's go back to that. Yes, and so that's the stone which is in a difficult location, and we would use instrumentation like a basket to kind of pick it up and put it into a more favorable location for us to work with. And then, so that's picking it up and putting it in a more straighter zone, if you please, to break it with a laser. So that's the laser at work, and you make it into fine dust, very small fragments, so which will pass out on their own. And one could, that's what one would achieve, make it into smaller fragments, and then end result is just very fine dust. And this is a very magnified vision. This is less than 1 millimeter. And even so, we would still pick out a few fragments for stone analysis and a better clearance rate. And that's what's possible with technology. There's still some role of laparoscopy in stone disease. We do it much less commonly than it's less commonly required thanks to this wonderful RIRS technology. And occasionally we even have to do a nephrectomy laparoscopically for stone disease, which is extremely sad because people just have ignored their stones for so long. This is another case where there's ectopic kidney and it's malpositioned, and therefore we ended up doing a laparoscopic for this, and that's the end result, a couple of holes, and patient still goes back home pretty fast. One can do a robotic pyelothotomy. It's wonderful for the surgeon. It is, however, more expensive, less commonly used. So there is a definitive role of medical dissolution therapy for stones, but is limited to asymptomatic pure uric acid calicial calculi. So one can use allopurinol and alkalize the urine to actually take care of these stones. The contraindication, of course, is that it should not be obstructed. There should be no fever, UTI. It should not be the solitary kidney. There should not be many anatomical variations. And one has to fix an endpoint.
Dr. Pankaj, can we?
Yeah, I'm just finishing. And directed medical management, depending on what we found. So somebody's got a hypercalciuria, you treat that specifically. You've got hyperuricuricia, treat that specifically. Cysteine is a tough thing to treat. More importantly, adequate fluid intake, treat UTIs, low salt, less protein, calcium citrate preferably, reduce weight, role of citrate, magnesium, and pyridoxine. Thank you.
Thank you, Dr. Pankaj, for this wonderful lecture. And I'll invite you to share the dice with us.
Thank you very much.
And as we have understood that if we are living in the stone belt, then there are world is divided into two kind of people: stone formers or non-stone formers. And if you are stone formers, there are you are attracting the complications also, as has been deliberated, that include obstructive uropathy like BPH or infections, hypertension, or ultimately kidney transplant need also. And therefore, it is very important topic, as it is, as Dr. Pankaj has touched, that there are, once there is a stone, you are always having the risk of another stone, and that is recurrence, and we have to take all the steps. So with this, we conclude our lecture on kidney stones, and discussions will be the part at the end of the sessions. And for next two lectures, I now hand over the deliberations to Dr. Anil Goel, who will be inviting the next two speakers also.
Thank you, Dr. Rajeev Sood, and thank you, Dr. Pankaj. At the outset, I must compliment profusely Dr. Chitis Wali, who has organized this IMA Kidneycon, wherein in this urology session, we are discussing various common urological diseases. And the speakers are mainly the stalwarts in their own field, whether it is Pankaj Wadhwa, and now I would introduce Dr. Ramesh Babu, who would be speaking on structural diseases of kidney in children. Dr. Ramesh Babu is a gold medalist in general medicine, general surgery, graduated from Madurai Medical College in 1985 to 1991, did his MS surgery from Calicut Medical College 94, and MCH pediatric surgery from the Institute of Child Health, Chennai in 1997. He passed FRCS Glasgow and Edinburgh in 97, and then underwent special training in pediatric urology and laparoscopic surgery in the United Kingdom between 97 to 2003. He worked at premier institutes of Great Ormond Street Hospital for Sick Children, Bristol Children's Hospital, University Hospital, Cardiff. And so he has a vast experience in the field of pediatric urology, and his research on glutamine, glutathione, and the Institute of Child Health, London, won the Donald Peterson Prize for the best pediatric research. He obtained his FRCS in pediatric surgery and pediatric urology in CCST, UK in 2003, and currently is a professor of pediatric urology. So without going into much of the details, obviously he's a celebrated pediatric urologist and accomplished one. I would request him to present his lecture on structural diseases of kidney in children. Dr. Ramesh Babu, please.
Thank you, sir, for the kind words. Can you hear me?
Yes, sir, we can hear you.
Yeah, I have just started sharing my screen. Please let me know whether you are able to see the first slide.
They are visible, sir. First slide is visible.
Yeah, thank you. And I moved to the second slide. Are you able to see that?
Yes, sir, it's perfect.
Yeah, thank you. Thank you. Without wasting much time, I would go into the topic. As you all know, the hydronephrosis, it gives you only the diagnosis of dilatation of the kidney. It doesn't exactly give you where the problem is, why the problem occurred. And when we are, nowadays, we get a fetal scan with the reports, and we seek the information like whether it's unilateral or bilateral, whether it is hydroureteronephrosis, and what is the AP diameter of the pelvis, whether the dilatation is the central or the peripheral. Now, when we look at the etiology of the hydronephrosis, one of the commonest thing is the transient hydronephrosis, also known as non-obstructive dilatation. And this is followed by the uretropelvic junction obstruction, vesicular reflex, posterior urethral valve. Now, the Society of Fetal Urology grading is the most important thing it used to be. And even now it is very valid, because we can look at the ultrasound and then say what is the grade of the hydronephrosis. Anteroposterior diameter again is an important parameter, and based on the trimester, whether it is the first, second, third, or after birth, you can have a cutoff like 4 millimeters, 7 millimeter, and 10 millimeter to call it a hydronephrosis. And you can also look at the severity, like if it is like 4, 7, and 10 in second trimester, you get mild, moderate, and severe. 7, 10, and 15 in third trimester, and 10, 15, and 20 are severe. So more than 20 millimeter after birth is really severe. Now, the urinary tract dilatation classification looks into multiple factors. It looks into, it actually includes the anteroposterior diameter features, as well as the features of the Society of Pediatric Urology, like whether the dilatation is central or peripheral, whether the parenchymal is normal or abnormal, and then whether the ureter is normal, abnormal, bladder is normal, abnormal, and also it includes the oligohydramnios, and it classifies them into UTDA1, which is a low risk, or UTDA2 to 3, which is high risk. And when it is a high risk, you obviously need a specialist consultation for further evaluation. Now, transient hydronephrosis, as I said, also known as non-obstructive dilatation, is due to insufficient maturation of the uretero-pelvic junction and increased fetal urine output. This is a case of a 1-month-old baby who had a grade 4 hydronephrosis, and the AP diameter was really high. It was more than 20. It was actually 35 millimeter. And we went for this diuretic renogram, and it showed that the curve was obstructed. So when we followed up this patient at 6 months age, the function reduced from 45 to 39%. So any drop in function of more than 10% is an indication for pyeloplasty. However, in infants, early pyeloplasty, even before drop in function, is better, because we have to make sure that they are able to recover the lost function. And we in this paper proved that early pyeloplasty in prenatally diagnosed grade 4 hydronephrosis leads to significant improvement of renal function, whereas delayed pyeloplasty can lead to marginal but significant loss. So nowadays we are even in infants, we are able to do laparoscopic pyeloplasty. This is technically like an open pyeloplasty. The same steps are followed. We use 3 millimeter instruments, and the steps are exactly like how it is. And the results are pretty good. You don't even see the scar because we use 3 millimeter instruments, and the function also recovers. As I said, the younger the infant, the function recovers. Now, posterior urethral valve is an important condition which we have to be aware of. It is often picked up in antenatally with severe bilateral hydroureteronephrosis with a keyhole sign, which is basically a dilated bladder and posterior urethra, progressive oligohydramnios. It can also present later with the palpable bladder, dribbling, severe urinary tract infection, failure to thrive, or sometimes it can just end up with a renal failure. So an ultrasonogram often shows bilateral hydroureters, thickened bladder, and voiding cystourethrogram gives the diagnosis where there is a cutoff in the junction of the posterior and anterior urethra. So these are all tiny membrane-like leaflets, but the causes of the obstruction are very severe. So we use endoscopic ablation using these instruments. We divide the valves at 12 o'clock, 5 o'clock, and 7 o'clock to relieve the obstruction. And once this is done, we should keep the follow-up to make sure that the hydronephrosis improves. In a case where successful PUV fulguration, the dilatation actually comes down. So we looked at it and then showed that cold knife ablation is superior to diathermy in relieving obstruction in a single attempt, and it produces significantly less stricture. So nowadays I use a cold knife rather than a cutting diathermy. And also we showed that when the posterior urethra to anterior urethra ratio is less than twice, then you have a successful fulguration, whereas the posterior urethra is still more than twice the diameter of the anterior urethra. You have to do a check cystoscopy to exclude a residual posterior urethral valve or a stricture. Now, vesico-ureteric reflux is an important condition. It causes recurrent urinary tract infections in a child. Febrile UTI is typically diagnosed when there is a fever and constitutional signs. That means there is a pyelonephritis. And this is an important history we need to evaluate. If that is the case, then we need to make sure that the children with the pyelonephritis are properly evaluated. Otherwise, they end up with the scarring, renal failure, hypertension, etc., etc. Again, avoiding cystourethrogram gives the diagnosis, and the reflux is graded from 1 to 5. The main advantage of grading is grade 1 and 2. We know that there is a good rate of resolution, whereas the higher the grades, the resolution chance is much less. So this is a 6-month-old girl who presented with the urinary tract infection, 2 episodes of febrile UTI, bilateral hydronephrosis and hydroureter, and the DMSS scan initially showed very little or no scars. But when we followed up her later, the initial management of all these children is conservative. We put them on antibiotic prophylaxis, usually cotrimoxazole, and when they develop a urinary tract infection while on antibiotic prophylaxis, we call it a breakthrough infection. And the scars get worsening, as in this case, that's a typical indication for intervention. So this is a failure of conservative management, which is a breakthrough infection, worsening of scars, or high-grade reflux. Now, sting procedure is a subureteric transurethral injection of dextranomel, or various other materials are also there. And basically what we do is we make this material, which is made of the dextranomel with hyaluronic acid, and that material is injected with the needle via cystoscope at the location below the ureteric orifice. It creates a volcano-like appearance, and once it creates the support to that refluxing ureter, over a period of time, the reflux spontaneously resolves. So we looked at this meta-analysis where we compared multiple materials, and we found that the material called polyacrylate polyalcohol copolymer, PPC, is slightly better than dextranomel hyaluronic acid. This is widely available in the Europe. It is yet to be available in India. Hopefully it will come soon. Now, this is another patient with vesicouretic reflux. We can always go for endoscopic treatment also in these patients. And this is a patient who underwent laparoscopic extravesical reimplantation. And I won't go into the details, but we did a meta-analysis on this. And we found that laparoscopic extravesical ureteric reimplantation has a shorter operating time, higher success rate, and shorter hospital stay compared to transvesicoscopic ureteric reimplantation. So this is another method where we put the ports directly into the bladder, called vesicoscopy, and mobilize the ureter like a Cohen's reimplantation, cross-trigonal reimplantation, and correct the reflux. We also compared robotic-assisted versus laparoscopic extravesical reimplantation. Robotic-assisted reimplantation reported longer operative time, lower success rate compared to laparoscopic reimplantation. While robotics is very popular in adult urology, in pediatric urology, it is still catching up. The main reason being the size of the instruments. Whenever we operate in infants and 1-year-old, the instrument size is like a 7 on 12 millimeter trocars. Whereas when we do a routine pyeloplasty or reimplantation, what we use is a 5 millimeter telescope and 3 millimeter instrument. Now, a little bit about neurogenic bladder. The neurogenic bladder is due to high pressure in the bladder. It can be because of a spina bifida or myelomeningocele or sacral agenesis. It typically leads to urinary incontinence. It leads to constipation, on recurrent urinary tract infections, hydrouretronephrosis, and if left untreated, chronic renal failure. So the typical management of neurogenic bladder is anticholinergic medication, clean intermittent catheterization, and injection of Botox. So this is another endoscopic procedure where we inject Botox into the multiple areas of that tuberculated bladder. The injections can be in the submucosal plane, or it can be in the intramuscular plane. Both of them work. So we just avoid the trigone and inject the material into multiple places within the bladder. So this is to reduce the pressures of the bladder. And once this is achieved, we can avoid a major augmentation. However, if the bladder capacity is already really small, and then we have to ensure that we do a proper bladder augmentation and Mitrofanov procedure in these patients. So to summarize whatever I've spoken now, antenatal hydronephrosis, most of them resolve spontaneously.
Sir, we are running a bit late, sir. If we can.
Yes, I'm the last slide. So post PUG obstruction hydronephrosis more than 20 millimeter need surgery. In a boy with bilateral hydronephrosis, suspect posterior urethral valve, and in a UTI child, suspect vesicular reflux, and neurogenic bladder, you have Botox injection as one option. Thank you for listening to this talk.
Thank you, Dr. Ramesh Babu, for giving the some basics of structural disease of the kidney in children. What I have just want to make a comment in these last 30 years. The IMA audience includes the gynecologists, pediatricians who may be listening to this talk. The only thing I want to say is we need to find out the patients who needs operative intervention. Earlier the better, especially in posterior urethral valve or even in the view reflex. We are seeing patients who keep on getting antibiotic prophylaxis. So possibly that is not right. Also in the case of PUG obstruction, we are getting patients late with poor kidney function. So that's my comment on that. And thank you once again.
Yeah,
I now want to introduce dear friend Dr. Sanjay Pandey, who is head andrology and reconstructive urology, consultant robotic urology and gender reassignment surgery in Kokilaben Dhirubhai Ambani Hospital, Mumbai. He has 23 years of academic urology behind him and vast experience. Advanced training in niche area of uretroplasty. He got in uretroplasty in 2003 in Italy, then genitoplasty 2005 Germany, gender reassignment 2007 Belgrade, and robotic urology 2014 in Korea. I think it is time, Sanjay, you need to start your own advanced training center in these niche areas. I think, where is the slides? Just show me the slides of Dr. Sanjay Pandey. Gautam?
Good morning, sir. I could only share slides. Yeah, thank you so much.
Yeah.
Thank you.
Sanjay, yeah. So he is past associate professor in urology, Sri Ramchandra Medical College, University, Chennai. Thank you, Sanjay, for joining us in this IMA conference. And I would like to speak, you speak on urinary tract infection. Dr. Sanjay Pandey.
Good morning, sir. Good morning, Anil, sir. Good morning, everybody. Respected chairpersons, moderators, friends, Pankaj, Dr. Suraj, Dr. Bali, Dr. Vineet. I think it's a great day. It's a great honor to be here. Thank you so much for inviting. As I share my presentation, and I hope it's visible, my left eye is on the clock and the right eye is towards moving the pace. Each of you in this audience is a pilot. You run the show across. The good news is that all of us are combining together on a very wonderful platform. The bad news is time flies. To take subjects of these kinds, which you've just heard luminaries speak, is something to bring an encyclopedia into a 20-minute session is a wake-up call. So today, urinary tract infection 2022, a case-based approach. It's only time to take it to a front row seat, as Dr. Bali wanted this to be a presentation at the IMA Kidneycon. Thank you so much, Dr. Bali. And like Gary, greetings from Kokilaben Dhirubhai Ambani Hospital. It's only to show that every life matters in all the diseases that have been talked about. Today, we are trying to improve quality of life of individuals who land up with UTI and recurrent UTI. Sadly, we are at crossroads on many aspects. We're also at crossroads on UTIs because UTI is treated by all of us, you, me, and everybody. It's just that, have we come a long way? Are we under control or are we losing control? We don't have many antimicrobials left over in the pipeline. So on one side, being judicious with man-machine medicines and the motivation to do it and take it forward as a teamwork is what matters in urinary tract infection. We may probably roll it very trivial, but it may not be so. UTI and inflammatory response of urothelium to the microorganisms which actually inflame the urinary tract, leading to that very basic that we always talk about as clinicians in the audience: dysuria, frequency, hematuria, urgency, suprapubic pain, costovertebral tenderness, maybe strangury. This could be missed out unless we look at a patient's history in detail and probably a physical examination. Friends, it's the most common urological disorder and something which is what everybody is consulted through. It's also one disease where you could have UTI in the morning. You could have a complicated UTI by afternoon. You could be on ventilator and a urosepsis by evening. And the same disease could probably kill somebody late in the evening. So no other disease in the world could be diagnosed in the morning as UTI. And by the time you land up in urosepsis and on a ventilator, you're dead on the same day. It's a disease that is a wake-up call for all of us. In other words, let me look at start to finish on a quick case-based scenario in the next 18 minutes. Acute case UTI is something where we have a patient in front in the outpatient department complaining of episodes of dysuria, burning sensation, urgency, strangery, fever. But is the patient having an obstructive warding, or the patient is having a dysfunctional warding? Is somebody having no structural abnormality in the urinary tract as a young man or a woman, or somebody who is an elderly with a hypocontractile bladder of a diabetic cystopathy or a neurogenic bladder, or somebody who has got a prostatomegaly with an occlusive prostate causing trouble to him? Recurrently, he is being treated for it. So friends, UTI has risk factors, as our colleagues have alluded to, on stone diseases, on prostates, on pediatric urology. We looked at risk factors are ubiquitous. From the day of birth till we are around, you could have a UTI. And elderly people, young, old, not so old, young, everybody could get it. But let's look at a subject of complicated UTI where you and I team so much. That means a urologist in your team actually happens to be doing that. Infection associated with a condition such as a structural or a functional abnormality of genitourinary tract, or the presence of an underlying disease that interferes with the host defense mechanisms, commonly diabetes, which increases the risk of acquiring infections or failing therapy. Very important for us to look at this subject of complicated UTI, which means there are factors which complicate a UTI called complicating factors. Indwelling catheters, obstruction to the urinary passage as alluded to by the prostate or by the stone, male gender, which is a complex genitourinary system, elderly age group and changes happening both in the urethra, prostate, meatal stenosis, lichen changes, and other host defense mechanisms like renal insufficiency, diabetes mellitus, immunosuppression, the reflux which has persisted, urolithiasis, pregnancy, and obviously warding dysfunction missed out unless we take a very proper history. Friends, let's look at one individual who has got recurrent UTI and is a young man. Recurrent UTI always has a cause. That's something which we will probably take back home on Monday morning tomorrow. History speaks all. He says, I get a recurrent UTI, I get burning discomfort. Did we ask him that he has a good flow or a poor flow? And it all speaks. When I do a uroflowmetry, when I look at him, and probably I take the evaluation to the highest level, doing a urethrogram, we know that this gentleman has a recurrent UTI not because of anything else. The recurrent UTI here is because of a urethral stricture. So let's not miss out on history, examination, and evaluation to the highest level A to Z in men who complain of UTI scenarios. Number one. Let's look at somebody else, another younger man who has a recurrent UTI. He complains of dysuria and he has pain at the tip of the shaft. I think if we have not examined him, we have missed him out. He has been treated outside. Don't forget, such individuals are asked to do urine routine and culture, not telling them how to give a proper sample. A midstream clean cat specimen after pulling the prepuce and washing it up is all that is required, and many of them may not be knowing, especially these gentlemen who are in question right now. The clinical examination finally speaks out. A phimosis, adhesive balanoposthitis, firm indurated prepuce, smegma, the kind of picture that you see once you under the undergarments. He does not need a treatment for a UTI. All that he needs is a circumcision and a frenuloplasty. I think his job gets done. So we have missed out all those things, perhaps because of the kind of role that we play as doctors morning till evening, the kind of role that we have. Somebody who is having a constant source of situation where I have to really retract the prepuce and see that this is a chronic balanoposthitis of adhesions of balana, that is erotica obliterans. So examination. So from a history, we move on to examination. Young men can get a UTI too, though it's not so common compared to women who go through the trauma. Women with UTI sadly is an epidemiological phenomena because perhaps God forgot to make organs such where urethra, urinary bladder have got no bacteria, but just behind that is the vagina and the rectum. And female urethra being shorter, the introitus being colonized with vaginal and rectal bacteria, they could get UTI post-coitus, post-examination, spontaneous, etc., etc. Changes of hormone bring them change from young to not so young, and changes do happen. They get reinfection, they get relapse, and therefore women are always under radar, unfortunately, getting UTIs because of anatomy, because of changing anatomy, and because of changes which cannot be examined even by them. Let's look at two quick examples. 25 years, cinematographer, she comes from South Extension. Recurrent UTI, occasional febrile episodes, doesn't have constipation, doesn't have obstructive warding, no vaginal discharge. Ultrasound abdomen and pelvis, which you and I do so quickly and always, is normal. Minimal residual volume, upper tracts are normal. Then why on earth is she getting a recurrent UTI? Is it something to do with some missing links? Perhaps the hygiene component, which may never have been taught, or an aspect of sexual hygiene. So because she has expected anatomical and structural alignments which are normal at her age, compared to 20 years later when she'll be postmenopausal and changes may happen. So there are times when UTI has to be looked into with these aspects. Move forward to look at somebody who's middle-aged, from 46 years old, perimenopausal, recurrent UTI with acute episodes. Acute treatment happens around, and there are prophylactic doses that you give as you treat such patients around. But she gets recurrent breakthrough UTI even after you have done so well. And it's not related to postcoital phenomena. She knows, Dr. Pandey, I maintain great sexual hygiene. I have no problem on those things. Attempted all to prevent recurrent UTI as a patient, and you and I as a doctor. And what we do very commonly is an ultrasound, which looks almost okay, with some bladder wall thickening, etc., etc. Out here, we could miss out such patients if we don't take a history beyond this. She is perimenopausal. Ultrasound is a great observer-oriented study. It can be repeated again and again, and we can pick up some findings, which could be hydronephrosis, hydroureteronephrosis, bladder capacity, bladder wall thickness. Sometimes you can pick up debris and floating echos in such patients, or stones, or a high residual volume. But friends, there is a missing information in this, which is in the history of all UTIs in the susceptible age groups or in susceptible population, which is a voiding pattern, which is very important. Let's talk about issue in ultrasound versus uroflowmetry. Ultrasound gives you static images on a wonderful pictures that our colleague radiologist has given. It gives you a size of prostate, it gives you ureteric jets, it gives you bladder wall thickening, it gives you post-void residue. But what is the uroflowmetry that I'm talking about? It gives you a voiding information. It's a dynamic study which tells you regarding the pattern in which you pass. I call it as an ECG of the bladder. That is the way a patient passes urine and the way the patient holds urine back. It is all told in one study compared to ultrasound, which talks about a pre and a post void. So patterns tell you all, like the ECG tells you all about it. Intermittency, hypotonic bladder, box shape, stricture urethra, etc., etc. For example, that's a uroflowmetry which Dr. Anil, Dr. Sood, and Dr. Bali do every day in their lifestyle in terms of asking patients to void. And when a patient passes urine, the ECG of the bladder comes in many forms. For example, that is a normal flow pattern that you and I have, a great bell-shaped pattern. But there could be somebody who could be having this kind of a pattern. A flat flow, you can see the flow is flat, long, and somehow has a high residual volume. So out here, if an ultrasound picks up only a high residual volume, it may not be great enough. The causes need to be known. For example, the man with stricture urethra may be able to empty his bladder completely till one fine day you can't catheterize him in emergency, and you see that he has a stricture urethra. So women can also land up with stricture urethra. In other words, I'm waking up to a reality that diseases don't come with knowledge and sound. For example, the final diagnosis in this lady was a micturitic cystourethrogram, which talked about a stricture in the distal part of urethra in a perimenopausal age group. Could be iatrogenic, could be related to catheterization, could be just a change of lichen sclerosis. So female urethral strictures are not uncommon. Inflammatory, iatrogenic, traumatic, presence with background of adjusted symptoms of recurrent UTI, treated with antibiotics. Many a times the woman doesn't know how to give a urine sample, and there could be definitive cures by the urology colleagues in the audience. And that's how patients sadly are adjusted to lesser modes of therapy of getting their urinary sterilized, which comes again. It was only to wake up that these kind of phenomena do happen. We may miss out unless we go to the depth. Pregnancy-related issue comes up, childhood recurrent UTI, on chemoprophylaxis before menarche, everything was fine. When the diagnosis comes up, at that point in time, she was grade 3 VUR. She was asymptomatic for 20 years till she got married, asymptomatic bacteriuria. And that's the only time you treat asymptomatic bacteriuria is a situation when you have a pregnancy, which means you will have to wake up to look at everything. Evaluating, need to treat, prevent episodes, prevent issues, and obviously prevent a pyelonephritis. A wake-up call for all of us that pregnancy asymptomatic bacteria holds importance. I just move forward and look at what Dr. Ramesh Babu was presenting in the pediatric age group. Limited mobility in a 28-year-old female. Meningomyelocele, obstipated for all reason on purgator, lives on diapers, voids with Valsalva, and has a recurrent UTI with febrile episodes. Will antibiotics treat her that she's taking for the last 10 years? Perhaps no. Ultrasound shows a significant post-void residue, debris plus bilateral hydroureteronephrosis. She doesn't fit into a uroflowmetry at all. In other words, it's all about examining wet diapers, fecal impaction, expected high residual volume, breeding ground for all UTIs. And therefore, a urodynamics, a micturating cystourethrogram would give us some idea. That's looking like a bladder with multiple diverticulae and a VUR. If that is what it is, it almost behaves that she has a hypocontractile bladder, delayed sensation. She lives with a pregnant bladder all the time and debris is visible. These kind of patients already have a proof of safe bladder. The kidneys are not being jeopardized. The creatinine is still 0.9. All she needs is the clean intermittent self-catheterization with anticholinergics, augmentation cystoplasty by our colleagues with bilateral ureteric reimplant, put her back into the main road, the wall that we go. So moving quickly forward to elderly men, which we did hear about in the wonderful lecture by Dr. Vineet on BPH. Recurrent UTI in elderly man, always a cause. Febrile episodes, sadly treated conservatively all the time. Fluctuating glycemic control, presence to urologists, clinically benign prostate, ultrasound shows a high post-void residue. And Euroformatry tells us all. We won't wait on such patients around. We are looking at somebody who has got a ureteric jets on ultrasound, which is an important aspect. For patients who have got ultrasound showing hydroureteronephrosis, the ultrasonologist could move one step forward and tell to us whether the jets are visible or jets are not visible. In other words, is it an obstructive hydroureteronephrosis or a non-obstructive hydroureteronephrosis? Let's look at a gentleman who had a recurrent UTI febrile presentation finally. Recurrent UTI being treated at that age group and febrile presentation. Ultrasound showed mild, long-standing hydroureteronephrosis. Perhaps we missed the boat. If there's a mild hydroureteronephrosis, I would go to a logical conclusion. Look at a ureteric jet absent or present. Perhaps do a plain CT-KUB. A CT-KUB is done in a febrile presentation. Down there on the right ureter, you find a juxtavesical ureteric calculus with a central lucency. There are gas pockets in the ureter. In other words, this patient deserves something very urgent. That's just a quick 20 seconds non-edited video for patient with febrile presentation, right gross hydroureteronephrosis, presents with high fever, chills into sepsis, almost getting into a ventilator right now. This is the kind of a patient who has mild right hydroureteronephrosis for a long time. Something has been missed out. He was a diabetic. Perhaps a papillary necrosis has been missed out as a central lucency, over which a stone may have formed as a radiopacity that is visible on the CT scan. All that somebody did was a cystoscopy and a digest stenting, and it saves all. In other words, we need to decide when we will treat a UTI and when we'll probably pass it to our colleagues in urology to move forward. In other words, we are a team. We all are a team as doctors together. Have a look at the toothpaste coming out of this ureter. We are busy treating such patients with recurrent UTI across, perhaps because the patient is not decompensated. By the time he decompensates and presents, it is too tough a situation in urosepsis in this situation. I'm coming to my last few slides, Dr. Bali. It is all about looking at how do we take it forward. So that toothpaste coming out is a telltale story that recurrent UTI always has a cause. The stone was sitting in the ureter, and no stone defies the natural history of either growing or falling down and possibly causing a trouble. So make hay while sun shines. Today, we have retrograde intrarenal surgery, which is a prophylactic surgery. While you do UTI prophylaxis, you prevent this kidney stone from falling down. And if it falls, we don't always do a medical expulsion therapy because a small stone is blocked in the ureter. There's a reason it's blocked. So we move forward to somebody who failed catheterization. Look at this picture. 3 months post CABG. He is on Brilinta. He is on clopidogrel. He's a 69-year-old man treated by recurrent UTI by many of our cardiology colleagues. Prostate is only 20 grams, so nobody ever bothered perhaps. But Vineet and I told you that 20 grams or 200 grams prostate, not a big issue. What is the prostate doing to the urethra or the prostatic urethra? How much is it causing an occlusion? And this gentleman, when he came to the emergency department this time, no anesthesia, obviously he's come to emergency with another issue. He's failed catheterization. And sadly, we can't do a suprapubic cystostomy with Brilinta and clopidogrel. He's taken for a cystoscopy, which is all about a 20 grams prostate. Look at this 30 seconds where a patient under anesthesia, I'm taking a telescope, the prostate is only 20 grams. The scope is not going in under general anesthesia. What does it mean? He failed catheterization for a simple reason that our colleagues could not catheterize, only because the prostate is grossly occlusive internally. So 20 grams or 200 grams prostate is not important. He is getting recurrent UTIs. We are making our attempt to enter the bladder and just put a catheter. And it's getting difficult. I come back, I go in, I come back. And finally, I push the scope to enter a full Pandora's box of thick debris pus in the bladder for which recurrent UTI has been treated. He got decompressed. I'm just in the last second. Thank you so much. So that's where we are. And you enter and you find that. So recurrent UTI always has a cause. That is what I was talking about. Let's not let it slip from this to that. Friends, long-term catheter issues are important. Neurogenic bladders, elderly people, limited mobility. Long-term catheters, why urethra is not acceptable. Suprapubic cystostomies are safer. Urine examination always matter. On catheter, examining a urine will have no value. There will be pus cells, which are inflammatory cells. It is important to look at that aspect of. As I come to a close, thank you so much. Impossible to possible, finally treatable and finally curable is what it is. So all those who deal with recurrent UTI and UTI, today is a wake-up call. Life come to a full circle. Let's prevent a UTI to urosepsis. Let's embrace changes and guidelines for success, because we need to change goalposts as we land more. Friends, I love a doctor is what our patients say when we treat a UTI. I love a urologist is what my colleagues say, because we have been a team member to aspects that we have looked at. Come to a close. Age, presentation, needs and expectations are always a challenge. An evaluation missed could be a treatment delayed, could be a very slippery slope. Recurrent UTIs can be prevented. Urosepsis can be treated. We're bringing them back with the motivation of a man, machine, medicines, and that is how it is. Thank you so much for inviting me to this. Thank you.
Thank you, Sanjay. And you are really very fast forward, and as usual, the best. Only comment I would like to make here is that this is an IMA audience. Just do a proper examination. We have seen lots of patients with chronic retention urine having a large bladder and being treated for recurrent UTI. Just they have a phimosis or a meatal stenosis, a stricture, or somebody has not done an ultrasound to find out a stone disease or any structural abnormality. So always do a thorough physical examination, do an ultrasound other than routine urine, routine culture, and kidney, because ultimate aim is to prevent the loss of kidney unit, to prevent the morbidity, and to prevent the bladder function loss. Thank you, Sanjay, for being so eloquent. Thank you very much. And over to you, Dr. Kshitij Bali and Dr. Rajiv Sood.
Thank you, Goel sir. Thank you, Pandey sir. Nice presentation. We'll just quickly take 3 questions. Very interesting questions are here.
Thank you very much. All the speakers have done wonderful job and we are in time, but quickly we'll take the questions. And the first question is to Dr. Vinit Goer. Some audience are continuously pouring questions. Some have already been answered during deliberations. So first question is that when this is prostate patient, we diagnose, and we know that nowadays 80% or more are managed by medical management and surgeries are 20% or less. So what are the today also absolute indications for surgical intervention in these prostatic enlargement patients? Dr. Vinit.
Dr. Vinit, are you there? I think Dr. Vinit is not there. Dr. Sanjay Pandey sir, can you reply this? If Vinit is not there?
Sorry, the audio was, I missed out the audio, Bali. I missed out the question.
Sir,
just recap.
The question is absolute indication, surgical intervention for absolute indication for surgical intervention in a BPH patient.
Wonderful question. Wonderful question. In very crisp, number 1, BPH is a pathological diagnosis. Bladder outflow obstruction is your diagnosis as a clinician. If you find a bladder outflow obstruction, you rule out the causes. If there's no stricture urethra in a 50 to an 80-year-old male, you know his uroflow is obstructive. He gets a recurrent UTI. He has got bladder stones. He is getting gross hematuria from a enlarged prostate, or he is getting into silent renal failure. So in today's refractory retention, silent renal failure with prostatomegaly, multiple bladder stones, and not being able to avoid on medical management, which is failing because of the medicines not working on him, we do a uroflowmetry urodynamics and go ahead with a TURP or a HOLEP and open the bladder outflow obstruction, which is what we call as a BPH.
Thank you so much. We have a very interesting question for Dr. Pankaj. Somebody's asked, what is the ideal treatment for a stone in the kidney, which is 15 millimeter? Lithotripsy, RIRS, PCNL, or mini-PERC?
Right. So as I said, it's not just the only stone size. It's also how hard the stone is. So on that CT, one would be able to see whether there is the Hounsfield unit of the stone. So if it's a very hard stone, more than 1200, then a PCNL would probably be a better option. If it's still about 1000, one could go ahead with the RIRS also, as long as the anatomy allows it and as the patient factors allow it. So the options are still open. It could be PCNL, it could be RIRS. Lithotripsy would be a much poorer option because the clearance rate would be much lesser.
Thank you, Dr. Pankaj. Now the question to Dr. Ramesh Babu: how to follow up children diagnosed antenatally with hydronephrosis?
Ramesh sir, are you there? Ramesh sir, are you there? Okay, I think Dr. Anil Goel sir, can you do this?
Yeah, I think it will depend on the AP diameter. That if it is say less than 40 mm or more than 40 mm, when to do surgery, it will depend on if it is less than 40, we can observe and do an ultrasound after every 3 months, say 3 months, 6 months, 9 months, and a DTP at the age of 3 months. So in this, I just want to add that we have found that early intervention may be better in cases where the AP diameter is more than 40 mm.
Thank you so much. Last question, Pandey sir, for you. It's very common, sir. What is the first choice of antibiotic once you see a patient of UTI? Culture report is still not available, sir. Patient comes to you with symptoms of UTI.
In February 2022, if there's a patient who walks in with a UTI, which is only dysuria, strangury, a discomfort over the last 24 to 48 hours, and I know that I have to wait towards evolution, which I want to cut down as quickly as possible, then the era is about looking at hitting hard and hitting fast rather than letting the patient go into urosepsis. A very generalized question and therefore a generalized answer, because a patient could be an elderly man with a prostatic enlargement, or a patient could be a recurrent UTI, or somebody who could be having just a female with UTI. I would look at two aspects to this. So the antibiotic could either be using a newer antibiotic, which is the one that we use as a 3-gram sachet, which comes as, I'm just forgetting the name. We use one short antibiotic.
Fosfomycin.
Yes, fosfomycin. Sorry, my apologies. So fosfomycin 1-gram sachet is something which is safe as one sachet. While before you do that, you ask him to give a proper clean catch midstream urine specimen, and the patient is going home. As the patient goes home, you ask him to be continuously watching himself, not slipping into something significant. While you wait for the cultures, the disease should not evolve. So that could be one short antibiotic compared to the era when we used to give a bacteriostatic antibiotic called nitrofurantoin, which is bacteriostatic alone. It may not be able to treat urethritis and maybe an ascending pyelonephritis in 3 days' time. So my caution would be to use nitrofurantoin as a drug of choice for patients who have come to you in the OPD with dysuria, strangury, discomfort, and possibly could have an ascending UTI in 3 days' time and slip into a slippery slope. So something of a quinolones, which is not yet still very badly abused, a ciprofloxacin group kind of thing, but more so with fosfomycin 1 sachet, with all symptomatic therapies of urispas and cetralca and pyridium, etc. for the lower tract and mephtal spas. Watching very closely, the patient and you are a team. It's just not giving an antibiotic and letting a patient go, come back in 3 days' time with a florid UTI. So while you give one antibiotic, you watch them symptomatically, you take it forward, you wait for the culture reports. If a patient is slipping into something, then there could be much more to do. So I've just given a very generalized answer. For one antibiotic, take it forward, observe closely and move on.
Thank you, sir. So we conclude this session.
Yeah, thank you. Thank you to all the esteemed urologists for that great session. All of us learned a lot, our audience and nephrologists alike. Now, just as a token of our appreciation, I'd like to call upon stage Dr. Didi Chaudhary to please present a memento to our chairperson and moderators who are present here with us. So please come on stage, they'll bring the memento. So please, Dr. Didi Chaudhary to please present a memento to Dr. Rajiv Sood. Dr. Didi Chaudhary to please present a memento to Dr. Kshitij Bali. Dr. Didi Chaudhary to please present a memento to Dr. Kshitij Bali.
Please show the stage. Organizers, please show the stage. Thank you.
And Dr. Didi Chaudhary to please present a memento to our speaker, Dr. Pankaj Wadhwa. Thank you, sir, for joining us today. Thank you. With this, we move on to our next session. Thank you to Dr. Kshitij Bali and the moderators for this session. The next session is on chronic kidney disease. I will be your moderator along with my colleague, Dr. Akash Shingada, who's joining me online. Before we begin this session, I'd like to call upon stage Dr. Anil Chaturvedi. He's the Chairman, Preventive Health and Lifestyle Diseases at Goel Hospitals. He's a National BC Roy Awardee as well as a V. Parmeshwara API Lifetime Achievement Award. So we request you to join us on the dais. With that, we'd like to introduce our chairpersons, Dr. D.S. Rana, Dr. Akash.
Thank you, Dr. Garima. And at the outset, I would like to congratulate the organizers, Dr. Garima, Dr. Kshitij, and the entire team of IMA Kidneycon. It's been an excellent conference, and it is truly a privilege to introduce Dr. D.S. Rana. He's been my teacher and mentor, and technically does not require any introduction. But just to summarize, his passion of teaching, he was instrumental in getting a DNB program in nephrology in 1991, and he set up the Gangaram Institute of Postgraduate Medical Education and Research. He's been actively involved in teaching programs for DNB and DM students, and has been a accrediting officer and examiner across variety of institutes in the country. He's been truly instrumental in development of a nephrology education program in Kathmandu, Nepal. He's been awarded Padma Shri by the Honorable President of India in 2019, and he's been awarded Dr. V.C. Roy National Award by Medical Council of India in 2016. Most importantly, he's a very respected and very loved teacher, colleague, and anybody who knows him would kind of attest to that. On his behalf, I would like to apologize that he's not available today here because he's traveling to Banaras for the North Zone ISNCon, but he's with us in spirit. With that, I invite Dr. Garima to. Yeah.
Thanks, Akash. I'd like to introduce our second chairperson, Dr. R.V. Ashokan, sir. He's a practicing general physician since 1983 in Kerala. He was the IMA State Secretary for 3 years and later its State President. He also conceived and established the IMAGE, a biomedical waste project of the IMA Kerala State Branch, which has been very successful. He is an advisory group member of TB of WHO Geneva for the last 2 years. He was the National Vice President in 2013 and later the National Secretary of IMA Hospital Board of India. He's also been its chairman for 4 years. Dr. R.V. Ashokan, sir, we are happy to have you here. Please, would you do the honors of introducing our first speaker? Thank you.
Yeah. Thank you, Dr. Garima. This is an extreme honor to be with the IMA Con team. I congratulate the organizing secretaries, Dr. Garima and Dr. Kshitij Bali, and the president and secretary for this wonderful initiative. The young team is the academic phase of Indian Medical Association. We are all very proud of that. Let me introduce my speaker, Dr. Siddhini Vishwanath, who will speak on diagnosis and staging of chronic kidney disease. He is a DNB in pediatrics and a DNB in nephrology, and he is the HOD of nephrology in Mahe, Manipal University, and member secretary of the Ethics Committee of Manipal Hospital. And he is a gold medalist in Mysore University in MBBS and a gold medalist in DNB nephrology. He has, to his credit, more than 35 national and international publications. Over to you, Dr. Siddhini Vishwanath.
Thank you, sir. Thank you very much. At the outset, I would like to thank IMA for the opportunity given, and I would also like to congratulate the organizers for wonderful work. Hope you can see my screen.
Yes, sir, they're visible.
Okay. I'll just run it. Are the slides changing?
No, sir, not yet. If you can click on the full screen. Yeah, now it's
Yeah. Thank you. So my talk today is on diagnosis and staging of CKD. Staging is very important, as we all know. The content of my talk would be with a few introduction. I'll go to the definitions of CKD. What are the risk factors and how do we diagnose CKD basically? And what are the stagings and how do we utilize the staging in our day-to-day clinical practice? As we all know, kidneys and the collecting system are very important. That's the whole theme of our conference today. Nephron is the functional unit, which has all the units we all are aware of. Each kidney has about 1 million nephrons, and many times because there are so many nephrons available, slow loss of the nephron mass may not be detectable at all. And many people may look healthy, though there is a progressive loss of kidney function and nephrons. And by the time, most of the times we recognize symptoms, more than 3/4 of the kidney function is lost. That's the reason the recognition of kidney disease in the early phase is very important. As we all know, it not only does filtration, reabsorption, and secretion, it also helps in various metabolic parameters management in most of our body. Ultrafiltration, basically a kidney filters the blood. So almost it filters about 130 to 180 liters of blood per day. and 99% of the water from this blood is reabsorbed, and only 1 to 1.5 liters is put out as urine. This is again based on the size of the molecule and how larger is the substance and what do we want to restrict. And reabsorption and secretion happens within the tubule. And we all know that potassium is very crucial for our body, so it is reabsorbed, and sodium and glucose is reabsorbed based on what body needs. Not only this, it also regulates in the acid base of the blood. It also helps in maintaining various inorganic ions, including sodium, potassium, calcium, and it also has excretory functions. We should not forget the endocrine functions of the kidney and metabolic functions. Endocrine functions mainly being controlling the blood pressure and vitamin D activation. CKD usually means there are fewer nephrons, that is fewer functioning nephrons available. So these fewer nephrons that disrupt the balance, urine volume may not change in the initial phase, and as I said earlier, reduced waste excretion may not be apparent till CKD is advanced. Of course, by the time people develop anemia and bone disease, it may be a little late. So how do we assess the functional status of the kidney? By definition, any chronic kidney disease means a GFR of, that is glomerular filtration rate, of less than 60 ml per minute, and this has to be persistent of more than 3 months. Sometimes you may see kidney damage, sometimes you may not see. Any GFR of less than 60 ml, which is persistent for more than 3 months, fall into the definition of chronic kidney disease. And this 3 months kidney damage, if it can be monitored, and if you recognize a pathological abnormality, or you see any proteinuria, or you see any structural abnormality, all of them fall into CKD. I'll come to this detail in my next slides. We in general practice assess what is called as eGFR. eGFR is basically estimated GFR, which estimates the glomerular function rate. It is not routinely measured in most of the clinical setups. That's the reason estimated GFR is taken as a standard practice. Nowadays, most of the labs give estimated GFR. So what is this GFR? GFR is basically whatever cardiac output you have, 6 liters per minute, almost 20% of this goes to the kidney. That makes it 1.2 liters. And out of this, 50% is plasma, that is 600 ml per minute is done every minute. So if you look at filtration fraction, that is 20% of this will lead to 120 ml per minute of glomerular filtration rate. This is the normal glomerular filtration rate. The range is between 80 to 120 ml. So what we measure is the measured GFR. What we are looking at in day-to-day practice is what is called as estimated GFR. The estimated GFR estimates the measured GFR. This is actually a good estimate to look at the risk of kidney function deterioration. There are also various other ways of looking at kidney function deterioration. So as you can see in this picture, by the time you pick up a deteriorating kidney function, the kidney function would have lost almost 50%. 50% kidney function is lost to see the creatinine jump from 1 to 2. So that means by the time we recognize creatinine 3, 4, already almost 75 to 80% of kidney function is lost. That's the reason we need to pick them up early in this phase where there is very early loss in GFR and prevent further progression. So I'll give you the example of these two individuals. One is an elderly lady. The other one is very active sportsman, very muscular. Creatinine 1.36. What does this mean? So if you look at GFR, this elderly lady, the GFR comes between anywhere 30 to 40. But this gentleman who is very muscular, his GFR with a creatinine 1.36, that is estimated GFR, comes to around 80 to 100 ml per minute, which is normal. So there are various equations right from CG formula, MDRD. The current recent one is what is called a CKD EPA equation, which is actually a little simpler one. You need not calculate, you can feed into the system and automatically the computer will give the estimated GFR, which is now the standard practice by most of the labs. There is another one, cystatin C, which is not a common practice to use. Where do we do this testing in individuals? One is the high-risk individuals, like anybody with long-term diabetes, hypertension, cardiac disease, or if they have any structural abnormalities, and of course, if there is any hereditary kidney disease. So the basic after GFR is looking at proteinuria. So what do we mean by proteinuria? Proteinuria could be a milder one, that is albumin excretion, which is normally looked at as ACR, albumin creatinine ratio, and PCR, that is protein creatinine ratio. I'll come to this in my next slides. We need to identify CKD in these individuals. One is to look for GFR, the other one is to look for proteinuria. So if you look at renal risk of these two individuals, though the GFR is low in this lady, it is probably acceptable for her age. And if you look at the same person with proteinuria, though his GFR is good, his proteinuria is more. So he has higher risk of developing progressive kidney disease. This old lady, though she has GFR little lower, she may not have renal failure in her lifetime. We need to manage her other cardiovascular risks. So cardiovascular risk is very high in CKD population, especially with proteinuria. There is a lot of data to show if you have microalbuminuria, you may develop cardiac problems, heart attacks, and things like that. So as I mentioned earlier, many times you may see low GFR, but if there is no other risk, they may go through their lifetime and they may not need any dialysis. But if you see earlier, people with proteinuria, younger people, they may progress to develop end-stage renal disease. These are the people whom we want to pick up and treat them earlier. How do we pick up? By the simpler formula called CKD EPI, which is calculated by these formula. There is no need to remember this. It is available in most of the apps. I'll come to that. So this is most standard one, which is almost equivalent to MDRD, which is well validated. So many times, as I mentioned, creatinine alone may not be sufficient. It also depends on what is the muscle mass of the individual, what is the medication he is taking, what are the dietary supplements he is taking. All these influence creatinine. And as of now, we have only creatinine to estimate GFR. So that's the reason many times we may rarely look at measured GFR in people like who are donating, or if you are looking at dose modifications. In day-to-day practice, we don't measure GFR. eGFR, that is estimated GFR, is good enough. Many times, GFR is given by these normal values depending on the various age groups, and we need to classify them based on the GFR levels. As I mentioned, this is available by the formulas. It is available in the app. I commonly use what is called as QX, which all of you can download. And if you enter the gender of the person, age of the person, and creatinine, automatically GFR is generated. The most common cause of kidney disease is diabetes and hypertension. How do we explain this to the patient? So we need to show them this chart. You can show saying if you are in green, if your GFR is more than 60, you are normal. If GFR is less than 60, you are in danger zone, and red meaning kidney is completely failed. So we need to screen these people annually. What do we screen? To begin with, if GFR is normal, look for albuminuria. Sometimes there can be transient. So look for any transient cause of albuminuria, like there should not be any infection, no congestive heart failures. In these situations, if you look at proteinuria and identify proteinuria, we can prevent and identify the high-risk individuals. We need to also consider if there are any other causes for chronic kidney disease. There are still a lot of gaps. Many people may not identify the chronic kidney disease. That's the reason staging has come. So what do we mean by CKD? As mentioned by Hippocrates, when you start seeing bubbles in the urine, that is the time when we need to look for proteinuria and albuminuria. So CKD definition I already mentioned. So whenever there is low GFR with proteinuria with associated abnormalities either in the structure or functioning of the kidney, they fall into CKD. And if it is persistent more than 3 months, that's when we classify them as CKD. Urine albumin is a significant good marker which can be used in diabetic population or high risk population to screen them on a regular basis. So what do we mean by albuminuria? The first and foremost is albumin creatinine ratio, or ACR or MCR, which is called as in common day-to-day practice. This is quite commonly used in diabetics, which is the earliest indicator of kidney disease. If this is picked up, then it can be treated appropriately. As proteinuria increases, we also look at protein creatinine ratio and gross proteinuria or nephrotic proteinuria. Why do we see this protein? That is the indicator of glomerular filtration barrier damage. That's the reason we need to pick it up early. The risk factors are diabetes, hypertension, smoking. I won't go into this. That's not the topic of my today's talk. So albumin creatinine ratio, if it is more than 30, that means it is abnormal. How do we explain this to the patient? We can tell them normally urine doesn't allow protein to come into the urine. If you start seeing bubbles or protein in urine, that is abnormal and that has to be picked up early. So this is classified by KDIGO as shown in this chart. When you have normal or good GFR, they are in the green zone. If you start developing proteinuria, which is now classified as moderately increased or severely increased, earlier it used to be called as microalbuminuria and macroalbuminuria. This is to make simple things. So if you are in yellow zone, you are already getting into the discomfort zone. So you need to look at this, treat them appropriately and try to bring them back to the green zone. Red zone meaning already there is severe compromise and GFR has dropped to less than 30 ml. We need to also look at trends of GFR. If the progression is slower, then there is nothing to worry. If there is rapid decline, we have to be careful and see if we can correct it appropriately. It also applies to the albumin creatine ratio. And whenever there is GFR less than 60, why is it important? We have to be very careful with whatever drugs we use, and also we need to be careful with cardiac risk. So whenever there is GFR of less than 60, that's the time it puts everybody at risk of all-cause mortality and also cardiac mortality. That's the reason we need to stage CKD and pick it up early and treat appropriately. The CKD is staged right from 90 ml GFR to 15 ml, less than 15 being stage 5 CKD. The stage 3 is again split into 45 to 60 and 30 to 45. This is again to explain why should we risk stratify, so that anybody is less than 60 ml GFR with gross proteinuria, they are in the danger zone and it can help in prognosticating the CKD. Albuminuria criteria I've already mentioned, more than 30 and more than 300. That is abnormal. This indicates that the kidney is progressing. The recent classification of this is called as CGA classification. That is the cause of CKD, GFR category and albuminuria category. That gives us a proper classification and staging of CKD, where we can look at chronic damage to the kidney and take appropriate actions. Also, we need to look at how fast is the kidney progressing and assess the GFR and albuminuria annually, and if needed, we can also do more frequently whenever there is significant higher risk. This is the table which shows how frequently we should monitor. In the earlier stages, once annually, in later stages, twice and thrice, depending on the progression. This is again to show CVD CKD complex, and there are some errors in GFR which we need to keep in mind, like drugs can interact and muscle mass. There are special formulas for pediatric GFR, which is a separate group as such. It is called as Schwartz formula. It is available on the net. I won't go into the details. There are some strengths and limitations of GFR. That's the reason we sometimes rarely use measured GFR with the help of nuclear imaging and 24-hour urine creatinine and creatinine clearance. So when do we refer a patient to a specialist? Whenever they are in the yellow and orange zone, that's the time probably you should monitor and consider referring to a specialist to prevent further progression. Monitoring has to be done on regular basis at all levels of GFR. And whenever there is rapid progression, more than 5 ml per minute, that's the time we have to be more careful in preventing further progression. So why should we bother about this monitoring? Definitely, if we pick it up early, we'll delay the progression.
Dr. Vishwanath, we'll request you to give concluding remarks because we're crossing the limit.
To summarize, chronic kidney disease, we need to screen them appropriately for proteinuria and GFR, diagnose them early so that we pick up early proteinuria and delay the onset and progression and prevent further complications. To conclude, early detection of CKD is very crucial. Appropriate staging helps in risk stratification. Staging also helps in prognostication and planning the treatment. We also need to be aware of reversible causes, and this helps primary care physicians to treat and refer on a timely manner. Thank you very much. Thank you very much.
Dr. Ashokan, sir, you're on mute.
Dr. Ashokan, you're on mute. You have to unmute.
Sorry for that.
Yeah, now you're no problem.
Thank you. We move on to the next topic, diet in kidney disease, dispel misconceptions. We have Dr. Arpita Roy. She is a postgraduate in general medicine, DNB and DM nephrology, and professor and head of the Department of Nephrology in IPGMR in Kolkata, joint director, Regional Organ and Tissue Transplantation Organization. She is the vice president of Indian Society of Nephrology and Apex Technical Committee member of NOTO. She is also in the editorial board member of the Indian Journal of Nephrology. She has published more than 60 papers in multiple journals, national and international. Over to you, Professor Dr. Arpita Roy.
Thank you for your kind introduction. And I'm really thankful to IMA for creating such an interface with the nephrologist on the eve of the kidney day. That, just a minute, I'll share and engage me in this talk in the interface on the eve of the kidney day, where we are subserving the slogan of bridging the knowledge gap in kidney care. Thank you, IMA Kidneycon organizing team, for giving me this opportunity. Now, respected chairpersons and other dignitaries, I'm going to start, and at tandem with my previous speaker, I start with this GFR and albuminuria stratification chart, which is very important in diagnosis and also important in prescribing and counseling about diet, as with deteriorating GFR, your diet counseling changes, and with albumin creatinine ratio rise, there is increased rise, and there are some diseases, and there are some diseases like hypertension, diabetes, nephrotic syndrome, where you need to modify your prescription according to the native kidney disease present. So this chart, if you include in your smartphone app as a GFR prescriber, is very helpful in nutrition counseling, and also identifying the high proteinuria patients and the native kidney disease as well, so that you can modify diet prescription. Now, why do we need diet therapy in CKD? Because we want to maintain a good nutritional status, slow progression, and to treat complications. Most of the time, physicians see patients much earlier than us. And as Dr. Bishwanath highlighted, that we may see a relatively normal creatinine, but altered GFR, contrary to the normal belief that 1.2, 1.3 creatinine is not that high. But in some patients that may be quite high, and with high proteinuria, they come in the higher risk category, for whom slowing progression of CKD becomes very important. What are the ways you can control? Controlling blood pressure, and the dietary prescription relates to reducing the sodium intake, reducing protein intake, and managing diabetes in a multi-pronged way. It's not only sugar control, but lipid control and many other things which we will be revealing through the presentation. But as eGFR declines, we see complications as well. The complications like malnutrition, because the patient becomes anorexic, unwilling to take food, and cannot tolerate many foods. The metabolic acidosis, as the acid generation exceeds base generation, and that gets accumulated and triggers number of complement activation, inflammatory milieu, and activation of the ET1 and RAS, and contributing to progression of CKD. We will see hyperkalemia, the mineral imbalance and bone disorder, which is just not calcium and phosphorus. And here, prescribing calcium without taking note of the load sometimes may give you a pain of creating an iatrogenic calcium load, hypercalcemia, which we are identifying to be an important risk factor, along with hyperphosphatemia, regarding a new risk factor with the CKD population. Anemia needs to be addressed and cardiovascular disease, because the outcome of CKD is very much coupled with cardiovascular disease. Most of the patients do not progress to ESRD, but dies in the stage 4 and 3 due to cardiovascular insult. So KDOCI comes out time to time with nutritional advices as new knowledge repository is built up, and the last one is in 2022. And one thing I may advise, a strict guideline following should be improved by patient-centered care, because guideline gives you a fixed patient picture, which is not actually the clinical practice picture. You may not get that stable patient to introduce all the guideline things there. Remember these while implementing the guidelines. So you require a constant renal dietitian support for a patient-centered care, and this is very few available in very few institutes. So you yourself become some degree of renal dietitian, nutritionist, and that's why we need to talk about this. And after prescription, you can see this type of reaction in your patient's face, which really hinders with the adherence to the diet, which is also a practical clinical problem. And lots of myths are prevailing in the area. So sodium restriction, there is no myth in it. Restrict it to 2 grams per day, no rock salt, no fried salt, nothing. All the salts do serve the same, and many times the LONA gives actually potassium load in terms of potassium chloride, and BP modification dependent effect is strongest. We have seen many trials which have told about sodium restriction and benefit of lowering 7 to 8 millimeter of mercury blood pressure. I'm not discussing a lot about this BP independent effect, but these are the pathways through which BP independent renal and cardiovascular damages can be there. This I was talking about how the acidosis, acid generation, and protein catabolism with negative nitrogen balance contributes to acidosis and activates all these pathways, contributing to systemic and inflammation, hormonal resistance, and ultimately causing inflammation, protein catabolism, malnutrition. So guidance about protein and energy intake is crucial. And this is the area where misconceptions are most prevalent, because all the guidelines are formulated by the Western bodies, and Western body people take around 1.3 gram protein per day, mostly animal protein. Whereas in India, we have a lot of vegetarians who do not take adequate protein, and average Indian protein intake in diet is only 0.6 gram, which is already restricted. So protein restriction, what the guideline says is when the CKD patients are not on dialysis and without diabetes. Remember, these patients are metabolically stable. So these are not the patient you see sick in your hospital, admitted and unstable. They're under close clinical supervision. You should go for protein restriction with or without keto acid analog. I will come to this part of the end of my talk, and to reduce the end stage kidney disease and improve quality of life. We usually prescribe a low protein diet, and I told that usual Indian diet has this much protein. So you need to modify the dietary protein rather than to restrict dietary protein. A very low protein diet can be introduced with 0.2 to 0.43 that had evidence of benefit. I'll show that with additional keto and amino acid analogs. With diabetes and not on dialysis, the recommendation changes. You see, with diabetes, there is a lot of proteinuria, and restricting protein to less than 0.6 may be detrimental to introduce a protein energy wasting, which I'll show later. 0.6 to 0.8 gram is the recommendation, and my request is don't go below it. The albuminuric diabetic patient, when are admitted with AKI, low in albumin, we all are infusing albumins liters and liters to keep them at a standard level. That will not be there if we do take care in prescribing protein to diabetic CKDs. When they go into dialysis, the recommendation changes. In dialysis, there is protein loss issues. There is we are taking out the acid and metabolic waste products. So protein intake can be increased to 1.2, and diabetic patients should be considered for glycemic control even in dialysis, even during dialysis. And this much is the recommendation in stable metabolic state. When the dialysis patients come to you with infection and other causes, catabolic reason, you may see more catabolism and more protein, more energy loss. You can go for, even in acute setting, you can go for, and sometimes during peritoneal dialysis where protein loss is relatively more, you can go for even higher, 1.4 to 1.7 gram per day. And then energy intake should be assured that 25 to 35 kilocalorie per kg body weight energy is provided to the patient. So whenever you refer to your dietitian, please mention the energy that the patient should get according to the status of activity, age, and everything else. So protein energy wasting is an important area in CKD. So where you will find that in advanced stages, there is more malnutrition, hypercatabolism, uremic toxin related pathway of inflammation, recruitment. So they are in need of adequate energy supplementation and proper addressing the issue properly, so that they do not progress to dialysis with severe hypoalbuminemia. The target albumin is close to 3.8 to prevent protein energy wasting, because when the patient goes to dialysis, we have identified through many studies that hypoalbuminemia while they're entering in dialysis is an important mortality and morbidity risk factor in this population. So take care to prevent protein energy malnutrition in advanced CKD patient. In up to 40% CRF population, multifactorial protein energy malnutrition is seen in Western population. I'm sure in Indian population, it's going to hit a number of 60–70%, which we see in our everyday practice. And these are the reasons which contribute to malnutrition. They can't take well. We are imposing a lot of diet restriction. There is loss of nutrients in dialysate, concurrent illness and hospitalizations come and go, increased inflammatory and catabolic milieu they suffer from. There is chronic blood loss because of the uremic gastritis and other causes of during dialysis, the tubing, the blood sampling, everything is there. Acidosis is there, I mentioned, and sometimes the aluminum toxic alumination, which is no more there because of we do not prescribe any more aluminum hydroxide, and water doesn't contain aluminum as toxin. So endocrine disorders are also you need to remember. So provision of a renal diet that limits protein, salt, nutrition, potassium, phosphorus, fluid, everything becomes really a burden for the patient. So to check adherence, to check the nutrition parameter, ask for a frequent visit with you or your renal dietitian, whoever is counseling the diet for the patient. So what type of protein we should give? We would like to include the high biological value protein because of good availability of the essential amino acid, which our body doesn't manufacture. And those are available mostly in the animal protein like eggs, fish, poultry, meat, and dairy products. If I cannot make my veg population to take the fish and poultry and meat product, and sometimes these are also not very advisable for advanced non-dialysis patients. So at least encourage them to take eggs, which can give them good amino acids. And particular protein type is not recommended in the guideline, that plant versus animal, which is going to be the best. So Mediterranean or DASH diet, that's good. We all know that emphasizes salt limitation and preference for plant-based or unprocessed food, because a high potassium can prevent a lot of problems, 4.7 gram, 4.5 to 4.7 gram per day, but this much can cause hyperkalemia in your CKD patients. So take care of prescribing fruits, veggies which are still low in potassium, and if you need to give them adequately, you may need to couple them with potassium binder. The newer potassium binders are on board, but remember, your patient's pocket that may not bear the cost of the potassium binder, so that you can be liberal enough to recommend these diets. So it's a balance in clinical practice that we from LMIC countries we do every day, and we are in habit of doing that. Remember that gut-kidney axis causes an intestinal dysbiosis. I'm not going again into details because of time restriction, and that can cause a persistent inflammatory milieu. And for this, people are prescribing right and left probiotics, for which still not, there has been no great evidence-based recommendation, and these are really costly. And this is the chart. This may be available on NET and many other sources. I'm not going to detail, but I'm telling you that stage 1 to 4 receives one type of recommendation, whereas a stage 5 on hemodialysis, a different recommendation. Stage 5 peritoneal different, and transplant is close to stage 1 and 4, but not always the same. They enjoy much more liberal advantage in terms of fluid intake. Now come to the keto analog supplemented vegetarian, very low protein diet, which we would all like to prescribe. Because in CKD progression, I'm mentioning so much about the inflammatory milieu, and the study by Lilian Garmenta et al., which has gone strongly in recommending the diet, has shown that at least inflammatory milieu has a significant improvement, if not the other factors, by taking this VLPD diet when she compared it with the low protein diet. But can't see which are the patients that she included in her trial. She included non-diabetic adults with stable eGFR. So diabetic population, unstable patients, they may not be candidates of these. And the proteinuria when in excess, like nephrotic syndrome patient excreting 15 gram, 14 gram, 10 gram protein, should have additional protein replacement, at least 5 gram, not the restriction of VLPD diet. And after 3 months, the patients were randomized to keto diet, and just see how many keto analogs per day, 1 capsule per 5 kg. So a 60 kg individual is likely to get 12 caps. Again, the cost of this, I am in a public sector hospital and hardly my patients can provide that. So depending on the patient, we may go for this recommendation, and non-diabetic patients are likely to be benefited by this, not the diabetic patient, which constitute at least 50% of our CKD population. So dietary phosphate intake is another area where hyperphosphatemia is an important non-traditional cardiovascular risk factor implicated in pathogenesis of vascular calcification. Prevention and correction of hyperphosphatemia through reducing dietary phosphate burden is an important thing. These are the papers which has shown the benefit of low phosphate diet. I'm not going in detail again because of time restriction, and decreased phosphate intake with protein with low phosphate. Eggs are the good examples, and the cheese burst pizza is the worst. So prevention and treatment of protein energy wasting. Potassium in high amount is good, but not good for our patient. There is risk of hyperkalemia, and you just check the potassium chart before counseling your patient about the diet. The take-home message is, remember protein energy wasting, frailty and sarcopenia, because large of your population is now elderly CKDs. They have more diabetes, cardiovascular comorbidity, and frailty is an important issue where you cannot compromise nutrition. Preservation of the nutritional status, muscle mass, and function is not only a matter of nutrient intake, but also of the metabolic status, which the most natural stimuli to anabolic stimuli is the physical exercise, and do do give emphasis on that. After that, I thank you for your opportunity to allow me to discuss all these things, which are very important dialogues, I feel. Thank you all. I thank the IMA Kidneycon technical team and organizing committee, particularly Garima, for perfect coordination. A nice conference going on. Thank you all.
Thank you. Thank you.
Thank you so much, ma'am. I now take an opportunity to invite Dr. Neeru Agarwal, madam, to the dais. Dr. Rana was unable to join us, so I will introduce Dr. Neeru on his behalf. She's a senior director, nephrology at Max Vaishali Hospital, Vaishali, Ghaziabad in Delhi. She has over 25 years of experience in the field of nephrology and kidney transplant. She's been associated with Royal Perth Hospital, Australia, and Institute of Kidney Disease and Research Center at Ahmedabad and Batra Hospital in New Delhi. She's won several awards and accolades and appreciation in the respective fields of research. Over to you, ma'am. We would love to hear your talk, ma'am.
Good morning, everyone. I want to thank Dr. Garima, Dr. Kshitij, IMA organizing body, and all the members of the organizing team for this wonderful conference. I can smell the fragrance of community nephrology in this. IMA and nephrology coming together, I think they can make a lot of difference to the community for prevention of not only diabetes, but many other kidney diseases. So my topic is diabetic kidney disease and its medical management. So I'll go to the epidemiology part first, because it's a huge load of diabetes, not only in India, all over the world. So it's the leading cause of kidney disease in the world. So as per USRDS in 2016, diabetes was the most frequent primary diagnosis, and diabetic kidney disease was very, very frequent. In China also, the diabetic kidney disease has taken over glomerulonephritis as the most prevalent cause of end-stage renal disease. The prevalence is between 40 to 60% in all the diabetic patients. As per Indian scenario, the Indian CKD registry, if you see, diabetes is one of the leading causes of chronic kidney disease. Diabetes is responsible for 4 million deaths worldwide in a study done in 2017. 50% of the patients were below the age of 60 years. You know, all working people below 16 years, they died of diabetes and its complications. And mainly 50% of them were related to increased risk for cardiovascular and other diseases. So now what we see is type 2 diabetes is seen more often in the developing countries. 4 out of 5 people with diabetes now live in low and middle income countries. So the projected data, all that we see is from the developed world. And in the developing country like India, the load of diabetes is increasing day by day. And it's likely to increase further in next 2 decades. If you see this graph, if you can see that in Africa, 109%, in Middle East, North Africa, 96%, in Southeast Asia, 70%. So there is going to be a huge rise in diabetic kidney disease population. So in Southeast Asia, high mortality is noted from diabetes, mainly between the age of 50 and 60 years. And if you see the patients who have DKD, diabetic kidney disease, there is a reduction in lifespan of more than a decade or 10 years. So reduction in the lifespan of 10 years is a huge difference. So up to 60% of Asian population of diabetes have albuminuria. That means the data we read from the developed world is that 30 to 40% of the patients have diabetic kidney disease. But in Asian population, we see that 60% of the patients have albuminuria, that is, they have diabetic kidney disease. And it imposes a huge financial burden because of DKD, not only in the West, also in India. This is a study by Muthu Jayaraman and V. Vishwanathan. It shows that cost of treatment was much higher in diabetic patients having end-stage renal disease as compared to non-diabetic ESRD patients. And over 2 years, patients who are on dialysis, the cost of treatment is much higher than those patients who had their transplants. So my idea of describing all this to let you know that this is a huge load of diabetes in the Indian population is going to happen in next 20 years. And you as clinicians who come across these patients as the first contact, you have to realize this fact from the beginning so that we could prevent the diabetic kidney disease in later part. So the presentation of diabetic kidney disease. Classical features of diabetic kidney disease are observed in about 60% of patients. They have normal sized kidneys despite having end-stage kidney disease. The proteinuria is more than 1 gram in 24 hours. They may or may not have retinopathy. Type 1 diabetic patients have retinopathy after 5 years of diabetes, but type 2 diabetic patients cannot have retinopathy at the time of diagnosis, but they may have diabetic kidney disease at the time of diagnosis of diabetes. So all the patients who present to you with diabetes with type 2 should be evaluated for diabetic kidney disease. Sometimes they may have atypical presentations, like 13% can have ischemic nephropathy, 27% may have primary renal disease besides having diabetes, like IgA nephropathy, membranous GN, FSGS, SLE, etc. Then, unfortunately, some patients of diabetes can have irreversible AKI leading to chronic kidney disease, like patients who are on prolonged NSAID intake, who are having cardiac events, or who had septicemia and shock, leading to AKI and further leading to CKD. So many patients also lose the clinical manifestations of overdiabetes due to increased half-life of insulin in CKD. They may present to you that, Doctor, I had diabetes 4 or 5 years back, but now my sugar values are normal. I don't need any medication. Probably this is an alarm bell should ring in your mind. Means that this patient might be having chronic kidney disease due to diabetes, and he should be evaluated in detail. Obesity is one of the major risk factors for cardiovascular disease and has a negative influence on renal function. Why? Because obese individuals have large kidneys. There is extra stress on the kidneys due to glomerular hyperfiltration. So evolution of diabetic kidney disease. First stage is hyperfiltration, then microalbuminuria, macroalbuminuria, and ESRD. This has already been described by Dr. Vishwanath and Dr. Arpita Chaudhary in detail. This is a very, very important slide. It has 3 parts in it. And we have to deal as IMA body. All the clinicians have to deal with these 3 parts: primary prevention, secondary prevention, and tertiary prevention. When the patient comes to you, you are the first contact and you are responsible for primary prevention. So at this stage, patient only has diabetes, might be having high blood pressure, but microalbuminuria is not there. So here comes your role when you have to prevent the development of microalbuminuria. Then comes the secondary prevention stage. And if you see, if a person's diabetes is not well controlled, blood pressure is not well controlled, then the nephropathy develops, microalbuminuria appears, and this is the stage of hyperfiltration. Some patients, they come to us, they say, my creatinine has come down from 1 to 0.7, and they are very happy about it. Diabetes is uncontrolled. This is an alarming sign. If this is happening, it means the person is developing diabetic nephropathy, and his diabetes and BP should be well controlled. ACE or ARB should be started to revert the changes. And as nephrologists, we see the tertiary prevention type of patients. Their creatinine has risen, albuminuria has become overt, it is rising, and now our job is to retard the progression of the kidney disease. we slow down the process. But we, as a human being or as a clinician, I don't think all of us are doing any justice to the patient, because had we stopped it at primary prevention, we could have avoided many of the complications related to diabetes. And the lifespan of the patient and effect on the working of the workplace of the family of the nation, all are affected with this. So diabetes is associated with many extrarenal, microvascular and macrovascular complications. Diabetic retinopathy is one of them. In type 1 diabetes, it appears after 5 years of diabetes, and afterwards all these patients should be evaluated for diabetic retinopathy. But in type 2 diabetes, only 50 to 60% of the patients have diabetic retinopathy, but they may still have proteinuria. Therefore, all the patients who have diabetic nephropathy should be evaluated for diabetic retinopathy. Annual checkup is a must, because retinopathy tends to progress faster in diabetic nephropathy patients. Amongst the macrovascular complications, stroke, coronary heart disease, and peripheral vascular disease, these are 5 times more frequent in diabetic patients as compared to the diabetic patients not having renal failure. So the survival in patients with diabetic kidney disease, mortality is very high, both in type 1 and type 2 diabetes. If the person has proteinuria, the risk for mortality increases by 20 to 200 folds. The major increase in risk begins with albuminuria, as already been described by previous speakers. The albuminuria is ominous. The presence of albuminuria reflects generalized endothelial cell dysfunction. It promotes atherosclerosis. This is the histology picture of the diabetic kidneys, in which you can see this is mesangial sclerosis has already set in, mesangial fibrosis. That means the kidneys are damaging over the time. So now we come to diagnosis and differential diagnosis. Early diagnosis of DKD is by detection of proteinuria. Hypertension and retinopathy may be present at the time of diagnosis of diabetic kidney disease. So what do? We should measure urine albumin or protein. We should measure serum creatinine, estimate the GFR, and measure the blood pressure. These are very small things which we can always do in our clinic, in our practice. And eye examination is must. So spot urine for protein creatinine ratio or albumin creatinine ratio is nowadays preferred, because 24-hour urine sample collection is cumbersome and it may not be accurate because of the dropout of some samples. So second void morning urine sample is ideal for albumin creatinine ratio estimation. Normal value is less than 20 microgram per ml. So these have already been described by previous speakers. Normal albumin urea is less than 30 milligram per day. Micro is 30 to 300, and overt nephropathy, it is more than 300 milligram per day. So when to begin primary prevention as a clinician? So as per KDIGO guidelines, the spot urine albumin to creatinine ratio or protein to creatinine ratio should be done annually. So when the patient comes to you for diabetic control, every year you should get his protein creatinine ratio done. At the same time, their ophthalmologic examination for diabetic retinopathy should also be done, which is both of these two go hand in hand. So to halt the initial progression, it is important to prevent progressive chronic kidney disease. In general, the treatment principles for established diabetic kidney disease and prevention of diabetic kidney disease, they are similar. So what as nephrologists we do, you do as clinicians. So strict blood pressure and good glycemic control is most important. Good glycemic control decreases the risk for albuminuria and impaired GFR. Early glycemic control is important in the primary prevention of microvascular complications and macrovascular complications I just described. So how much should be the HbA1c values? It should be below 7% for most patients with type 1 and type 2 diabetes in early stages. But if a person is frail or elderly, has cardiovascular problems, or who is susceptible to hypoglycemic episodes, then HbA1c goal should be set at 8%. Tight glycemic control at the onset of diabetes in patients with few comorbidities should be used as a preventive strategy, and this is by ADA guidelines. Less stringent control in patients with more advanced comorbidities, that means they are similar by ADA as well as KDOQI. What should be the BP target? The blood pressure should be less than 140/90 for all diabetic patients and should be less than 130/80 for patients who have CKD or who have microalbuminuria positive in their urine. The first line of drugs are ACE inhibitors or ARBs. If you see this graph, you can see the patients who had diastolic pressure less than 85, the progression of renal failure was much less as compared to the patient who had more than 85. Similarly, the patients who had pulse pressure of less than 57.5, the progression of proteinuria was less as compared to the patient who have more than 57.5. So, few words about ACE inhibitors and ARBs. Serum creatine concentration may increase up to 30% in proteinuric patients with renal impairment after you start a RAS blocker. But if it is only up to 30%, you should continue with these ACE inhibitors or ARBs because they provide long-term protection. But if the rise is more than 30%, then the possibility of renal artery stenosis may be there. And in this situation, you may have to withdraw these drugs or you may have to reduce it to minimum. So many times it has been seen that aggressive dose increments of ACE inhibitors and ARBs along with diuretics can precipitate AKI. So you should be careful while using medications. Everything should be monitored. So besides good glycemic and BP control, there should be aggressive lipid lowering, lifestyle modifications, adherence to low protein and low sodium diet has already been described by Dr. Arpita Chaudhary. Exercise, if a person is obese, weight loss is mandatory, and stop smoking because it is going to aggravate the atherosclerosis. So all these are beneficial and likely to improve renal and cardiovascular outcomes. Now, few points about oral hypoglycemic agents, the newer drugs, SGLT2 inhibitors and GLP-1 analogs. These you must be knowing already by now because they have already been approved and they are very much in the market. Empagliflozin, dapagliflozin, and canagliflozin. They are now widely available. And how do they work? It has been seen that sometimes patients are already on ACE inhibitors and ARBs. They continue to have proteinuria and their CKD progresses. These are the patients adding SGLT2 inhibitor might help. So if you see this picture, you can see these SGLT2 is an enzyme which is responsible for absorption of glucose and sodium in the proximal tubule. So by inhibiting this absorption, SGLT2 inhibitors decrease the sodium and glucose reabsorption, and they increase the afferent arteriolar vasoconstriction, so reduce the filtration fraction. At the same time, they reduce the obesity by causing glycosuria. They increase the erythropoietin levels in the blood, therefore they help in correction of anemia. They increase the iron utilization and reduce the inflammation in the body, and they are good for the heart also. So initially, all these drugs, most of the people say they should be used where GFR is more than 30 ml per minute. But there is a trial, DAPA-CKD, that has come. In this, SGLT2 inhibitor has been used in diabetic as well as non-diabetic patients, and the benefit has been obtained, and therefore people are now using in congestive cardiac failure patients who have cardiac dysfunction without having diabetes. And the trial shows that dapagliflozin had a 50% lower risk of decline in GFR, ESRD progression, or death from renal or cardiovascular causes. GLP-1 agonist. If still the patient's blood sugar is not controlled, the macro or microvascular complications are there, then these are the newer group of drugs where if they started, they reduce the incidence of new onset of albuminuria, they reduce the doubling of serum creatinine, reduce the ESKD progression, and reduce the kidney death due to kidney disease. So if additional glucose lowering therapy is required in a patient with DKD, despite initial glucose lowering therapy, then start GLP-1 receptor agonist because they also reduce the rate of cardiovascular disease. So a point comes when to refer to the nephrologist. So one, patient has advanced chronic kidney disease like stage 4 or 5. Patient has consistent proteinuria more than 300 microgram per gram. Person has hematuria, rapid decline in GFR, that is creatinine is rapidly rising. Patient has uncontrolled hypertension, hereditary kidney disease, or other condition like renal artery stenosis, nephrolithiasis, persistent abnormalities of potassium. Some patients continue to have high potassium and you cannot use ACE inhibitors in them. So from my side, the take-home message is good glycemic control is a must, good blood pressure control. When the patient comes to you, annual evaluation for microalbuminuria and diabetic retinopathy is a must. Lifestyle modification is important. Exercise, weight reduction, aggressive lipid lowering, and a healthy, balanced diet. Thank you.
Thank you. Thank you, Dr. Neeru ma'am. I request you to please join us on the dais. I request Dr. Anil to please introduce our next speaker.
It's my proud privilege to introduce the next speaker, Dr. Manoj Singhal, whom I know for nearly 2.5 decades. He is a Senior Director Nephrology and Kidney Transplant Medicine, Max Hospital, Vaishali. He is a medical graduate from KGMC, Lucknow, and DM in DNB and DM in nephrology from SGPGI, Lucknow. He is a fellow in Clinical Nephrology University Healthcare Network, Toronto, MBA Healthcare Administration, Delhi University, Fellowship in Indian Society of Nephrology, a Program Director of DNB Nephrology since 2011. He has published more than 60 papers in international and national journals and authored 10 chapters in various textbooks. Now I invite Dr. Manoj Singhal to talk on the subject, renal replacement therapy.
Am I visible?
Yes, sir, you're visible and audible. Good to go.
Okay. Thank you. Thank you. Thank you, Akash, for this flattening introduction. And let me take this opportunity to thank IMA and Garima Agarwal in particular for inviting me for this talk. So what I will talk today is about renal replacement therapies. When the patient reached the advanced stage of kidney disease, what are the options available? What are the problems associated with these therapies? And what is the outcome of these patients who start renal replacement therapy? Just a word about burden of chronic kidney disease. We all know it's a global public health problem, not just because there is a huge number of patients, but also because there is a huge cost involved in the management of these patients. It is the 12th cause of death and 17th cause of disability. And let me tell you, this is an underestimate because most of the patients who have chronic kidney disease, they die of cardiovascular disease before they reach end-stage kidney disease and require renal replacement therapies. In India, there are no registries, so we do not have exact data. There's one study conducted in Bhopal, which has estimated an incidence of ESRD to be somewhere between 150 to 230 patients per million population. So with that estimate, almost 2 lakh patients develop renal replacement, end-stage kidney disease, and require renal replacement therapy every year. But unfortunately, 2/3 of these patients do not start dialysis and they die without receiving dialysis. And this was an estimate in 2010. So let me just give you an example of one of our patients. This is a patient, a 34-year-old gentleman. He presented with marked fatigue, weakness, anorexia after an acute flu-like illness. And to his surprise, he was detected to have chronic kidney disease and hypertension. His hemoglobin was 7.4 gram and his creatinine was 23. So he was immediately started on hemodialysis through internal jugular catheter. He used to work in MTNL. His wife was homemaker. He had 2 kids, 8 years and 5 years. We discussed the option of kidney transplant at that point of time. His blood group was O positive, but there was no compatible donor in the family. AV vascular fistula was made and he was advised for thrice a week dialysis, but he agreed for twice a week dialysis and continued dialysis twice a week. His other medical treatment was optimized and he was vaccinated. So this patient has presented with advanced renal failure. So in absence of methods of screening, we miss this opportunity of early detection of chronic kidney disease. Most of these patients, they present to the healthcare system with advanced kidney disease and need urgent starting of renal replacement therapy. And this is not a very uncommon scenario. According to the study done in Sanjay Gandhi PGI, almost 70% patients present to a healthcare system with such problems and require dialysis for life-threatening complications. So that we miss the opportunity to diagnose these patients, to treat them at early stage, and to prevent complications of kidney failure, which start at the early stages of renal failure. So what are the options available at this point of time? Obviously, the best treatment is kidney transplantation. As far as quality of life is concerned, longevity of life is concerned, and also cost effectiveness of the treatment is concerned. In India, most of the transplants are live donor kidney transplantation. This has an advantage because patients can go for transplant early. When they need dialysis, they can go for transplant. In fact, preemptive kidney transplantation can also be done without starting dialysis if the patient is aware that he has progressive kidney disease and there is a donor available in the family. Although at that time, ABO incompatible transplant was not available, but now if there is no compatible donor in the family, most of the centers are doing ABO incompatible transplant, or there is an option of paired kidney donation where we swap the kidneys between 2 pairs of donor and recipient. If there is no such option available, patient can also be listed for disease donor transplantation. The number of such transplant is progressively increasing every day. Patients where transplantation cannot be done for any reason, they can start dialysis. There are 2 options, hemodialysis and peritoneal dialysis, which is an option done at home. Not all patients are candidates for dialysis. Sometimes we see patients who are elderly, who have multiple comorbidities, they have almost bedridden, and at times the family decide to continue conservative treatment. And I completely agree with such decision, and we support such patients. We continue all the preventive measures to make them comfortable, to prevent complications, and let them live a dignified life, whatever life they have. When do we start kidney replacement therapy? Most of the people will agree we are guided by signs and symptoms. So when the patient has signs of symptoms of kidney failure, that's the time we start dialysis. These symptoms may be mild. For example, they may have problem with volume status, blood pressure control, deteriorating nutritional status, and at times they will just have mild cognitive impairment, which cannot be explained except for renal failure. And usually such symptoms correlate with a GFR of 5 to 10 ml per minute. So this is the time when we start dialysis, not just based on number, but if the patient has symptoms, we advise for dialysis. What type of dialysis they should choose, hemodialysis or peritoneal dialysis? This is mainly decided by comorbidities which the patient has. If the patient has had multiple abdominal surgeries in the past, we expect a lot of adhesions in the abdomen. So peritoneal dialysis is not a good option in such patients. Similarly, if the patient have multiple cardiovascular problems, heart failure, these patients are not good for home-based treatment. So they should be coming to in-center hemodialysis. So mainly it is guided by comorbidities which the patient has. Besides that, there is patient preference and their capability. Because to conduct home dialysis, they have to have reasonable dexterity of hand and vision. Also, they should have family and social support, which can help them to conduct dialysis. So all these factors will decide what type of modality is good for that particular patient. Distance from the dialysis center. Sometimes patient has to travel 200 or 500 kilometers just to get the dialysis. So these patients are good for home dialysis. Goal of care and quality of life. As I said, if the patient want independence, they are working full-time, or students who want to continue with their studies, these are the patients who are good with home-based dialysis. So they work throughout the day and they hook them to the dialysis machine in the night, get them dialyzed, and again go back to work in the daytime. So what type of lifestyle they're leading, that also decides which type of dialysis is good for the patient. Reimbursement strategies. Right now, hemodialysis is recognized as an outpatient treatment by most of the insurance agencies, whereas home-based peritoneal dialysis is not reimbursed. So even if patient wants to go for home dialysis, in the absence of reimbursement from insurance, they have to continue with hemodialysis. Outcomes, whether they are good on PD or hemodialysis, there is no conclusive data. Most of the data is retrospective and observational data with a lot of selection bias. They've not concentrated on quality of life or frailty, but in general, most of the studies have shown that the outcome is almost similar for hemodialysis and peritoneal dialysis. There is an initial survival advantage for peritoneal dialysis, but again, that is not very robust. And in patients who have kidney disease because of diabetes, in elderly patients, and in patients with multiple comorbidities, this advantage is lost. So more or less, the outcome is similar for hemodialysis and peritoneal dialysis. So the choice is basically guided by quality of life, patient and caregiver convenience, and the ability to travel to the dialysis center. So coming back to this, our patient, Mr. ABC, who continued to be on dialysis twice in a week, he became anuric within a year, and this is again not very uncommon. Most of the patients become anuric within 6 months or maximum 1 year after starting dialysis. So he used to have multiple visits to ER with accelerated hypertension and fluid overload, required emergency dialysis. He developed progressive anorexia, fatigue, and weight loss. We convinced him to start thrice-a-week dialysis, but initially he was very reluctant. But after multiple admissions, he agreed to do three dialysis per week, and he improved his nutritional status, became more compliant to fluid restriction and salt restriction, and continued on dialysis 3 times in a week. Subsequently, he developed hepatitis C infection after 6 years of dialysis. Initially, it was asymptomatic, and once these direct antiviral agents became available, he was treated for hepatitis C. He also developed acute coronary syndrome and required primary intervention for that. His ejection fraction dropped from 60 to 45%, but he remained clinically stable. So once the patient is on dialysis, the journey is not very smooth. There are multiple problems which can occur even during dialysis. And common one is cardiovascular disease, anemia and mineral bone disease, protein energy malnutrition, repeated infections, bioincompatibility and ongoing inflammation, and then depression, physical and cognitive impairment because of chronic disease. So coming to the cardiovascular disease, most of the patients who are on dialysis, they die of cardiovascular disease. And cardiovascular mortality in ESRD, if you see, the lower lines represent the general population, and the top line represent the patient who have end-stage kidney disease. So patients who have end-stage kidney disease, the cardiovascular mortality is 500 to 1,000 times higher than general population. The person at the age of 25 years has a risk of cardiovascular death, which is equivalent to 85-year-old individual in the general population. So most of the patients on dialysis, they die of cardiovascular disease. Almost 80% patients on dialysis have one or other comorbidities like heart failure, cardiac arrhythmias, or diabetes, and that correlates with the risk of death. If they have one of these comorbidities, the risk is at least 2 times higher. If they have 2 of these, the risk is around 2.5 to 3 times higher. And if they have all 3 comorbidities, the risk is 5 times higher as compared to person who does not have these comorbidities. Other problem is anemia, which is now very well controlled with erythropoietin widely available. Mineral bone disorders, it is a combination of lab abnormalities, abnormalities in the bone metabolism, and also vascular calcification. And this vascular calcification is harbinger of long-term outcome, high cardiovascular disease and mortality in these patients. So we control metabolic bone disease in all patients who are on maintenance dialysis. Main problem with these patients is malnutrition, which is quite rampant. The figure is 18 to 70%, but in India, most of the patients, almost 90% patients have protein energy wasting. You can look at this individual, he's 25-year-old man, requires dialysis, and you can count his bones. There is no muscle, no fat in this individual. He can't stand. So at this stage, no matter whatever you do to this individual, the outcome is going to be very bad. And this is the strongest predictor of mortality and morbidity in these patients. There are various factors which are responsible for protein malnutrition. And as I said, it is associated with increased hospitalization, poor quality of life, repeated infections, and high mortality in these patients. This is just to show the serum albumin, how it correlates with mortality. As the albumin go below 3.5, there is a exponential increase in mortality in these patients. Infections, again, is very common in these patients. Most of the infections are related to dialysis catheters. Tuberculosis is 7 to 10 times more common in these patients who are on dialysis. Mortality because of sepsis is 100 times higher, and death rate because of lung infection is almost 10 times in these patients. Hepatitis B, C used to be a problem in dialysis, but now with wide use of hepatitis B vaccination and availability of good medicines for viremia, for hepatitis C and B, we don't see such problem in dialysis now. The various factors responsible for infection in these patients, which are related to bacterial factors, host factors, and dialysis related, they have to go on dialysis, repeated puncture, exposure to blood. All these things increase the risk of infection in these patients. Then there are unphysiological effects of dialysis. Whenever the patient is exposed to dialysis membrane and dialysis fluid, it elicits the inflammatory response in these patients. And that inflammation correlates with accumulation of beta-2 microglobulin, which leads to amyloidosis in these patients. It impairs their nutritional status, increased susceptibility to infection, and loss of residual kidney function. As I said, most of the patients become anuric within 6 months to 1 year starting dialysis. But now we have good membranes which are widely available. We use ultra pure water for dialysis, and that has significantly decreased the amount of inflammation in these patients, have decreased these comorbidities in these patients. What is the outcome in these patients? What is the risk of death? Although dialysis prevents death from uremia, but the mortality in these patients is still very high. Only few cancers have mortality worse than dialysis. So patients on dialysis are at a very high risk of death, much more than the common cancers which we see. There has been an improvement in technology, and that has led to improvement in the death rate. In last 10 to 15 years, the death rate has gone down by almost 30%, but still it is much higher as compared to general population. What are the common causes of death in these patients? 50% death occur because of cardiovascular causes. So patients on dialysis, they die because of cardiovascular disease rather than dying of anything else. The second important cause is infections. They're more prone for infection, higher risk of death because of infection. So they succumb to infection. And the third, although in the Western world, withdrawal of dialysis is 10%, but in our situation, this is a study from South India where 48% patients stopped dialysis within 1 year and they died. Okay? So this is the first cause or very common cause of death in these patients. What are the risk factors for death? Again, just like in general population, increasing age, Now we see more and more elderly patients on dialysis, so they have a high risk of death. They have associated comorbid conditions. Almost 80% patients have heart disease, arrhythmias, and diabetes, so they have a very high risk of death. Underlying kidney disease, so patients who have kidney disease because of diabetes, atherosclerotic heart disease, they have a higher risk of death. Residual kidney function, once they become anuric, the risk of death is much more. Pre-dialysis care and nutrition. So if they have received adequate pre-dialysis care to prevent complications of kidney disease, maintenance of the nutritional status, that is a harbinger of good clinical outcome. And when this is denied to most of the patients, they have a very high risk of death. Then there are certain dialysis-related factors. Adequacy of dialysis. If the person gets good quality, adequate dialysis, the outcome is good in these patients. If we look at nutritional status, maintain good nutrition, again, the outcome is going to be good. Psychosocial support. If they have a good family support, they live in a family, the outcome is going to be good. This is just to show you the effect of adequate dialysis in most of these centers. The data is from West. So in diabetics, that 5-year survival is somewhere to the tune of 25 to 30%, whereas the best data is reported from France, Tassin, where the 5-year survival is almost 65 to 80%. And these are the patients who are dialyzed 5 to 6 hours every night, 5 days a week. They get 5-hour-long dialysis, and they have reported the best survival so far. There is an increased life expectancy by 9 to 15 years with longer dialysis. So patients who are on daily long dialysis, that the outcome is similar to kidney transplant patients. So this is the data from Italy. So patients on long dialysis, outcome is very good. And similar type of data with nocturnal home dialysis from Canada. So the outcome in these patients is equivalent to cadaveric kidney transplant. So if we dialyze these patients adequately and with longer duration, they can have good outcome on dialysis. Coming to the cost of dialysis in India, although the overall cost of dialysis is less than the developed countries, but still it is out of reach of most of the people in India. Most of the people in India, they are on twice-a-week dialysis, and about 1/4, 25% patients are on SOS dialysis. So whenever they develop complication or pulmonary edema or hyperkalemia, they go and get dialysis once in 10 days or once in 15 days. Cost of such dialysis, twice-a-week dialysis in India is approximately 30,000 per month. Most of the patients have to travel long distance, and that increase their cost of transport as well as loss of manpower days. So they don't come alone. There are 2 or 3 family members who lose their work and they come to the dialysis facility to get their patient dialyzed. Although PD is good, that can be home-based, no infrastructure is required, the cost is much better for the society, but the penetration is very poor. So it was estimated that in 2019, only 8,000 patients were on peritoneal dialysis. This is just to give you an idea of numbers. As I said, almost 2 lakh new patients develop kidney failure and they require renal replacement therapy. However, only 1/3 patients start dialysis, 2/3 patients die without starting dialysis. Those who start dialysis, almost 50% stop dialysis within 1 year because of some or the other reason. Peritoneal dialysis penetration is very low, 6% patients on PD. Most of the patients, they continue SOS hemodialysis. Most of the patients have to fund from their own pocket. 50% patients pay from their pocket for dialysis. Other means are state funding, which is seen in 30%, employment-based insurance 10%, and charitable institutes 10%. So this is the important cause of pushing these patients below the poverty line. So that is the state of dialysis. Coming back to our patient, which we started, he has been on dialysis for last 25 years. So when I talk to him, he says, now I am very good. I lived a good life on dialysis. My children have grown up. So my daughter has a job in Google. She drives her own car. The son has graduated from engineering college. So although we say that the dialysis is a bridge to kidney transplantation, but some people can have good life on this bridge. So that's what this man's journey has been on dialysis. So with that word, I stop here and I thank all of you for your patient listening.
Thank you, Dr. Manoj, for a very comprehensive review on the subject in 20 minutes given to you. Now we come to the last topic on this subject. Doctor, I don't want to do dialysis. And the speaker is Dr. Smriti Khanna. She is a consultant, Sparsh Clinic, Mumbai, consultant, pediatric palliative and supportive care unit at Wadia Hospital for Children. Her interests are pediatric palliative care, non-oncology palliative care, and medical ethics. Over to Dr. Smriti Khanna.
Good afternoon and welcome to today's talk. I thank the organizers of IMA Kidneycon for inviting me to give this lecture. My topic for today is what to do when your patient comes into the OPD and says, "Doctor, I don't want dialysis." So let's start with the case. Say this gentleman enters your OPD. He's a 75-year-old male, hypertensive and diabetic, past history of an angioplasty, known CKD, and has been on hemodialysis since 5 years. Currently, he is frail. He requires assistance with the help of a walker. He has diabetic neuropathy, and he's had a recent admission because of sepsis. He also has difficult HD access. 6 months down the line, he's had a few more admissions. He is bedbound. He is partially blind. He has a bed sore, and he has many other symptoms like anorexia, constipation. He suffers from hypertension during HD and has had to terminate HD multiple times. There have been episodes of delirium reported by the family, and he is now a financial burden on the family. This is what he perceives. And all of this comes together, and he comes to the OPD and says, "Doctor, I don't want dialysis." Will this gentleman benefit from palliative care? So this is the WHO definition of palliative care, but what it essentially means is that it is a holistic assessment and management of the patient as well as of the family, and there is impeccable assessment and treatment of pain as well as many other symptoms. Palliative care includes end-of-life care, but it is not only limited to end-of-life care. There are some myths about palliative care which need to be broken. It's not something that can be given only at the end of life. A patient can receive care does not mean that you are giving up. Along with palliative care, curative treatment can continue. It does not mean no more treatment. There is symptom management is a large part of palliative care, and it can be given in patients who have a host of other illnesses apart from cancer. So coming back to patients with chronic kidney disease, who would benefit from palliative care? Non-dialysis or patients on conservative management, those who are undergoing dialysis but have a high symptom burden. Any patient whose quality of life is affected a lot because of his illness, whether it is the illness itself, CKD, or the treatment that is dialysis. Patients who have dialysis, who have CKD along with other organ failure. We do see patients with concurrent IHD, with concurrent hepatic or pulmonary failure. Those who are considering withdrawal of dialysis for any reason, and those who may also be diagnosed with cancer along with ESKD. Then there are special populations. For example, dialysis in the elderly, dialysis in those with multiple comorbidities. It has been found that if a patient has many comorbidities, dialysis may not gain them a survival advantage because they will have issues associated with the other comorbidities. Hospital-free survival becomes similar in these patients. In many of these patients, we see that there is a lack of independence. And they have to be dependent on someone for their activities of daily living. And the quality of life of patients on dialysis is actually found to be similar to that of patients with a terminal malignancy. So when is it possible to actually have this discussion about withholding dialysis? Even if your patient comes to you to to say this. When is it medically a good idea to talk about withholding dialysis? This was an algorithm given out by the Renal Physicians Association, and it says that patients with multiple comorbidities or those who have bad functional impairment, poor performance status, those with severe chronic malnutrition, and a response of no to the surprise question. So 2 or more of these, it is reasonable to withhold dialysis or at least discuss it. The surprise question is when a physician asks himself whether they would be surprised if this patient died within the next 12 months. And if the answer to that is no, usually that is a good time to start palliative care. What is the role of the family physician in palliative care? The family physician by themselves are patient and family centered because they have been looking at the entire family and not just the patient. They may have multiple patients within that same family group. And that is what palliative care is. The family physician is best positioned to focus on improving the quality of life, understanding patient preferences. Patients are usually most comfortable with their family physician to discuss their medical decisions. Symptom management is an integral part of palliative care, and that is something that a family physician can take an active role in. Non-abandonment, that is, even if the patient has decided not to go ahead with one part of the treatment modality, other treatment continues. This could be symptom management, this could be infection control, this could be vaccination, this could be preventative measures, keeping a control on the sugars, BP, etc. And this is something that a lot of our patients feel but may not be able to emote, that they want a dignified life in their sunset years and also a dignified death. So what are the symptoms that we can expect in a CKD patient and what we can do about them? Nausea, vomiting, and anorexia are one of the commonest symptoms. Many of these, you must already be knowing about a lot of the things that need to be done, but I would just like to quickly go through some of the things that can be done. So for nausea, vomiting, using prokinetic, small frequent meals, calorie dense meals, and having minimal diet restrictions. Reducing the diet restrictions as along with what symptoms that they have. For constipation, using lactulose, stool softeners, stool stimulatory agents if the patient is on concurrent opioids. Sometimes patients may be on tramadol or fentanyl for pain management. And we have been using motility agents like glucalopride recently for constipation. Patients with CKD require a lower dose. So instead of 2 mg, give 1 mg. Those with breathlessness will need optimum diuretic management, propped up positioning, oxygen. In end-of-life care or towards the last weeks of life, we also prescribe low-dose opioids for breathlessness. Fluid overload needs optimization of BP, fluid, and salt, and of course, looking at diuretics. Also looking out for orthostatic hypotension, which can be a common side effect of diuretics in these patients. Itching will need emollients. At first, if it does not improve with emollients, then using antihistaminics or low-dose gabapentin. Insomnia and restless leg syndrome. Here also, patients can benefit with low-dose sedatives or low-dose gabapentin. It's important to focus on the dose of gabapentin in these patients because kidney patients do not tolerate the normal dosage of gabapentin that patients with other illnesses may be able to take as well. And we may have to look out for falls, look out for excessive drowsiness, myoclonic jerks in these patients. Aches and pains due to renal bone disease. So here it's PCM, paracetamol, which can be used. Obviously, NSAIDs becomes difficult to be given. Tramadol is sometimes given in patients where pain is not being controlled by PCM. And here also we may have to look out for side effects like constipation, drowsiness, vomiting, with tramadol, and low-dose gabapentin in case there is concurrent diabetic neuropathy. Now, sometimes our patients who have decided to go more for home-based care rather than hospital-based care, who have decided that they don't want to go ahead with aggressive management, no ICUs, no ventilator. How do we prevent admissions? or if they do get acute events, how can we take care of them at home without admissions? So here are some of the common reasons why these patients will get admitted. They can get admitted because of infections. So keeping them up to date with vaccinations, and if they do have infections, then home oral or IV antibiotics. With regards to fluid overload, we need to keep a watch on fluid and salt and prescribe diuretics as and when needed. For hyperkalemia, look at potassium restriction and look at acidosis correction. This can actually improve the quality of life and make them feel better if we can keep acidosis at a low level. GI bleed. This is where we may have to look at the drug chart of the patient and discuss withdrawal of antiplatelets or anticoagulants if they are on this. Patients who have decided to opt for home-based care, patients who are at their end of life, patients where you have said no to, as an answer to the surprise question, it's a good idea to go back to their drug charts and cut off some of the unnecessary medications. Statins for hypercholesterolemia, antiplatelets for those with ischemic heart disease, because these can actually potentiate the side effects and cause bleeding. And that will then be a reason for needing admission for these patients. If and when GI bleed does occur, then tranexamic acid, ethamsalate, antacids, or sucralfate is useful as oral agents. Encephalopathy. Again, looking at the drug chart, looking for drug-drug interactions, looking at the dosages that the drugs that they have been given, they have, cutting off unnecessary medication. BP, hypertensive encephalopathy is a possibility in these patients, so monitoring and controlling BP and looking out for infections. Advanced care planning is an important aspect in any patient who is receiving palliative care, and in any patient who actually has an illness that is impairing their quality of life and is likely to increase further. So patients with any organ failure will benefit from advanced care planning. Discussion about whether they would want hospital to the admission to the hospital or ICU, whether they would want CPR or ventilation, discussion on whether they would want vasopressors or major surgery to be done. Some of these points are quite fine, and we may think that they are small, but once we start the discussion on advanced care planning, it becomes easier to talk about all these various things. And there is another way, that is the living will, that is a good way to document advanced care plans, and I'm going to be coming to that. So some other things that we may need to, that we should include in advanced care planning is methods of artificial nutrition. So would the patient be okay with having an RT or a PEG tube anytime in the future? Would they be okay with relying on IV fluids as the sole means of nutrition? And who would be their healthcare proxy or their medical power of attorney if they are unable to make decisions for themselves because they are comatose, because they are on the ventilator, say? Who from the family or from their close circle would be the one making medical decisions from them? This makes it much easier for the patient and for the rest of the family, and for the doctors also, as time goes. And sometimes patients have decided that they want their place of care to be only the home and not go to the hospital. So it's important to discuss that. Sometimes they might want they might want to go back to the native place in their last few months or weeks of life. So talking about that too. This is the living will that I had mentioned. A copy of this can be found on the Vidhi Center for Legal Policy website. On the 18th of March 2018, the Supreme Court passed the Common Cause judgment, which talks about the living will and how to implement it in a legal fashion. This is actually a legitimate legal will that has been ratified by the court. It can be downloaded from this website, and it's something that we can all look at, talk to our patients about it. They can document all these different parameters that I had discussed in the advanced care planning. All these things can be documented in the living will. There is a complete legal process after this. It has to go to the magistrate, etc., etc. It's a little long, but patients can go ahead with it. And even if that doesn't happen, at least their family knows, their physician knows that this is what they would wish for. I'm also going to share this ICMR consensus guidelines on DNAR. DNAR is a very contentious subject, but in 2020, the ICMR has released guidelines on how to approach it, along with a form that can be downloaded and used directly in hospitals. So let's go to the take-home message in the interest of time. What are the 5 things that I would like everyone to remember, even if you've forgotten what we have discussed up till now? Aggressive symptom management is essential for any patient, even if they have decided to withhold dialysis. Review their drug charts, reduce their medications if possible. Communication and shared decision-making, give them that space to be able to talk and make medical decisions for themselves. Talk to them about advanced care planning, encourage them to make their living wills, and focus on home-based care, even when it comes to end-of-life care. Thank you.
Thank you, Dr. Smriti, for a wonderful talk on palliative care in CKD, which is care beyond cure, and cure rarely, comfort mostly, and console always. With this, we come to the conclusion of this session. All the 4 speakers have done a wonderful job for the academic talks and scientific bent of mind and academic flavor and fervor. You have seen how the chronic kidney disease can be tackled by you. Thank you.
And now we'll be taking some questions. I'll start with the audience. Anyone in the audience who has a question? Yes, sir, please.
A wonderful session, and my question to Dr. Neeru regarding in diabetic kidney disease, where the eGFR levels are reduced. It is a kidney disease, mind you, diabetic, not chronic kidney disease. Reverser of eGFR, to what level? Second would be the half-life. You have talked about the insulin. How do you titrate the insulin levels? And you've talked about the dapagliflozin, SGLT2 inhibitors. You've talked about DPP4 inhibitors and GLP-1 analog. Specifically, my question, the benefit you said for the kidney disease of SGLT2 inhibitors, and as it is linagliptin, which is more allowed related to liver and kidney disease, and more focus onto semaglutide, with what benefit? Because we have option of using insulin. Thank you very much.
In diabetic nephropathy, once the GFR has declined, the person has already progressed to chronic kidney disease. It is a irreversible process. You can slow down this is what I said, that it is a secondary prevention and tertiary prevention. That means you can slow down the kidney disease. You cannot stop it. It's bound to culminate into end-stage kidney disease. This was first part. Second is you asked about the gliptins and SGLT2 inhibitors. The SGLT2 inhibitors alone have no role. But yes, in combination with DPP4 inhibitors, they can be used, but alone, by causing glycosuria along with sodium, it reduces the obesity by excretion of extra glucose load, which is the case in case of type 2 diabetes mellitus, where insulin resistance is there. Then by reducing the sodium in the proximal tubule, absorption is less and it goes to the distal tubule, and that's how it reduces the filtration fraction in the glomeruli. So once the filtration fraction is less, that means the protein filtration would also be less. That is how they reduce the proteinuria, the other part. Then it reduces the hepcidin levels. It reduces the inflammation by hypoxic stimulation of the erythropoietin. This is other part. What else? Other about? The insulin excretion is delayed in diabetic kidney disease. In all the diabetic kidney disease patients, insulin excretion is delayed. So the levels are prolonged for a longer time. We usually modulate the dose. We reduce the doses as per the blood sugar levels. As such, there is no specific formula. It varies from person to person. About semaglutide, these are incretin mimetics. They increase the availability of insulin in the blood, and that is how they work, and they also reduce the filtration fraction. So this way we manage the diabetic kidney disease. Other thing is they have good effect on cardiovascular disease also. So if a compound has good effects on the kidneys as well as the heart, so I would prefer to use that molecule. Another thing, the cardiovascular disease is very high in CKD patients. So the use would benefit both the things and would delay the progression of kidney disease as well as would add to the longevity of the patient.
We have a lot of questions with 1900 people watching us online. So I'd go on this next question to Dr. Manoj Singhal, sir. The question is about what is the precise timing of RRT initiation. I think you mentioned it already, but I think a take-home point about, maybe guideline based or is it clinical, I think is what the question is. What is the precise timing of RRT initiation according to you?
So most of the people are guided by signs and symptoms of chronic kidney disease. So when the patient present with symptoms which can be attributed to CKD, that's the time when the dialysis should be started. There is a group of people who believe that why do we let the symptoms which are very late in onset? So once the GFR go below 15 ml per minute, we should not leave them in advanced kidney failure and we should preemptively start dialysis. In fact, there is a study which was conducted where they compared early start of dialysis just based on serum creatinine or GFR level or delaying dialysis till the patient develops symptoms because of renal failure. And in fact, there was no advantage of starting dialysis just based on GFR level. So that's what also has been recommended in KDIGO 2012 guidelines. So when the patient has symptoms, say anorexia, weakness, weight loss, difficulty to control their blood pressure and fluid status. So these are the symptoms which will prompt us to start dialysis, and usually they correlate with the GFR of approximately 8 ml per minute. So that's the time when most of the people will agree to start dialysis.
Thank you. Thank you, sir. We have another question from the audience. Please go ahead, sir.
Hello, good morning. It's a question you can say from a non-medical or from a general practitioner. How long can you sustain a person on a dialysis if he is not getting a transplant or is not getting a donor?
I think we'll address this question to Dr. Singhal again. What do you think?
Yes. So the patient, if they have no option for kidney transplant for whatever reason, they can continue on dialysis. The crux here is to, I'm coming to it, sir. So the crux here is to get good dialysis. If somebody wants to have a good quality and a long life on dialysis, he has to get good quality, adequate dialysis and good nutrition. So these are the two things which will help in continuing dialysis for a long time. There is no life as such, a half-life or anything. So it depends on patient comorbidities. If the patients are younger, they do not have comorbidities, they get good dialysis, their nutrition status is maintained. We take measures to prevent anemia, control their metabolic bone disease and vascular calcification. These patients can live on dialysis. As I said in example, my patient was started on dialysis in 98. And today in 2022, for last 24 years, he has been on dialysis. So when he started dialysis, he had two small kids, 8 years and 5 years. Now his kids have grown up. So he is quite satisfied with his life on dialysis. So he has lived a good, fruitful life, and he felt that he has fulfilled all his obligations to the family. So that's what we try to achieve on dialysis. So patients who are younger can live for 30 years, 40 years, 50 years on dialysis.
And how much does a fistula, which is formed for dialysis, it last?
Sir, fistula again, it again depends on the type of vessel. See, generally men, if they have good vessels and the good fistula is made, it may last for years. So I have seen fistulas which have been working for last 20, 25 years. Whereas in women, especially when the veins are very thin, they are embedded in fat, they are sclerosed because of previous injections. These patients have problem getting a fistula made. And then they have other options like venous graft or permanent catheters, which can be a lifeline for these patients for dialysis. So vascular access difficulty definitely is a Achilles heel in these patients, but that can be managed. We have multiple options available for dialysis in these patients.
Thank you.
Thank you. We have another question for Dr. Vishwanath, please. So the question from the audience is, till what stage is CKD reversible and how can you prevent the progression of chronic kidney disease in brief? I think you already mentioned in your talk.
Yeah, it depends on what disease we are looking at. That's the reason, in fact, the newer classification includes the cause as a major factor in determining. If it is diabetic kidney disease, if there is already GFR less than 60, we cannot reverse. Only stage we can reverse in diabetic kidney disease is microalbuminuria. Other diseases, if there is already onset of macroproteinuria, that is moderately or severely increased proteinuria, or there is chronic kidney disease more than 3 months, we cannot completely reverse. Only stages where we can reverse is maybe some glomerular disease. If it is picked up early, biopsied, we can definitely reverse. Then they will fall into acute. So if it is already an onset of CKD, proteinuria, and GFR less than 60, we cannot reverse. We can only delay the progression.
Right. Thank you, sir. I'll take one last question for you. A lot of questions on complications of CKD, but a very repeated question is high blood pressure always seen with worsening CKD?
Both go together. It is like catch-22. If you have hypertension, you can have CKD. And if you have CKD worsening, that can lead to hypertension being difficult to control. Most of us practitioners, we have seen whenever GFR is dropping, their blood pressure worsens. And once they have transplant and kidney is working well, many people may not meet any antihypertensives. So it is both the ways. If you have poorly controlled blood pressure, it affects kidney and GFR drops rapidly. If CKD is progressing and GFR is dropping, worsening hypertension is expected.
Right. With that, I'd like to thank all of our speakers and the chairpersons for this wonderful session. We have a lot of questions. I'd request the speakers to go into the chat box and reply if you can. And now with this, we conclude this session.
We come to a conclusion of this CKD session, and we have mementos to be given. I would request Dr. Anil Chaturvedi to honor Neeru ma'am. Sir, आगे आ जाओ. इधर आ जाओ. Come this side. Come this side. Yeah. इधर आ जाओ. I would request Dr. Anil Agarwal to come on dais and honor Dr. Garima. Well deserving. Now with this, we come to the final session, which is the most important and very waited for session. It's a panel on kidney transplant. I would invite Dr. Shankaran Sundar and Dr. Umesh Ojha to please take over from here. I would request Dr. Rajiv Sood to come on dais. Please come, sir. Dr. Garima, you also come. Do we have Dr. Shankaran Sundar and Dr. Umesh Ojha? Yeah. Okay.
I'm here. I'm unable to open my video. I think somebody else from the IT team has to help me out.
The IT to
We have sent the
please,
request for to open your video. Kindly accept that.
we have with us.
Okay.
We have
Done,
with
done.
us Dr. Umesh Oza. He's the professor and HOD Department of Urology and Transplantation, Bombay Hospital, Institute of Medical Sciences, Mumbai, Maharashtra. And we have Dr. Shankaran Sundar with us.
Thank you.
Sir is an ex-chairman of the Indian Society of Nephrology Southern Chapter. He has vast experience in the area of transplantation. He has performed over 3,000 transplants in his institute. He is an adjunct professor of nephrology at the Manipal University, and he is the founder member of the Indian Society of Organ Transplant. Over to the moderators now.
Good afternoon. Kidney transplantation is an accepted mode of treatment for patients of end-stage renal disease. Outcome of transplant has improved over the years, and the surgical results in India are comparable to international standards. However, it is not only surgical challenge, but has legal, emotional, financial, and organizational challenges. Successful outcome, increase in longevity, and longer survival on dialysis has increased the demand for kidney transplantation, which has become a great challenge. I take this opportunity to thank leadership of IMA to include this topic in this conference, and it's a pleasure to see Dr. Rajiv Sood in front of us, watching us when we are conducting this session. Over to Dr. Sundar.
Thank you, Umesh. I think this is a very interesting, important session we have. And we are going to have two chairpersons for this session. And the first chairperson is a close friend of mine, Dr. Balla. Dr. Balla actually doesn't need much introduction. He's a Padma Shri awarded in 2010. He's the chairman of nephrology in the Gangaram Hospital. He's got many fellowships, from the fellowship of the Indian Society of Nephrology, fellowship of the Indians of Transplant, the American Society of Nephrology. He's a BC Roy Award winner. Above all I can say is he's a very humble human being. All the patients who see him, all the students, they love him, and we're very fortunate to have him as one of the chairpersons for this important session. So I request Umesh Oza to introduce Dr. Sandeep Guleria, please. The other
Dr. Sandeep Guleria. He is a former professor of surgery, All India Institute of Medical Sciences, New Delhi. He was formerly consultant surgeon at St. James's University Hospital, Leeds, in United Kingdom. He has been awarded the Padma Shri by the Government of India. He has pioneered kidney pancreas transplantation in this subcontinent. He has been the past president of the Indian Society of Organ Transplantation, and he has been a member of the Ethics Committee of International Transplant Society. Well, he has delivered many orations, he has many publications, and I can go on and on and on. But Sandeep is a close friend and a great person. May I invite Professor Sandeep Guleria and Dr. Bhalla to start our next session. Thank you very much.
Thank you, Umesh. I'll hand over the... is Dr. Bhalla... Dr. Bhalla, can you hear me?
There, Bhalla?
Dr. Bhalla?
So you can introduce him since Dr. Balla will be joining us in a few minutes.
Okay, we will ask.
Okay, well, it's a privilege for me to introduce Dr. Keyur Dave, who is a nephrologist working at the Jaslok Hospital and Research Center at the Suchak Hospital. He's also a director of the Kidney Association of Mumbai, a consultant nephrologist and renal transplant physician, an executive committee member of the Mumbai Nephrology Group, a standing committee member for CKD IMA headquarters, and an organizing secretary for NephroCon. I'm going to hand over the mic to Dr. Keyur Dave. Dr. Dave, please.
Thank you so much, sir, for a kind introduction. At the onset, a big thank you to the organizing committee of the IMA Kidneycon, for presenting this dais to me. And, I come from the city of Bombay. So the place which makes its films. So I thought, renal transplant we talk about in terms of as we do in films. And Rajkumar Hirani was not willing to make another Munna Bhai. So we thought we'll make another Munna Bhai. And that's how it will be. So I'll share my slides in a while. So can everyone see my slides?
Yes, sir. They are visible. You can go ahead.
Sure. So we'll start with this. So Munna Bhai chale kidney transplant karane. That's how we'll start. So Munna Bhai, the story begins with Munna Bhai has been now diagnosed with a CKD, and he has been recommended that he would either need dialysis or transplant. In fact, his creatine's gone up to 8 or 9, and now he does not know what to do. He speaks to one of his friends, and his friends, his friend is Jassi, who is already on dialysis. And he say कि क्या transplant के चक्कर में पड़ता है? Transplant में बहुत सारा problem है, तू dialysis कर, that will be better. And now Munna Bhai is confused, what to do further. So as things would be, he would consult his mentor Gandhiji. Gandhiji would appear from in the movie, and he would guide him. He tells him, Munna Bhai, you should do a proper research. You should do a proper research between dialysis and kidney transplant, and then take your decision on what you have to do. Gandhiji would bless him with a trial, a huge, meta-analysis of multiple trials, which has evaluated whether kidney transplant is better or dialysis is better. He goes through all the findings of this meta-analysis. What does the meta-analysis show? Meta-analysis shows that in terms of longevity, in terms of life, in terms of patients staying alive for longer, renal transplant has a definitive advantage as compared to dialysis. He goes and sees more and more studies, and every study shows that transplant is much better than dialysis. He is also concerned about his heart. The trial says that kidney transplant has a favorable outcome as far as any kidney event is concerned, as far as any heart failure is concerned, any hospitalization regarding is concerned. So kidney transplant wins the war here too. And overall, if he sees further in terms of physical functioning, in terms of emotional well-being, in terms of social functioning, in terms of mental stability, every data favors transplant. So things are clear. Munna Bhai has to undergo transplant. That's the end of the thing. Now circuit, as usual, he says, Bhai, tension nahi lene ka. We will arrange a donor for you. But the problem is, circuit picks up everyone whomsoever he finds and decides that he is going to donate a kidney to Munna Bhai. But is this the right way? Munna Bhai again goes to Gandhiji. That what am I supposed to do? Who can donate a kidney to me? So Munna Bhai ka donor kaisa ho? Ideally, it should be of a compatible blood group. It should be of good cross match. But yes, in selected cases, the blood group barriers are very well breached, and we have excellent transplant outcomes. The donor should be healthy. He should not have any acceptable medical surgical risk. Donor should have a stable kidney function after donation. Should not have any transmissible infection or malignancy. He should have an acceptable renal anatomy and should not have a psychosocial problem. Now, who can donate? So who tells us this? We have the Human Organ Transplant Act, which was first formed in 1994 and then has had modification 2011 and 2018. So there is a clear-cut definition of who can donate in terms of live donor transplant. It has to be a near relative donor. So either mother, father, son, daughter, brother, sister, spouse, grandmother, grandfather. Or it can be any other near relative donor. So such a donor, who is willing to donate on the reasons of affection and attachment on any other special case. But this needs an approval of an authorization committee. It cannot be that anyone can come forward and, I'm going to donate. Or there can be a swap transplant where, swap transplant between two donor and recipient pair, where one donor donates to the other recipient and the other donor gets, donates to the other recipient. So this is done in a very formative and a legalized manner. So now it is decided that Munna Bhai's mummy is, willing to donate to Munna Bhai. So what do? It just, it's not like any other surgery that today we have a donor, we have a recipient, and we go ahead do the surgery tomorrow. It needs a systematic evaluation. The NOTO guidelines have given us a clear-cut guideline. So it needs a psychosocial evaluation. We need to evaluate blood compatibility. We need to evaluate the immunological status, medical evaluation, surgical evaluation, a proper consent, and further on. Because the biggest principle when we are doing a transplant is do no harm to the donor. This is an extremely important principle. When planning for a transplant, the more important is for us is the donor. So here, no matter what, Munna Bhai is the biggest bhai, but here his mom is more important for us because we do not want the donor to be harmed. We do not want 2 patients out of 1 patient after a transplant. So what should we understand? What are the absolute contraindications to become a donor? So any donor less than 18 years of age is not considered. Hypertension of a more than 50-year-old with end organ damage with more than 3 antihypertensive medications cannot be considered. A diabetic patient who is especially proteinuric cannot be considered. History of thrombosis, psychiatric contraindications, really obese donor, a donor with coronary artery disease, especially a symptomatic valvular disease, peripheral vascular disease, a chronic lung disease, a recent malignancy, significant urologic abnormalities in terms of donor kidney, or a presence of HIV infection in a donor, is an absolute contraindication. What are the relative contraindications? So virus infections like hepatitis C, hepatitis B. You may be wondering why are the relative contraindications? Because now there is efficient, treatment data available where you can cure hepatitis C, where you can cure hepatitis B, and, then the patient can, readily donate. Patient who is between the age group of 18 to 21 years. Now, invariably, these are the people there, the sons and the daughters of the patients or who wants to donate. But so here an important decision needs to be made, whether you're dealing with a genetic problem. Is it a chance that, children may acquire the disease? Because in the longer run, you need to ensure donor safety. Patients with kidney stones, patients with distant history of cancer, renovascular disease, moderate valvular heart disease, mild sleep apnea, obese patients. These donors, who are in the marginal, category, once you kind of treat them well and they become fit enough, you can ask them to be donors. Now, how do you ensure that a particular donor is well compatible? What is a well-matched kidney donor? So a blood typing is done, a tissue typing is done, we do cross-match studies. What do? We do the ABO blood group. But as I said, we do against the blood group transplant, which Dr. Bhargav also would be speaking about. We do the HLA typing and we do the CDC cross-match. There are further immunological tests, we further do to ensure that there is a complete immune protection and a good acceptability of the graft in terms of recipient. Now, donor evaluation tests has primary tests, has secondary tests. First, you want to screen the donor, whether he is really eligible to donate, whether he will be a suitable donor. So in terms of the tests that I advise my patients, I do a complete blood group, a CBC, a blood group, a renal profile, LFT. I check for proteinuria. I do a urine routine, do serological tests. I do HbA1c. I do T3, T4, TSH, lipid profile, USG abdomen, pelvis, and ECG, 2D echo, chest X-ray. These have been given by NOTO guidelines, and every nephrologist who is evaluating a donor follows these guidelines. These are the primary screen that we do. Once the donor is found suitable on these tests, we do further tests. We do a 24-hour urine creatinine clearance. We do a DTPA scan. We do the CT-KUB with renal angiography to understand how the anatomy is. We do an HLA typing. We do a CDC cross-match and a flow cytometry. There is a single antigen bead test, which is an advance to be sure about the immunological status as far as the recipient is concerned. Also, you want to do cancer screening of donors. So you want to do a pap smear, you want to do mammography, you want to do a PSA of men over 50 years, preferably even, a colonoscopy should be done, especially where there is history of, malignancies of the colon in the family. A psychological evaluation is mandatory and extremely important. We need to evaluate whether the donor is in sound mind, he's not being forced, or it's not that in the terms of, where society is as of now, we see various cases. So the donor should not be forced into a donation. At the same time, donor should understand what the risks and the benefits of the outcomes are going to be. At the same time, we evaluate the recipient also. Is he in a sound health? to, take care of himself post-transplant? Is he in a sound health to take immunosuppressive medications? So psychological evaluation is extremely important. There are important surgical aspects that we deal with. Now the CT has replaced the IVP or the MRI which was done. Left kidney is preferential. That's done because the renal vein or the left side is longer. But in select cases, you would choose the right kidney, especially when the left kidney has more a complex vascular anatomy, or the right kidney has, minor abnormalities like a cyst and, a mild obstruction. Or even in women who plan to become pregnant, that's when we kind of prefer the right kidney as compared to the left kidney. Now, the kidney removal from the donor is either done by an open approach or a laparoscopic approach. And, while doing the dissection, an adequate exposure is, ensured. The kidney is extremely, handled well. A good diuresis is ensured. And, we want to reduce the ischemic time that is involved while transferring the kidney onto the recipient. Now, invariably, this stuff, the Munna Bhai asks, why can't we do it like a normal surgery? Itna sab form bharne ka kya zarurat hai? So, this is a transplant is important from a legal aspect, because we deal with in a society where we see all kinds of cases that are happening. We have makeshift donors, people who are coming in disguises, people who are there is exchange of money, and this used to happen before 94. Then government got very, very strict about it. It came up with the Human Organ Transplant Act. Exchange of organs with money is not allowed in our country. So the various legal aspects while working up a transplant is done by a transplant coordinator. There are various forms like this one, where you need to have affidavits, you need to have sanctions where this transplant can be done. So you have a medical file which is prepared, and you have a legal file which is prepared. And as you can see the checklist, a transplant coordinator in every hospital which is an active transplant program always sees through that a legal file concerning all of these that is there in the checklist is there. It's only when the legal file and the medical file sanctioned or recommended by the nephrologist is complete, that's when this particular case goes for the authorization committee to the hospital. If it's within the state, it goes to the authorization committee of the hospital. Once outside state, it can also go to the state committee. And once the committee sanctions the transplant, that's when we can go ahead with the transplant. Now, is everything hunky-dory? Is everything so good about the renal transplant? What do you need to be careful with it? We need to be careful. We need to be telling our patients that yes, transplant is an excellent, modality. It is extremely good for longevity of life, but we need to be regular with our immunosuppressive medications. We need to have precautions to prevent infections. We need to maintain good habits and lifestyle. In India, an important point about infections, we are really scared about infections as far as transplant, patients are concerned. The concern with the patients, the concern with, this debate of dialysis versus transplant comes primarily from there, because the first 6 months is when, the patient is really prone to get infection. So if the recipient, is really careful about his habits, careful about wearing a mask, careful about his lifestyle, we can prevent these infections. A regular BP check, a sugar check is required. There is a minimum risk with immunosuppression as far as cancers is concerned. But again, if you maintain a regular, follow-up, then things are good. Stay away from overconfidence. A lot of our transplant patients ultimately get overconfident. They start skipping their medications. And that's when, the transplant gets rejected. And it's extremely important to maintain a regular follow-up. And, that's when a transplant does well. Benefits of renal transplant far outweigh the risks involved. And, as Harshad Bhai, Munna Bhai's, friend would famously put it, life hai to risk hai, and risk hai to ishq hai. So, we have to follow this. Once a good transplant, how is it? Khawanu, pivanu, and majjani life. And that's where it is. So, we need to encourage transplants in our patients, a live donor transplant, and we'll be able to deal with CKD much better. Thank you.
Thank you. That was really very interesting. I think Dr. Bhalla has now joined us. So if, we'll take the questions at the end, Umesh, or we take them right now?
We are taking it doing panel discussions. And
Hello.
Balla, please introduce.
Yes. At the outset, I will like to thank the organizers for giving me the opportunity to join this very important initiative started by IMA. And it is my proud privilege to invite Dr. Vinant Bhargav, who is a senior consultant nephrologist at Sardandaram Hospital, New Delhi. And I will request to start his presentation. Dr. Vinant Bhargav, please.
Thank you, sir, very much for this kind introduction. And there can't be anything better than having my own teacher, my own guide, my own mentor having introduced me for this session. So I have sent my video recording, and I'd request the IT industry to kindly share the video recording. I'll be at the back end. Thank you.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank you all for being here with us for this wonderful presentation today. And I hope I do justice to Munna Bhai. My sincere gratitude to the organizers for choosing me to being here to speak to you about this topic. I'd like to thank Dr. Umesh Khanna and Dr. Garima Agarwal for having invited me to present this topic to you. So I hope I do justice to Mr. Munna Bhai, Dr. Munna Bhai, in fact, who does not have any related donors in his family, but wants to undergo a kidney transplantation. And this is a very common scenario. So I'll just walk you through this over the next 15 to 20 minutes, and I'll have enough time spared to discuss the topic. To begin with, let me present you the statistics. Approximately 2 lakh patients in India are waiting for organ transplantation, and only 15,000 donors are available. So that brings us to Munna Bhai, who says, "Hey circuit, apan ke paas to donor hi nahi hai, apan kya karega?" So circuit, as always, says, "Bhai tum tension mat lo, apan setting karta hai na." But the question is in his mind, who and how? So we know, and the transplant wait list, the annual requirement is approximately about 1 to 2 lakhs, but only about 5,000 get actual transplants. So what are the options that I can give to Munna Bhai? I would like to suggest to him either living donor transplantation, which could either be with a related donor, with a distant related donor, with a pair donor, or also offer him disease donor transplantation. So when Munna Bhai asks me about the donors, I tell him, you have 2 types of donors. One is the living donors, which obviously remain alive while they're donating their organs. And the other is the disease donor, which is also called as the cadaver donor, which are declared brain dead and who are kept viable by ventilators. Amongst the living donors, you have directed donation, in which the donor chooses the specific person he wants to give the kidney to. And this type of donation will generally occur when the donor is related to the patient as either a family member or friend. The second is non-directed donation, and this living donation generally does not take place in our country. In this, the donor is, irrespectively of whom he has to donate, is just ready to donate the kidney, depending on who he matches with. So now, what are the problems that Munna Bhai could be facing because of which he couldn't undergo a transplantation? Either it could be because of a blood group mismatch, that is an ABO incompatible problem, or it could be because of antibodies such as HLA antibodies, HLA incompatibility, or maybe his donor is not suitable because of some medical condition, infections, cardiovascular problem, maybe even just diabetes. We have to understand that 30% donors are immunologically incompatible because of the presence of, in the recipient of antibodies directed against HLA system of the donor, or because of incompatibility of the ABO system. But we understand now in the recent years that ABO incompatibility has become very safe and effective with our improved understanding of the immune system and availability of new drugs. I present to Munna Bhai this data in which the meta-analysis from 26 single center studies showed that ABO incompatible transplants compared with ABO compatible transplant in a very good 1-year graft survival rate. And also, despite having higher rates of infections and antibody reactions, they did do as good as ABO compatible. Then he could be having a problem with the antibodies, HLA antibodies, that is. So I would tell him that, yes, you're right. We do have some conflicting results from studies. But however, in the present day scenario, there are specific and very good advances in antibody detection and screening, as well as HLA typing and desensitization of patients. And this has aided in curtailing associated risk associated with this kind of a procedure. I'd also like to show him this data, in which I'd like to tell him that this study, which was carried out in Korea on 190 patients of HLA-incompatible kidney transplantation over a period of 12 years, in which there was 3 groups. One was the CDC cross-match positive group, one was a flow cytometric cross-match positive group, and the third was a cross-match negative with a DSA positive group. They had 3 subgroups. One was the HLA incompatible living donor. The second was a waitlist or HLA compatible disease donor. And the third one was just the waitlist group itself. What they concluded from the study was that patients undergoing HLA incompatible live donation kidney transplantation had a survival benefit as compared to patients who were still on the waitlist for HLA compatible disease donor kidney transplantation, or those who received HLA compatible disease donation kidney transplantation. And this multi-center study, which was published in NEGM, also validated the single-center evidence that patients who received kidney transplant from HLA-incompatible live donors had a substantial survival benefit as compared with patients who did not undergo transplantation and those who waited for transplants from deceased donors. The last option that I would like to give him would be, if there is no existing donor in the family, is to go for other than near-related donors. So other than near-related donors are either distant donors, that is second-generation donors, or second-generation relatives, or even friends. However, this is a very controversial category, and there's always a possibility of monetary transaction, as we know of, and permission is given in such cases only by authorization committee because of a lot of legalities involved, and the committee grants permission only when the specific format given in Form 19 is fulfilled. So Munna Bhai tells me, "Bhai, do not discard organs, use them before they go back to heaven." And I say, yes, I agree with what you say. I also give him the possibility of paired kidney transplantation, which could either be a 2-way exchange or a 3-way exchange, in which different groups, different pairs interchange organs amongst themselves, sheerly because of the fact that either they share a problem with the HLA compatibility or maybe with the blood group antigen. There's another option, which is called the trans-organ paired exchange, in which a different organ recipient receives donor from the different organ recipient's paired donor. So this is also a possibility. So let me quote to you this data on the outcome of kidney paired donation transplantation in our country. The most recent data comes from Dr. Vivek Kute, who has analyzed nearly 300 patients, most of which were ABU incompatible, and most of which who had done a 2-way kidney exchange. He showed that at the end of 3 years, the patient survival was approximately 83%, and the graft survival was 96%, which is almost comparable to the live donor program. Apart from this 2-way, 3-way, 4-way, 6-way, or whatever n-way kidney exchange, which is actually a simultaneous kidney paired donation program, you can also have a non-simultaneous kidney paired transplantation, in which you have a donor which will donate at a later date and the recipient will get a donor from somewhere else, and the donor that is related to that particular recipient will be donating at a later date. However, there is always going to be a problem with that. Apart from that, you could also use desensitization plus the kidney paired donation, ABU compatible protocols plus use kidney paired transplant program. Also, you can use A2 donor to O patients. Acceptable mismatch program is not very prevalent in our country, and it's more common in patients who have a very strong disease donation program, in which you will use acceptable antigens and chart them and form an HLA program of the patient, which will match with another donor, which is already pre-programmed on the HLA list. Now, Munna Bhai says that my patient, my donor is actually hepatitis B positive. So what do I do? So I tell him that hepatitis B positive donors in a living program on this data has shown to have provided excellent graft and patient survival without HPV transmission. However, there's a protocol that has to be followed, which we will discuss at a later stage. Even so, even the HCV NAT negative recipients can be safely and successfully transplanted with an HCV NAT positive donor. But this is obviously outside the research protocol. And then access to the antiviral agents, that is the direct antiviral agents, should be there, and timely administration of therapy as well as monitoring of patients is very important. So this is what I was talking to you about. So if you have an HPV positive donor and he is HPSAG positive, and the recipient is also HPSAG positive, you can proceed using antiviral drugs. If the donor is HPSAG positive and the recipient is core antibody positive but has not developed adequate antibodies to the surface antigen, then you has developed adequate antibodies to the surface antigen, you don't need prophylaxis. However, in the same scenario, if the antibody titers are not adequate, less than 10 international units per liter, then you would consider vaccination and prophylaxis with high dose of hepatitis B immunoglobulin or lamivudine. In this donor, if the core antibody is positive and your antibody titers in the recipient are low of the surface antigen, then you would again follow the same protocol of doing vaccination, prophylaxis with high dose hepatitis B immunoglobulin, and an antiviral agent. However, if the recipient has adequate antibody titer, that is more than 10 international units per liter, you don't need any prophylaxis. Irrespective of what you do, there has to be a very strict clinical follow-up of these patients after transplantation with HPV DNA viral titers, as well as the liver functionality. So now Circuit is under a lot of stress. He says, "Bhai ne kam bola tha, karne ka hai." Matlab karne ka hai. But kaise karne ka hai? So now I propose to him that there is the National Organ and Tissue Transplantation Organization, which was set up in the 2011. And this was basically an amendment from the Transplant Human Organ Transplantation, THOA. And they set up the ROTO and SOTO, and after which a lot of improvements have taken place. So he asked me, how do I get to the transplant waitlist? And I tell him that you have to just go to a physician, fulfill the criteria for transplantation, and then you can just be enrolled in the hospital on the waitlist using the NOTO. So the renal transplantation are depicted in this table here. Let me take you to the most current study in 2015, in which 173 patients were studied. It showed a good patient survival at 5 years of 76% and a graft survival of at 5 years of 80%, which is comparable to living donor program. So disease organ donation rates have actually improved from 0.27 to 0.65 per million population from 2013 to 2019. This is after the NOTO was set up. And there has been overall increase by nearly doubling of the numbers in this time. Disease donor organ transplantation contributes to approximately 20% of the transplant. There is a little variable distribution of donation rates over the country, with the West and the South doing very well, and the Postgraduate Institute of Medical Education and Research in Chandigarh doing well. However, there seems to be very poor programs in the East and the central part of India. So my Munna Bhai is quite happy now. He says, "Tum bahut mast kaam karta hai. Ab aur kya karne ko mangta hai?" So I present to him the latest technology, which is called as xenotransplantation, which is using the pig kidney, which is basically a 10 gene edited pig, of which 4 pig genes are knocked out and 6 human genes are knocked in. And I tell him that this is something which is available not in our country, and you can probably get yourself in the program in the United States of America. He says, "No, I can't do that." So I say, "Okay, then you just continue dialysis, because we understand that with the present day technology, patients are having very high life expectancy with good nutrition, with good vascular access, with good dialysis facilities, whether it is hemo or it is peritoneal dialysis." In the end, I think Munna Bhai is a little happy. He says, "Hey, Circuit, लगता है donor मिल गया. And he ends by saying, thank you रे बाबा, ए मामू, जादू की चप्पू दे दाल और transplant कर डाल. Thank you very much for your patient listening. I'm at the back end, ready to take any questions at the moment. Thank you.
Umesh, you have to unmute.
Right.
Is Dr. Bhalla on still, or?
We're not seeing him
so
now.
Dr. Bhalla is not here.
Right, sir. So what do we do next? I think we can move to the panel discussion, or do we take the questions first?
I think we'll complete the panel discussion because many of those questions will be answered, I'm sure. After that, whatever is there, of course, we can take it up. So, friends, you had an excellent talk by two of our faculty, Dr. Keyur Dave and Dr. Vinan Bhargava. Basically covered, of course, more of a live donor transplantation. So, as you realized that there's a big gap between availability of organs and patients who require organs. And that's where there are a lot of patients who don't have donors. And there's a big role of cadaver transplant, or also known as a disease donor transplant. So we hope that in this panel discussion, we'll try to cover more issues related to cadaver transplant. And at the end, whatever are the questions, we'll take them up and answer all your queries. Today, we have a great faculty of a great reputation. If we start putting their biodata, I think our time will be exhausted only on describing their achievements. Suffices to say that all these people are the pioneers in the field of kidney transplantation in India. And I think that will tell you that's the reason why they are there on this panel discussion as a faculty. To start with, Dr. Sunil Shroff. Here we have Dr. Vijay Kher. Unfortunately, has not been able to join as yet. So I will introduce Dr. Sunil Shroff. He is the founder trustee of Mohan Foundation, professor in head Department of Urology, Madras Medical Mission Hospital, Chennai, Tamil Nadu. We have with us Dr. Anant Kumar, Chairman, Urology, Renal Transplantation, Uro-Oncology and Robotics. He was formerly Professor Head of Urology at SGPGI Lucknow. At present, he is with Max Hospitals at New Delhi. I think, and of course, Georgie Abraham, again, he has not joined, but well, we hope that he'll be able to join. He's a professor at Department of Nephrology, MGM Healthcare, Chennai. We also have our two speakers on the channel. And without wasting time, I think we'll start with our panel discussion. And let me put my first question to Dr. Sandeep Guleria. What is the disease donor cadaver transplantation? Can you briefly describe what when we say that we are talking about cadaver transplantation?
So when we talk, I think it's, anyway, hi, Georgie, welcome. You missed your introduction, but to come back to your question, when we talk about diseased organ transplantation, we have to understand that we're either talking about a brain, about a person who's had a cardiac death, or a person who is brain dead, right? So there are two types of cadaver organs that you can get. You can get them from a heart-beating donor or a non-heart-beating donor. When you refer to a heart-beating donor, you're basically referring to a brain-dead cadaveric donor, which means somebody who has most probably died in a hospital, has suffered irreversible brain damage. All the tests to look at brain function are negative, which mean are positive, which means he has no gag reflex, his pupils don't react, he has apnea, his ABGs say that his brain is not working. So you now have a controlled environment where you can harvest his organs, which means you have time, you can build him up, you can make sure the viral markers are done properly, you can even do a cross match, even study him higher. So that's a heart-beating, brain-dead organ donor. The other donor is a non-heart-beating donor. These are donors who just come to the casualty or the emergency of a big hospital, and crash while being resuscitated. So here you don't have time. Resuscitation starts immediately. And if the family agrees, which is difficult to get through sometimes, you could actually take non-heart beating organs, usually reserved for the kidneys, but there have been numerous examples in literature where even the livers have been taken.
Thank you, Sandeep. So friends, you must understand that it's the brain that controls life. Over the ages, we have been told that when heart stops, patient dies. In fact, it's the brain. And that's why there's a concept of brain death. May I request Dr. Georgie Abraham to talk a little about this brain death in a simple language for people to understand, and how this diagnosis is done. Though Sandeep has slightly touched the topic, but to reinforce, can Georgie help us?
Yes, we have been doing brain death disease donor transplantation from 1975. My esteemed colleague, Dr. Sunil Shroff, and we have put the momentum into that when we were in Ramachandra Medical College. So when you say a person is brain dead, it could be due to various reasons. One is road traffic accident. It could be due to an intracerebral hemorrhage. It could be due to poisoning, whereby we have used cobra bite victims' kidney for transplantation, or it could be organophosphorus poison. So there are various causes of brain death. So when we look at a brain death, the patient doesn't have any brain functions because the brain is completely devoid of any oxygen and blood supply to the brain. And all the reflexes, as Sandeep said, pupils are not reacting to light, and also the patient do not have any spontaneous respiration, and the gag reflex is absent. And this can be confirmed in the case of a brain death individual by two people assessing the potential donor over a period of time and confirming with an EEG, or in the extreme cases, you can do even an angiogram of the brain blood vessels to show that there is no blood flow to the brain at all. So a brain death individual can also be due to poisoning. In that case, we should leave enough time that the patient, is he recovering or not? If he is not recovering, the brain death certification can be made. So in short, there is absolutely no blood flow to the brain. All brain functions have ceased, but the heart is still beating over a period of time. This is what is a brain death individual who can be taken up for an organ donation.
Over to Sundar.
The next, I think, question I would ask about to Sunil again, because Sunil is the one who actually pioneered the concept of NGO for organ donation. And before Sunil actually came into my life in transplant, we never had the concept of something called transplant coordinator. And I think I would ask Sunil whether he can tell us about the role of transplant coordinator. He's doing a lot of training programs, and I think that is important. The other great thing which Sunil has done is about the donor card. We have, in the license, we put, I'm an organ donor. What is the legal sanctity of this? Suppose today I have actually got in my license that I'm willing to be an organ donor. Is that legally accepted? Can my son say tomorrow, no, my father cannot donate? I mean, this occurs regularly. And even about a couple of years ago, we had a potential organ donor. Everybody was ready, but one son refused to donate, saying that it was Amavasya and the organ cannot be taken. So these are some of the problems I would request Sunil to address.
Thank you, Sundar. Am I audible, Umesh and Sundar?
Yes.
Yeah, thank you. Thank you for inviting me thanks to IMA, thanks to Dr. Bali and Dr. Agarwal for doing this. First question, Sundar, I wanted to just answer before I go forward for the transplant coordinator in their role, was Umesh's question, which Georgie, of course, has answered very well. In simple language, how would you describe brain death? And this is a very important concept to understand for practitioners out there, because many times what happens is the patient's relatives, a patient who is brain dead, their relatives will go and ask the practitioner, and what is brain death they're saying, and should we donate organs or not? So in simple terms, brain death can be described like you have a computer. Computer consists of motherboard and a hard drive. If you take out the motherboard from the computer, you can switch it on, it will never work. Same thing with the body. If your motherboard is gone, your brain, the thinking area is gone, there's no coming back. And that's what happens in brain death. So it's a conditioned death where, not conditioned, I mean, it's a controlled death situation where, your heart and lungs are beating, but your brain is completely gone. And this is certified by twice by four doctors, 6 hours apart, to declare brain death. So this is a very foolproof method of declaring brain death. So you can be very sure that if somebody is declared brain death by 4 doctors twice, then there's no coming back, So that is much very clear. And you can use simple descriptions of computer, motherboard, and hard drive, so on, to explain to the patient's relatives. Coming back to Sundar's questions regarding the role of transplant coordinators. So when we started this program in 1995, we found that for the first 5 years, we had very few donations happening in the country. And when we looked at the reason for low donation rate was, we felt that, the families in this brain death situation who are extremely grieved are not fully supported in their decision to donate. So when I joined this program in 95, I had worked in England for 12 years and seen the whole cadaver program happen in England. So when I joined this program, I saw what was happening in India, my personal feeling was that we needed a healthcare worker who was an interim force to help the doctors, but doctors are generally very busy, especially this happens in intensive care, and intensive care is the busiest place in the hospital. So what we found was that the family was not being given the opportunity with a discussion or not being supported for a decision to donate. And that's where the role of these transplant coordinators or grief counselors come in. They speak to the family right from the time, let's say a person gets admitted in the ICU. From there on, they are with the family right till the end. And when these coordinators support the family, we have found that the decision to donate becomes easier. The families are better empowered. And many of the families, we say no to donation becomes yes gradually. It's because they're in extreme grief when a loved one is lost. And in that situation, to go and ask for organs is the most difficult task. And somebody has to do this dirty job. Who's going to do it? And doctors are not necessarily trained into this. So it requires special skill sets. And this is what we found in the first 5-7 years of this program in India, that we were doing donations, but very few. It was just episodic, Whereas, the brain deaths were so common because we had such a huge load of road traffic accident deaths in the country. So this is why we felt that the transplant coordinator is very important on the ground to support these families for when in their decision to donate. And then we, after so many years of training, when we did a study of looking at the conversion rate of these brain deaths, going to say yes for donation, we found that whether it's a government hospital or a private hospital, if you have a trained transplant coordinator who's been enough trained, the conversion rate was 67 to 68%. 67% was as good as any Western world. So if you have trained transplant coordinators, it makes a lot of difference in the program. And that's the reason, if you see from the year 2012, when we did only 196 donations, to year 2017, when we did close to 1,000 donations, our donation rate went so 5 times in 5 years, because you had a huge force of these transplant coordinators working in different ICUs, supporting the families, helping the families to take decisions. And that's why they play a pivotal role in this program. So this is about transplant coordinator. Regarding the donor card, I think we can take the question as we go forward, because this is an evolving program. It is not that it can happen overnight. And it's a very complex program, especially the disease donation program, because it happens in an emergency situation. It is not like an elective surgery of a living kidney transplant. And in that emergency situation, a lot of activities takes place. So you need a very coordinated team effort to happen. And India has definitely improved from what we were way back in 95, 97 to what we are today. We are much better, equipped with our hospitals, with our infrastructure, with our teams. What we need to do is that, we are creating green corridors within, on the roads now. But what we need to do is create green corridors within the hospital to make donations happen. Donor card is just a mere instrument of expression of interest, of your willingness to donate. It is not a legal kind of document. You still need an informed consent in this country. It is not, we don't live on presumed consent in this country. So this is just an expression of interest. It is just a way to break ice between the donor, family, and the ICU consultant or the coordinator to start the discussion on organ donation. It's not a foolproof method. In our country, we have huge population, 140 crore people. If you issue so many donor cards, you won't be able to even service them. So what is more important than a donor card is to inform your next of kin that you wish to donate, that you want to donate. You know, today I got a message from Dr. Colonel Ram Prasad, who is in Chennai, who lost his father. He didn't even realize that his father was carrying a donor card from our foundation. He just sent me a picture. So it is more important to inform the next of kin that you wish to donate your organs, more than even carrying a donor card. Donor card is like an ambassador. You know, you are carrying a donor card, you can be an ambassador of the program. Thank you.
Thank you, Sil. Oza, you can ask. Umesh.
Dr. Anand Kumar, I think it's important to understand that you must have faced, there are so many myths and misconceptions about this brain death. Is coma same as brain death? Also, the question arises that once somebody is declared brain death, are all brain death patients fit for organ or organ donation? I think these are some issues which you face. One, you have been told that there is a brain death patient in ICU. Your view on this?
Yeah, thank you for IMA for inviting me for this wonderful workshop and panel discussion. The question is very relevant because the public, they understand the word coma. And the coma, as you know, that has a different grade. Like all you know, there is a Glasgow score. So we tell the patient that there is a different grade of the coma. And when we say the patient is brain dead, that is the last stage of the coma. Now the patient brain is dead and there is no reflexes are possible. And we also tell the patient in that stage, no person will be alive more than 3-4 days. Most of them will die within 48 hours, even if the best possible ICU care is provided, they are ventilated, everything is supported, except children may go up to 5 to 7 days. But rest of the people will succumb within 2-3 days. And this is the window we can use it. So in coma, we do the test. And these tests, if shows that some part of the brain is alive, some reflexes are present, then we don't do the donation. We only do the donation, ask for donation when the brain is completely dead. And there are tests all over the world. They are recognized tests, also recognized by the government of India. If these tests are negative, then we know that patient is brain dead and he will not survive whatever you may do. And this is the opportunity you can take to donate the organ. And that what the way when we describe it and we tell them, then they understand. And it is also, they ask all these questions that patient is breathing, heart is beating. So we tell them brain is dead, and brain, as you said, governs the body. But very soon, even if ventilator is on, all the IV fluids are on, patient will die. And all brain dead donors are, all the brain dead patients are not the donor, because we have to see, we are going to take the organs, whether those organs are fit or not. Suppose patient donor, brain dead donor has infection, which can be transmitted to the recipient, then we don't do, because we don't want to risk the life of the recipient. Suppose the donor has some cancer which can spread in any part of the organ, except some type of the brain cancer can be allowed because they do not spread beyond the brain to the body. And suppose his kidneys are not good, kidney function is not very good, and like there is some degree we have idea to know whether this kidney will work or not. If liver is bad, heart is bad, number of times, even if patient is young, they do the cardiac surgeon, they do the echo. If heart is not good, then they will not take it. So apart from that, we make assessment. Is there any infection? Is there any cancer? Is there any things which will harm the recipient? Then we don't do the donation. One of the organ which can almost always be donated is the eye, even in the old age or anything, because even if there is other diseases, eye can also be donated. And we have a investigation or test to find out whether kidneys are reasonably okay, whether liver is reasonably okay, heart is okay, lungs are okay. And then it is decided, yes, we can take out this. So sometimes we take only kidney, sometimes we take kidney and liver, sometimes we take other organs like liver, kidney, heart, lungs. So that depends on the suitability of the organs for donation.
Thank you very much, Anand. Discussion, the message which I would like to reinforce, we must be very clear in our mind. Brain death is death. I think if imprinted on our mind, there'll be no doubt in anybody's mind. And this is proved beyond doubt by scientific community over the ages. The second point is certification of brain death is done by 4 independent people, where people doing transplants are not involved. So it's a very transparent system, and the fear that because somebody wants organs, they can bypass this certification is just not possible. I think that's the second thing which must be very clear. The third point is many times relatives come and say, well, you are saying patient is dead, but his machine is working. His monitor is showing some activity. He is warm. Let us be very clear. Once patient is certified brain death, we use ventilator only to oxygenate organs in a dead patient so that these organs are viable till we do transplants. So I think if these concepts are clear in your mind, because why it's important for you to understand, patients' relatives will come and ask you and not to us. They may have doubt in us, but they will not have doubt in you. But if you are not aware and not give appropriate answers, it means losing a cadaver, losing so many organs, and losing so many patients a chance of second life. Sundar.
I think, Anand, you raised the point about eye donation. I think it's a very important point. A few months ago, I lost my mother, and she died of old age at home, and we donated eyes. And actually, we donated the entire body for medical education at the Rama Medical College. And that is one option. So the other thing which I would like to ask Vinant, you mentioned that Munna Bhai didn't have a donor and he had to go for various options. And you mentioned about one in passing about the deceased donor transplant. But I would like to know what can actually Munna Bhai do? How does he register for a cadaver transplant? And what is the role of intensivist ICU doctors in this? And what are the medico-legal formalities? The other question, as Woza rightly said, is regularly, even though I keep getting messages, Mr. Sudhir has lost his wife and kidneys are available, please contact. And this comes from doctors and my own transplant. And this is going on for 5 years. Same Sudhir, same number is going on for 5 years. So I would request all the people watching, please don't forward such messages. It is not correct. It's not possible to do such cadaver transplant. You can't pre-arrange like that. So I would ask Vinant, what should Munna Bhai actually do? How does the process go on for the cadaver or disease donor registration? Vinant, please go ahead.
Thank you, sir, for picking up this very, very relevant question here. First of all, I will ask Munna Bhai not to look into Mr. Sudhir's message. That's one thing. Number two would be, it's a very simple process now after the NOTO was set up in 2011, in which it says very clearly that you need to go to a certified specialist who will first certify and see that you have renal dysfunction and that you fit into the category of receiving an organ transplant, which is obviously a kidney transplant over here. And then he also directs you to the transplant coordinator, or he directs you to the point in which you can register through the transplant coordinator for a disease organ. So for that, you need to go, what the coordinator is going to do is that he's going to put you into the right channel and put you onto the NOTO website, and he's going to make you fill a form along with what Dr. Dave has told us, with a lot of certification that has to be done. But primarily, it has been simplified now to use of just an identification card, as well as a proof of your blood group. So once that is done and you are notified onto the NOTO website, then according to the there is some grading system in which you get some points. So depending on the number of years that you have been on dialysis, or whether what your age is, so younger the age, the higher the points. The more the number of years on dialysis, the more requirement of yours is to have a transplantation, you get higher points. If you have failed vascular accesses, you cannot be put on long-term dialysis, you have higher points. You've had a failed renal allograft in the past, and you need an urgent transplant right now because of the reason that you cannot be dialyzed because you don't have good accesses, because you've already exhausted your accesses in the previous dialysis procedure, then again you get higher points. And you also do get points if you're sensitized. So if you have a very high donor-specific antibody, or as simplified as panel reactive antigen antibodies, so for every 10% increase in the percentage of PRA, you get 0.5 point extra. So in the end, with the tally of the number of points that you have a fair system in which the NOTO knows exactly what is your stage and what is your requirement. There is also a procedure which is also called as an urgent transplantation. And that is the prerogative, obviously, of the members of the NOTO. So once the NOTO is notified, then you have different centers depending on which region you come from. And you have subgroupings called as the ROTO, which is a regional center, and the SOTO, which is a state center. And the SOTO has to keep on, they have to every 3 monthly, they have to report to the ROTO as well as to the NOTO about the different kind of urgent transplantation recipients that they have. So once he's registered with the NOTO and once he's put up on the list, then he has to wait. And once there is a prospective donor, now it also depends on the center where he gets enrolled, whether his center is primarily just a retrieval center or whether it's an organ transplantation center. Because if he gets notified, if he gets enrolled through an organ transplantation center, the NOTO gives you the prerogative to keep one organ with yourself and one organ can be sent outside. That could be any organ. So now if on his own center, within the number of people who have registered in his own center, if his point system is on the higher side, then that's the time when he is notified and he's worked up for a transplantation. So once that happens, then he enters into the transplantation. He has to fill a couple of forms. Some authorization has to be taken on urgent basis, and then he undergoes the kidney transplantation. So it's a very simplified process as compared to what used to be before. And it has also ensured that messages from Mr. Sudhir and all are disregarded. And we understand that and it's been shown also that after all this was set up, there has been a substantial increase in the number of transplantations, the legal ones at least. And the people who cannot walk into the racket of people who do organ transplantation trade, they are given a justified means of receiving an organ now.
So Sandeep, I think if you could expand, Sandeep, if you could little expand on.
I just wanted to ask. Yeah.
NOTO, SOTO, ROTO, and of course you want to give.
Umesh, thank you, but I just want to ask you one thing, and in the room which we must sort out. And that is, Munna Bhai may also have somebody who might say, well, look, I can send you to some place where you can get an unrelated kidney with some amount of money. And let's not just brush it under the carpet. We all know it happens. And we know it does. So I just wonder what you have to say about that, Vinand. What do you say about the organ trade in India?
Well, sir, the more you say, the more there is to it. So I think we shouldn't be really encouraging such kind of a trade. And that's the reason why we are having this meeting here, so that we make people aware of the fact that there is a flourishing trade of organ. There's a racket which goes on in all countries. It's not just in our country. And unfortunately, or fortunately, there are patients who get benefited from it, but in the long run, it is not a very healthy system for the way the donors are treated. And it's totally unethical. And you can be booked again under the Organ Transplantation Act, and you could have serious outcomes from it.
Can I just add?
Yeah, I think that's a very good point, Vinand. That it's illegal. You're as much responsible if you go and buy a kidney, and you could get checked out, and it's absolutely end up getting your in a small seedy hospital. You could actually die and you wouldn't know what to do. So for all practical purposes, all Indian societies would strongly live related or unrelated transplant or organ transplant. I'm going to hand
Ramesh.
Sandeep, your voice was cracking. Now, I think in the same context, many people ask these questions. Will there be any incentive paid to the cadaver transplant donor relatives? I think this is again a question that comes up. So can you and Sunil clarify that is there role for any incentive or other benefits which are given to the family of the cadaver donor?
I would actually say remove the disincentive. There are a lot of disincentives for any donation, whether live donation or cadaver donation. I know families who have donated. I had a transplant patient of mine. He had a cadaver transplant. His own son died in a hospital, and he told me, if I had not had a transplant myself, I would never have allowed my son's body for cadaver donation because the process was so difficult. So there are a lot of disincentives. So forget incentive, whether it's live donor or cadaver. There are a lot of disincentives. Should we first address that and remove those disincentives? What's your take, Sandeep and Sunil?
Sandeep, you want to go first?
No, Sunil, you go first. I couldn't hear most of the question. I think my connection isn't very good.
I think, absolutely, Sundar, you're absolutely right that we have to make it easier for families to donate. The whole procedure can be very difficult, donation sometimes, and it is going to take time. One of the worries which we have in our country is with organ commerce, and the law actually wants to protect obviously the common man so that he doesn't get cheated. And today, with all the media hype on organ commerce, you switch on your television, you see all this organ commerce happening so rampantly. They describe it, dramatize it. Sometimes, of course, obviously, it's all fiction. It's not possible. But that kind of leaves an impression on the mind of the people that taking out a kidney is very easy. It's like changing the tire, of a car. It's as simple as that. That's how they describe it. So the general perception is of deception. And that's the reason why the law is, in fact, have one of the toughest laws in the world. I've read many laws, and I think ours is the most tough law. And I think the reason is to protect the common man. And also, remember that most of the donations which are happening in our country are happening only in corporate or private hospitals. Only 10% of disease donations are happening in government sector. So there is an imbalance in the equity, in the access. So what's happening is today, if you're rich, you get a transplant. If you're poor, you die. Another kind of disincentive, if you look at the largest disincentive, towards donation, a common man will say, why should I donate if my organs are going to go to the rich? So we need to take care of this equity if we really want to go forward in this country and balance this so that, today we have 260 medical colleges in this country, government medical colleges, and there are another 300, private medical colleges. All government medical colleges are, have enough infrastructure, enough manpower to do transplants, at least kidney transplants. So we need to look at these small ways of improving, the access to transplants, to, take care of the trust, factor in this program, which is hugely missing. And that's why you have all these disincentives in this program. I also want to address one more point here of what Dr. Dave was saying regarding, when you asked about how do you enlist for a cadaver donor. Remember, for a kidney, also it is, those criteria of, getting a kidney is first to the city, then to the state, then to the region, and then nationally. I can tell you, in the last 25 years, there have been very few instances where a kidney has flown out of one city or one state to another state. It is mostly to do with liver and heart, where the noto's role becomes supreme in the organ allocation. Whereas when kidney is concerned, to register, you just need to go to your nephrologist and register in that hospital for your transplant, if it's a transplant center. So, and kidney will, most likely the kidney will come from your own state and will be given to you. So there are also state waiting lists which are there in many states, including Maharashtra for that matter. So you need to register in that state, and that state will forward your name to the national registry. But with kidneys, the chances are very unlikely that the kidney will come from outside of the state. Just remember that. So this is my answer to the disincentive and to the allocation thing. On the
yes, can your quick comment?
A lot of times we get calls from our dialysis patients where a near relative is dying, and he might just call up saying that, I'm quite low down on the waiting list. Can I take his kidney? Can his kidney be given to me? And that's a very common scenario which we encounter. When we talk about incentives, it is our duty as nephrologists and further there, incentives can be kept there where someone's near relative is donating or ends up as a cadaver donor. This dialysis patient should get a priority later when he is enlisted on the list. Where I understand a lot of
we have done that many times in India, and many times we've not done it also. It is on case basis, but we need to have guidelines for this, and we actually requested. In fact, we are having a directed donation, symposium happening just in 2 weeks' time again, and we are hoping that Noto will come up with the national guidelines, because at the moment the last two or three directed donations have been disallowed.
To the court, I think they've gone to court. They've gone to court and then to the court.
Disallowed, but I think it is again an evolving field. Hopefully, again, the Noto will come in and we'll get some guidelines from Noto, and then you will have this opportunity where something like this can go through.
So just make it clear for the audience. At present, legally, incentives are not allowed.
Yes, absolutely.
Second point, which is clear, nobody can decide who will get the organs from the donor. You cannot insist that it should come only to my relatives, because legally it is not allowed. There is a system in place which is a very transparent system by Noto, Soto, and Roto, which decides the list is on the computer. It is the transparent coordinator. As per the rules, they decide who is the right recipient, and only they are given the organs. So at present, there is no way anybody can bypass this system. And this is done to create a transparency in the system, so no influential people can bypass this system and poor people suffer because they get organs. So let me assure you, at present, the system which works is very transparent, and only the Noto, Soto, Roto people can decide as per the list on the computer who will get the organs. Now, the next questions to Dr. Georgie. What is the role of intensivist and ICCU staff? Because I think they are a very important component of the whole system.
You're muted, Georgie.
Georgie, you're muted. You have to unmute.
Yes, can you hear me?
Yes.
Since we have initiated the deceased donor transplantation in 1995, the intensives and the ICU doctor plays a major role in maintaining the brain death individual in a viable situation so that these organs can be used. So the most important thing is to maintain the euvolemia, because a lot of them develop diabetes insipidus and they will be peeing and peeing and peeing, going into hypotension. So this has to be taken into consideration. And if necessary, we may have to use drugs to reduce the polyuria due to diabetes insipidus. Next one is to prevent infection, because most of these patients are on ventilator, and ventilator-associated pneumonia is not an uncommon thing in our situation. So to prevent infection, the ICU and the intensivist plays a major role, and appropriate antibiotic therapy should be tailored as per the need of the patient when it is necessary. Number three is some of the older donors above the age of 50, they may also have associated coronary artery disease. So it is possible that during this brainstorm of brain death, they could activate a lot of cytokines, and this can trigger off a coronary artery or a myocardial infarction. So the ICU is, along with the cardiologist, plays a major role. The next one is that to prevent ischemia to the other organs, because we are using vasopressors, and these vasopressors can have an effect on the other organs which are also suitable for donation. So this should be taken into consideration by the ICUist. And then the ICUist should be speaking to the relative, the close relatives of the patient, to maintain a communication channel so that they are being informed about from morning till evening, the state of the donor, prospective donor, so that they can establish a rapport with the patient's relatives, which will help a lot of the time in transplant coordinator stepping in and doing their work. So I think that these are the most important things one should take into consideration, and the ICUist and the intensivist plays a major role in maintaining the prospective donor.
That's right, because the patient is dead, the organs are to be put in the live recipients. So in fact, there's a great responsibility of everybody looking after this cadaver to make sure that these organs are healthy, surviving well, because so many people's life will depend on this organ. So they have a great responsibility. And now the main problem starts. I wouldn't say problem, but the big cycle starts and is a multi-organ retrieval. Anand, can you give us an idea, once you get a call that there is a brain death patient in ICU, how the cycle starts? How do you really start working about the retrieval of organs? And of course, Sandeep will chip into that for the maintenance of the organs and the transport of the organs. I think this is a big challenge because we must understand that time is a very important factor. Patient is brain dead, but the organs are being perfused with oxygen to ventilator. But anytime this patient can collapse. And if that happens, you have lost all the chance of getting good organs. So this window is so important, and all these activities which I described and which our two panelists are going to describe has to be in this time frame. And why I'm mentioning that decision making is very important, where your help is needed to help the patient's relatives take decision in time so that these organs remain viable for the transplantation. Anand.
Yeah, once we know there is a brain death is there, first brain death is done. So we, the multi-specialty team, try to assess which organs can be taken out. So the cardiologist, cardiac transplant surgeon, liver transplant surgeon, kidney transplant surgeon, lung transplant surgeon, they assess. And if they feel these organs are taken out, then can be used, then NOTO is informed. And as per the policy, they will come to know, yes, you will keep one kidney, this kidney will go somewhere else, this liver will be used by you or by other hospital, heart will go somewhere else, lungs will go somewhere else. So that part of the job of the NOTO to decide where the organ will be distributed. Our job is, while these decisions are made, those other centers are informed, make sure that ICU team and transplant team make sure that donor is maintained, is nicely perfused, and other things are, other process are continued, like finding out his HLA, or sorry, is a cross match to be done, samples to be taken out for cross match, samples to be stored to be sent to other center for cross match, blood group and other information to be given to those centers where these organs will be going. From those two centers should have exchange of information about the organ, whether they are happy to accept it or not. So all these things are done with the center, and NOTO and other center, they coordinate. As soon as the second brain death is defined and patient is signed that just the brain death is done, consent is taken, then patient is, then no more time is wasted unless some team is coming, like cardiac team is coming, they said they are take 2 hours to reach, so that the time is waited for them. But if the donor is crashing, then donor is immediately shifted to the patient and organ retrieval is starts. And invariably there are, the two centers will have some degree of coordination, like my center can take out the heart and liver and other organs and give it to the others, or if they insist to come there and it is not possible, then our centers will take out the organ, perfuse, flush, stored, and keep all the information of the retrieval information about the organ is good, bad, or whatever, liver is looking fatty or not. So all those information is given, and then organs are taken out. And there is a system of doing the multi-organ retrieval. There is a definite guidelines, like first usually the heart surgeon will check the heart, and abdomen will open, liver surgeon will check it, the heart. Unfortunately, kidney surgeons will get the last chance to step in, but they are standby, and they are there waiting patiently for big brothers to take out the organs, and then we take out the kidney. So this is all coordination is required. The whole idea is that as much organ which is usable should be retrieved. It will be nicely preserved and perfused, all the information about this to be shared with the center which are going to be used, and the organs should be transported with the help of the police and administration, green corridor or air ambulance to the centers, so that organ can be used as soon as possible and more people get the lease of life.
So Sandeep, can you expand on this about the challenges? Also, you are the first person to do in subcontinent kidney pancreas transplantation. So when the multi-organs are involved, what are the challenges in, say, preservation, preparing the team, transport, etc.?
So see, Dr. Anant has really covered most of these things, but I think communication will always remain the key, especially for the abdominal organ transplant teams, because if you are, the first thing is, of course, there will come a time when you have to, when the ICU will have to decide that the man is now brain dead, he has been twice certified, and at that time, everything will now concentrate on making sure that you can get the organs in the best possible condition. This might include sending blood cultures, doing the virology markers, making sure, like Anand said, that you've got his blood for a cross match, and of course, measuring the urine osmolality, seeing his liver function tests. Once he's in the operation theater, then it is the cardiac team that takes first priority, because the heart is most vulnerable to ischemia. So they will first come in, and they will, a long incision is made from the xiphoid right down to the pelvis. And after that, of course, the cardiac team will start getting their dissection in, and the liver team will start getting their lines in. Remember, your first issue when you are for a cadaver retrieval is to secure your perfusion catheters in, which means since the liver has a dual blood supply, you must get a cannula into the aorta and into one major branch of the portal vein, which could either be the superior mesenteric or the inferior mesenteric. For the kidneys, it's not much of an issue because the kidneys only have one blood supply. And once you've connected all this, all teams are ready. The organs are sequentially harvested. It is the heart which takes the first right. The liver is then divided between the kidney and the pancreas team, because there's a little bit of crux when fighting upon the artery that comes, and that's the splenic artery, and dividing it just distal to the origin of the common hepatic artery. So you can actually talk this out with your liver team, how much pancreas, how much on the arterial supply, and it's all very easily possible. Even if they do take more, you can actually use an arterial graft to increase the length of your superior mesenteric as well as the splenic artery to make a common graft. That's not much of a problem. The kidneys are taken out last, but remember, once you take out these organs, they're put in cold solution. Most of them are reflushed. Again, communication is shared with the transplant team, which is at the other hospital, to tell them how these organs look like, whether they are worth transplanting or not. They are then actually idly packed in a sterile plastic bag with a little bit of perfusing fluid, and then immersed in an ice box, and then taken away and then taken away to the transplant center for transplantation. But the essence of all this, yeah.
Sandeep, the common question is how much time is available or safe before you do organ transplant, be it heart, liver, kidney, because that's a question, how long these organs can survive before you reperfuse them.
So most people will say that for the heart, you have about 6 to 8 hours. The liver should go in, they say, within 12 to 24 hours, but most people will cut it at 12 hours. The kidney, of course, gives us more time. If you remember, kidneys were flown in transatlantic from the US to England. I myself have seen these kidneys languishing for more than 24 to 48 hours. You might have a higher incidence of primary non-function, but they do open up. But it is best to put all these organs within 24 hours if you don't want to have a stormy post-operative period.
Thank you very much. So friends, you must have realized, sorry,
the earlier
Sandeep,
you put them in, the earlier you put them in, the better for the recipient, because the better they start working, the less is the reperfusion injury, and therefore organs will work better if they're transplanted as fast as possible. Sir.
So you must have realized in such a short time.
I just wanted to add something to Sandeep said. Please collect enough blood from the donor so that they may recur cross-match with multiple recipients. So please make that sure that you collect enough blood, and also, if possible, a piece of the spleen. to prevent and later on, the cross-match issues.
Right. So what I was
Valid
trying
point.
to say is that you can see that urologists, nephrologists, transplant surgeons are in the front line. But how many people have to work at the backstage, you will realize. It's a big undertaking because you have to get all the patients, you have to prepare them, you have to prepare theaters, and all this happens at midnight most of the time. And you understand, be it administration, be it nurses, be it ward boys. I think it's a big teamwork, which is the most important and key to the success of cadaver transplantation. So it's a big challenge. And unless everybody works, be it police, be it administration, be it physicians, cardiologists, it cannot be a successful program. Over to Sundar.
I think we're coming over the end of the panel discussion. The one important question which comes to our mind is, what are the results and complications of transplant? I know I will ask this first turn to either Keyur first. My own, I keep reading this regularly. What is the success of transplant? We have been in the field for the last 40 years and transplant is going on from 1950s. Transplant is like marriage. It's a boon for many, curse for some, a risk for all. So if you have a good successful transplant, it's a blessing. But if you have a rejection, infection, it's like having a nagging husband or wife, it's a curse. But most of us have taken the risk of marriage. I'm sure most patients would want to take the risk of transplant. So I would pass on to Keyur. What is your take on the results, complication, and roughly the cost of transplant? It varies, I know, from a government setup. And even in my own hospital in Bangalore, I have 10 Manipal hospitals, and the rate is not same. One Manipal is different from other. And what is the quality of life of transplant? I'm sure both of you discussed this. The best quality of life is a successful transplant. I would want you to reiterate a few facts on this. Please, Keyur first.
Thanks, sir. I'm glad you asked this question. You know, I recall a famous line which my teacher, Dr. Gandhi, would always, tell his patients. So if dialysis is a headache, then transplant is a stomachache, is what he would say. So obviously, yes, for all those people who want to feel that, transplant is the end and now, you can be carefree, that is not the essence of transplant. But what it ensures is a good quality of life, a good longevity of life. And, as I and Dr. Vinant both we ably demonstrated, there is enough data now which supports that transplant ensures that the patient has a longer life and an event-free life. And, in terms of cardiovascular morbidity, mortality, overall, transplant ensures excellent results. Why are we so scared about transplants? It's because we need to use immunosuppressive medications. Now, we have excellent data where we're doing ABO incompatible transplants. We are doing highly sensitized transplants. But each time, especially in India, we are extremely circumspect about infections. We need to cover up for infections. And once we win over infections, our transplant outcomes are even going to be better. And that kind of comes from our own roots. We teach our transplant patients to enforce good lifestyle changes, to ensure good cleanliness. In fact, I would want to tell all the general physicians, even a recipient usually stays in the hospital about 15 days. A patient is mobilized within, the second day or the third day. Why this prolonged course? We are always monitoring how his kidney function is happening. But at the same time, the transplant nurse, the transplant unit is constantly talking to the patient to enforce upon the precautions that he needs to take. The things that he needs to be careful about is medications. The medication is not, the knowledge is given to the patient. The good lifestyle changes that he needs to implement once he goes home are always driven into the patient. If the patient, continues this, transplant is a boon, because other than being regular with his medications, he has a good life. He doesn't have to stick to a dialysis unit where he spends 12 hours in a week, sitting there with his life bound. He is free to do everything. So it's a good life that is ensured post-transplant that kind of stands out. Coming to the second question, which Dr. Sundar asked, is regarding the cost. Now, as he said, it varies from center to center. If I come from the city of Bombay, so in a government setup, also with all immunosuppressive medications not readily available, a patient easily spends about a lakh and a half, or around 2 lakhs. When it comes to a private setup, the cost runs anywhere between, say, 5 lakh of rupees to about 8 lakh of rupees, depending on the kind of investigations that we do, the kind of the sensitization that we're looking at, and that we're there. But again, I would want to, not discourage people. We need to encourage people with transplants. Why? Because there are suitable mechanisms now where these patients can be helped. So say if I have a patient who is not able to afford, say 3 lakhs or 4 lakhs per se for his transplant and is getting stuck with his finances. Now you have a lot of NGOs, a lot of institutes which are willing to donate to such patients. Now, recently I had a transplant, a patient, a surgery that was done. Patient fell short by about 3 lakh of rupees as far as the budget was allocated. My transplant coordinator, this is the role of the transplant coordinator. He helps the patient out with finances. He puts the cases to various NGOs. The NGOs are ready to help. A lot of patients have an underlying insurance, but you kind of help the insurance. Insurance money helps. Along with these, NGOs are willing to contribute. So now finances is actually not a burden as far as transplant cost is concerned. In fact, with a lot of help now, the transplant costs are coming down. A lot of poor patients are being able to manage transplants, be it cadaver transplant, be it live donor transplants. And it is our duty to encourage transplants more than dialysis in terms of longevity in such patients.
Thank you, Keyur. Now we are going to the chat box. There are a lot of questions, interesting questions, but some of the common questions asked is, I think I would address this first to Anand. The question is, common question is whether males can donate kidney to the female can donate to male. Because when I got trained in 1982 in Vellore, before MGR had kidney failure, most of the time hydrocele or testicular swelling will come as kidney swelling, and they will always say, man can donate kidney, because they always thought scrotum was the kidney and the women cannot donate. So that was a misconception. It changed. After MGR, the whole thing changed. I would just say about MGR disease, and now we say Rajinikanth disease. There's a different story. The patient will immediately say, do you want me to give transplant? Do you want me to go for PD or HD? So your thoughts, Anand, for the general public and to our IMA colleagues, is there any difference between man donating should donate to women or women donating to man? What is your take?
The simple answer is men can donate to female, female can donate to male. And that's only thing, organs are precious, whatever is available, that should be done. And there is no problem in donation between the two sexes.
Okay, thank you, Anand. And I go to next to Sandeep. The question commonly asked is, in live donor situation, is it safe to donate kidney? Is the lifespan same with a single kidney? I know I keep talking to many people. I keep giving the example, 1 in 1,000 is born with one kidney. Vajpayee had only one kidney. That is a common thing. But in your practice over 30 years, what would be your recommendation? Is kidney donation safe? Is lifespan and the quality of life same after kidney donation? Your thoughts, please.
I think it's important to remember that the most important person in this entire crux of transplantation, especially in a live related program, is the donor. And we will turn the donor inside out. We will look at all his tests. And only if we are sure his GFR is good, he has very good, he has hardly any proteinuria, his blood pressure is well controlled, and he has no diabetes, will we take him as a donor. Having said that, we also do understand that in a country like India, where the pressure of donation is high, we will end up taking some marginal donors who may be having some little ambiguity or the other, like borderline diabetes, a little bit of hypertension. But remember, normally donors are extremely well screened and are unlikely to have any major problem for the rest of their life. Having said that, the incidence of renal failure in donors is equal to the normal population. 1 in 300 will have a procedure after the donation, might need to go back to theatre for another procedure. And 1 in 10,000 can have a serious complication during the procedure, which can sometimes lead to loss of life. So it's not an operation to be taken lightly. It is a major chapter in your life to give a kidney to someone you love. It's not going to harm you if everything goes well, but there are risks involved with organ donation, which you must understand. And that's why we always say, well, think about it and then come back to us.
Thank you, Sandeep. I would like to go to Georgie. I mean, Georgie is, in the introduction, I forgot to mention that he's considered the father of CAPD, my senior in college. And Georgie, you have to unmute yourself. The question, please unmute. The question commonly asked is, we had a debate on this. Is there any age limit for transplantation? Would you offer a kidney transplant for somebody who's 80? And the same way, would you take a kidney from somebody who's 80 years old? What is your take on elderly people getting transplant, elderly people being donors? This is a common question because we know commonly 65 is the cutoff, but all of us have taken over 80, 80 plus, either as donor or recipient. What is your opinion and what is your take on this important point?
Regarding the recipient, there is something called chronological age and biological age. So I understand that even in developed countries, they are doing transplants in recipients who are 80 and above, who have been on the waiting list for quite some time. As long as they do not have any malignancy, they don't have any significant coronary artery disease, and they are not demented, and they don't have any other major issues which can lead to complications after the transplant. So that question becomes very relevant, that age we have increased. Previously, we were not transplanting patient recipients above the age of 50. Now we have gone up to 70, 75, and 80. Now regarding the donor, we have used parents as donors, especially father or mother as donors, and we look at their GFR and look at their comorbidities, and then we take them as donors. But one should keep in mind that from the age of 40, there is a drop in the GFR by about 8 to 10% every decade. So this has to be kept in mind, when you are choosing a donor. For example, recently we had a father who wanted to donate to a son, and although his serum creatinine was 1, when we did the isotope-renogram, we found that one kidney had only 35 ml per minute, and the other kidney had only 40 or 42 ml per minute. So I didn't want to take a kidney from that 42 ml per minute and transplant to the son, and neither the 33 ml per minute. So one has to take individual decisions regarding the donor and the age of the donor when you choose a live-related donor. In the case of a deceased donor, we have used deceased donors who are quite old, but we always do an implantation biopsy at the time of retrieval to see that it will only take about couple of hours to see that whether most of the glomeruli and the tubulointerstitium is fibrosed or not. If it is fibrosed, then it is better not to use that donor at all as a deceased donor. Thank you.
Thank you, Georgie. I think this is one question asked to Keyur. Does it take many years for getting a good live donor kidney? I don't know what context has been asked. Keyur, the question is to you. Does it take many years to get a live donor kidney?
I think no, not at all. Not at all. If you're talking about a live donor transplant, all it takes, say, about 10 to 15 days. All we need to make sure is the donor is healthy by doing the primary tests and the secondary tests that I described. In fact, the legal file might, if you have a efficient transplant coordinator team and a legal team, your legal file gets ready within the next 3-4 days. So in a week's time or max 8 days time, both your medical file and the legal file is ready. That is put up to the authorization committee of the hospital. Authorization committee of the hospital usually they meet at least twice in a month. So then your file is put up to the committee. Once the file is put up to the committee, you are interviewed as the donor, as the recipient, and the entire family is interviewed. In fact, now an important component of the legal file that is put up is an individual interview of the nephrologist with the donor and the recipient as well, where the nephrologist is filmed asking questions and directing the donor and the recipient. Now, once the authorization committee of the hospital is convinced that this is a good transplant, the donor is willingly donating it to the recipient, everything seems to be legal, the sanction is given. So within 10 or maximum 15 days, the transplant can be done.
Thank you, Keyur. I think we'll go into the last question before I hand over to Umesh. This is actually Sunil who's been asking whether you are asking Sunil about the role of the family physicians and the Indian Medical Association, how they can help us in either spreading the awareness of cadaver donation or the misconceptions of kidney transplant, because basically the patients go to them, the family physicians and our IMA colleagues. So what is your advice and what would you request them to do in this regard? Sunil, please.
Thank you, Sundar. I think, if for all the practitioners out there who are listening to this, great webinar, I would say follow the ABCDE of organ donation, especially the cadaver donation. A is help us create awareness. B is understand what brain death is. Very important. Remember that in brain death, more than 8 lives can be saved by donating all the solid organs, and more than 50 lives can be enhanced by doing tissue donation. So do understand what is brain death and what is organ donation in brain death. C is do some charche. If you want to be a donor yourself, do mention it to your family. Do a charcha in your family, because it's a very difficult conversation to have. So do some charcha. D is for donor card. Understand what is donor card. Today we have an opportunity of donation, not only using this kind of a donor card. You can also do it on a driving license. I don't know if you can see my driving license, like Sundar can. So understand the concept of donor card. It is just an expression of interest. Don't confuse it like, if you have a donor card, the chances of donation is going to be 100%. It's not going to happen. You have to speak to next of kin. And E is end. In your end is your beginning. Death is another beginning. Like, Rabindranath Tagore said, once your life, is gone, he says that, the chance of, death is, he says in his own words, death is not extinguishing the light, but putting out a lamp because the dawn has come. And that dawn is dawn of organ donation. So remember that you have an opportunity to continue to live after even death. So practice that. So if you practice this ABCDE of organ donation, we could have many more donations, many more lives can be saved in our country, because there's a huge demand for organs. We'll never be able to bridge the gap, but with some efforts, at least we'll be able to save many lives. That's what I would say to all of general practitioners out there.
Thank you, Sunil.
I think Sunil, this is actually World Kidney Day we're going to celebrate. And one of the messages is kidney health for all. And whatever we do, whichever country, dialysis and transplant is not going to help everybody. I think we have to, this is not the right time, but I'm sure we had a lot of sessions on preventive kidney disease, controlling blood pressure, diabetes, lifestyle modification, diet, stopping smoking. All these are also very important. As the Sanskrit quotation goes, swasthasya swastha rakshanam, keep the well healthy. That is what is the motto, and that is my message. I think apart from doing dialysis transplant, we as nephrologists, our IMA colleagues should look at prevention and also educating the people on talking on lifestyle disease. I finally end my moderation here and hand over to Umesh to conclude the session, please. Umesh,
thank you. Friends, you must have realized every year, more than 1.5 lakhs patients develop kidney failure, and they need renal replacement therapy to survive. We do about 10 to 15,000 transplants a year. You can understand 90% of patients have no recourse but death. That's the reality, and that's where our role comes in. We need help from all of you in this endeavor. There are so many myths. You as a family physician can give right information to the patients and relatives. Sometimes your one sentence, "I don't know about brain death," means a loss of disease organ donation. One disease donor can give life to a patient for a heart transplant, second person a liver transplant, 2 patients kidney transplant, 1 more intestine, 1 more lungs, 1 more pancreas, skin, so many things. Do we understand that sometimes not taking interest in giving inappropriate advice, so many patients lose their chance of living second life? I think the message, if we take from here, brain death is death. Do not take your organs to heaven after death. God knows they are required here. And probably we are the people who are supposed to help in achieving this goal. Not to say that transplant means 100% success. Not to say that after transplant there are no problems. Not to say that that is the final answer. Yes, it is a complicated matter. It is expensive. There are a lot of medical legal issues involved. But let us take care of all these issues and move forward. I am sure so many patients will get benefited. And when we see these patients someday meeting us and saying, that when you did a transplant 10 years ago, the satisfaction that we get is unexplainable. So friends, I take this opportunity to specially thanks Dr. Umesh Khanna, who had actually planned this program, but due to personal reasons, he could not attend this seminar. And thank you, Sundar, for taking over at the last minute. I also must thank Dr. Garima Agarwal and the audiovisual team and IMA leadership to give us this opportunity. And I'm very happy to say that, of course, we had an excellent faculty. I think they are who's who of transplant in this country, and that's why you got the best answers in this discussion, which made our life very easy. And I'm very happy to say I had a word with Dr. Jayesh Lele, the General Secretary, and he told me that IM is already doing a lot for organ donation, and he has agreed that whatever is required in this field, IMA will stand by and help in promoting organ donation and spreading awareness. We have with us Dr. Garima Agarwal from IMA, who has also done excellent job in organizing this meeting, coordinating with everybody. Can we have some message from Dr. Garima Agarwal? Once again, thank you very much for giving us this opportunity to conduct this seminar on kidney transplantation. Thank you very much.
Thank you so much, sir. Thank you, Dr. Dave, Dr. Bhargav, Dr. Sunil Shroff. Hi, sir. How are you? Dr. Jody Abraham, Dr. Anand Kumar, Dr. Umesh Ojha, Dr. Shankaran, Dr. Sandeep Guleria. Thank you so much, sir. We would like to, appreciate that for the past 2 hours, the audience here has not even gone out 1 second. And we have around about 2,500 people who are glued online. So that speaks volumes about the panelists which we had. Thank you so much, sir. Thank you. And I would like to invite, I think Dr. Jayesh Lele is there with us online, and request Dr. Vinay Agarwal to come on dais, please, sir. Dr. Lele, sir, it's up to you now. Over to you.
Yeah, thank you, Kshitij. Let me thank Dr. Umesh and the entire panel for this organ donation, because organ donation is a very important, very key factor in the IMS work with the patients. And I feel that every, sorry, 1 second, it is on the... Yeah, sorry, I can join now. Thank you, Kshitij, Doctor. Thank you, Vinay sir. Thank you, Dr. Garima. And I'm very happy that this concluding session of very important organ donation we have taken, and all the leading faculties in the organ donation, they are talking here. Last 2 days has been absolutely mesmerizing for the program. We have been working hard, Dr. Garima and Dr. Kshitij, and under the guidance of Dr. Ketan Desai sir and Dr. Vinay Agrawal. We were there yesterday for the inauguration, but today I had to come to the Ranchi. But I had made it a point that once I land Ranchi, I will immediately start the online. And thank you, Umesh, for making a statement on my behalf that organ donation will be definitely taken care of. I feel every registered medical practitioner should spend at least 2 minutes of every patient in future, whether it's basically why wait till end stage disease? Why wait? The motivation should start right from the day one, because as a family physician, consulting physician, and various places, we see the patient from day one. And here I feel the relatives are also equally important. The moment we start talking to the relatives, their mindset is changed. And I'm sure day by day, the organ donations will improve. Lot of things, many places we visit, they have been working very hard. The various donor cards are there, various donor forms are there. We will work hard in Bombay. Umesh, if you recollect, Umesh Khanna was there in my own branch, introduced this card, and which is taken further. So in every year, we at least publish that form and a card 2 times, and we have given it. So I think we should take up this job at the national level, and I'm sure all over my 1700 branches and more than 4 lakh doctors will take this cause for future. Thank you very much for giving me the opportunity. Over to you, Kshitij. Please go ahead. Thank you.
I won't do justice if I do not give the last word to the man responsible for this conference, the idea and the encouragement. Vinay sir.
Thank you, Kshitij. And my regards to our National President, Dr. Sajanand Prasad Singh and Dr. Lele, our Secretary General. There cannot be a better way to observe World Kidney Day. When we were planning to, that how can we do it, and I and Dr. Umesh Khanna, whom we gave the responsibility to being the chairperson of this event, were discussing what will be the attendance, what will be the type of crowd, what will be the delegates, and what should be the theme, and what the messages should be given in that form. And I think there has never been such a comprehensive conference on a international topic to observe nothing else than World Kidney Day. My all thanks goes to Dr. Umesh Khanna. Unfortunately, because of a family bereavement, he could not be personally present in these 2 days, but the entire sessions, he has been one who has been concerned, he has been one who has been looking, who has been guiding the entire team. My thanks goes to our young ebullient, to IMA activist, Dr. Kshitij Bali and Dr. Garima Agarwal, who have just as a team done a wonderful job. And the entire team, it will be difficult for me to name them, whether it is Dr. Mayuri, whether it is Dr. Sanjeev Nair, whether it is Akash, whether it is Manisha Dasi, and whether this is Lavi, and many. I'm sorry if I have not been able to name them, but as a team, I have been a part of those video conferencing and the entire working of the entire this thing, and you all have done a wonderful job. It is possible, it can be done, and that is the message you have given. And the entire content of this conference was not to address one group of doctors. It was to pass a message to family physicians, secondary care specialists, and even the super specialists, that what are kidney diseases, how to deal with them, what are the complacency, what are the complications involved in the entire kidney transplant and other things. We can never have a better panel and a better coordination by a person than Dr. Umesh Ojha. I'm really thankful to Dr. Shankaran Sundar, Dr. Sandeep Guleria, dear friend of mine, Dr. Sunil Shroff, Dr. Rajiv Sood, Dr. Anant Kumar, Dr. Georgie Abraham, Dr. Kayur Dave, Dr. Vinant Bhargav, and many other of our faculty members on these 2 days have given their best to not the 175 delegates sitting physically in this hall, but all those 2,300 persons, delegates who have been online, watching you consistently from the beginning to the end. Not only this, there have been our Facebook Live, where almost 1,500 persons joined us. On Twitter, 1,400 persons were there. And on YouTube, so far, about 900 persons have gone on the YouTube to see that. And I'm really thankful to every one of you. And all of you, I'm sure this organizing team has come up to your expectations. Once again, my thanks to the entire organizing team to this job. And I can assure you, we as a headquarter team will keep on taking topics of national interest, and we'll be sending messages accordingly. And also, I want to convey on behalf of our national president that organ donation and body donation will be of one of the targets, one of the momentum which we'll be taking this year. Simultaneously, also, we will take that preventive health checkups to identify kidney diseases as early as possible. So these are the two messages which our president and secretary are passing through our 1,700 branches, to our 450,000 members, so that this year we can justify and can actively work for kidney health for all. Thank you very much. Thanks a lot. Thank you.
I would like to thank everybody in the audience, and the lunch is ready so we can enjoy our lunch. Thank you so much for coming here. Would like to thank 2,300 people who listened to us very patiently online. Thank you so much.